Patients.
bile leaks, perforations, all these things. So and sometimes it can prolong the hospital stay, add to multiple interventions, maybe IR or surgery, whatever. So it's very difficult, but we usually tell a rough kind of things is certain percentage of population can have this. So be prepared that there can be a chance like 2 or 3% or 5% that you may end up in something else rather than the expected course. So at that time, and it's definitely difficult in private and corporate setup to convince them to the added costs eventually. So it's a tough task, definitely. At some point of time, we have to underplay. We have to convince the the management to reduce the costs and all. So definitely it's challenging. We really still face that whenever there is a complication.
Yeah, I think one other thing which is important for us as trainers and the teachers of the endoscopic procedure is never ever leave the youngsters unattended. So the complications will occur if the youngster is trying to fiddle around the papilla, trying to go across the obstructed passage in an attempt to bypass that passage. That is where the problem occurs. So Ankit, you are in a private sector, is getting trained. The number of the complications can certainly be mitigated. It is only unattended procedures which get complicated.
So I'll tell you my own experience. So yes, we do stand with all the mentors do stand with the trainees. So I was trained with Dr. Dheer and Dr. Maidev at BIDS after completing my gastroenterology. So during ERCP, Dr. Dheer would let me go step by step. He would, if I've done cannulation, I do have to ask him, can I go ahead with the sphincterotomy? And he'll be there standing behind me and saying, okay, go ahead with the sphincterotomy. And he'll be watching me do the sphincterotomy. Second step, can I do with the balloon sphincteroplasty? Again, he'll be watching how I'm doing it. And then, so mentorship is necessary. You need to stand behind your trainees, give support to your trainees, tell them what they're doing right, tell them what they're doing wrong, point it out at the right time, correct it, so that you avoid untoward incidents during.
So you cannot leave them unattended.
Yes.
That is very important.
Yes.
Saurabh, again, you have moved from from US to a private sector now. One of the important issues is the patient has a complication. Patient wants to know, if you try to explain him in detail, all complication which can ensue as a part of your therapeutic intervention, he like to know what happens if the bleeding occurs. Suppose there is a perforation, what next? How much will what will be the total entailment of the expenses? So how do you respond to them?
Yeah, no, thank you.
Any private sector in India, if you enter ICU, it is not less than 1 lakh rupees, at least in North India, per day. So what do you tell them?
Yeah, I think it's one of the most challenging things we do as physicians, and as interventional endoscopists. I think that remains one of the challenges you always encounter. And I think we are not in an insurance system mostly. So a lot of patients are cash paying, as you correctly pointed out. So in the West, didn't matter in terms of the cost. Here it does, and every penny they have to spend, they will question. So at least at our center, when the unforeseen things happening, we do have a foundation support, and I request the foundation to take care of their expenses, because the reality and the fact in India is that people are not going to be willing to pay for an extended stay for complication oftentimes. So we have to resort to foundation support for patients. That's one. The second thing I've learned over the last 3 years is I was very blunt, and I think I was very open about the complication risks in general. In the West, you just talk about everything. But then I realized that people in India are overall on an anxiety scale much higher when it comes to healthcare. So I think the more reassurance you provide, the better they feel. So I think the tact of handling Indian patients I have learned is very different. That you have to tell them it may happen,
you have quickly learned the tricks of the trade of working in India. Good to know.
You have to tell them it may happen, but you have to make them believe that you have the ability and the ability to handle it, and everything will be fine. They all want to hear everything will be okay.
So अच्छे दिन आ गए हैं. That is what you believe. Good. Deepak, you think you are at equally the same level of pressure as people in the private sector, or you think because they are not paying, you can be more liberal in terms of explanation?
sir. I think it's not the same thing. In government sector also, the patients are the same. So you have the same pressures when do complications happen. Yeah, definitely we have a slightly easier way to handle that. The financial implications are not much high, but as a physicians, when complications happen, you have the same pressure and same kind of way of handling the complications, dealing with the patients. And apart from that, in India, what happens that along with if the complication will happen, there will be 10 more relatives who will come to talk to you, what is happening. And one by one, you have to explain to everyone. It's not in private sector. I think it's everybody is facing the same thing. That somebody will come, then they will find somebody else who is known to you. They will talk to you. So pressure remains the same.
Okay. And yes, I agree. But I think the additional cost of the expense is another big burden, which is always, hanging, like having a, swinging sword around your neck if you are not able to handle that. That is the reason I wanted to know from the people who are in private sector. Now, coming to Dr. Sundaram again, what do you think can be done? Is it a time now? Dr. Sood is also here, who has been the founder member of therapeutic procedures in India. He was the pioneer of endoscopic procedures who started the first workshop. So I think we should address to him also. Has the time come when you have dedicated people at his level who are just assigned the job of training youngsters rather than trying to mix up your practice of IBS, IBD, NASH, and everything you're doing, and suddenly you're seeing somebody doing in US? People at his stage who are so well accomplished, should they be assigned the job of just training people in therapeutic procedures?
Yeah, so like already mentioned, mentorship is very, very critical.
But there is none at the moment. Everybody is doing everybody. At one time, you are seeing an IBS patient, you're looking at NFLD, you're looking at tuberculosis-induced drug-induced hepatitis. Suddenly, you see somebody having bleeding. So I think people at his level, or maybe people at the level of Pankaj Desai and others, should they not? They are so well accomplished. They have learned over a period of time of more than 4 decades of competence. I think we owe it to our youngsters for excellent training, and our people don't need to go abroad.
Yeah, so yes, of course, focus from both the mentor and the mentee is very, very critical if you want to become an expert. But I guess like you said before, not everyone is trying to become an expert. So everyone is trying to learn a skill so that they are able to sustain their practice. But then again, like you suggested, yeah, maybe we do need experts training, people to become an expert. So yeah, very much, I guess
Dr.
Sood can
yeah,
take a
yeah.
call on that.
Can I talk? Yeah.
Yeah.
It's like building a pyramid. Every gastroenterologist would like to be trained in at least level 1, 2, 3 endoscopies. It's not that they are without any complications, but the complications are normally not so severe and can be easily managed. I think it is important that we train to that level, whether it is a person treating IBS or the functional disorder or reflux. They will have to do an endoscopy or colonoscopy routine. Advanced therapeutic procedures, aptitude of the person first, and the willingness to go through the drill is important. So the program has to built in like hurdle race. You cannot make it very smooth so that everybody just walks in and tries to have a people go at it. It has to be according to the aptitude, and this is up to the mentee up to the mentor to identify that skill in a person. You remember we used to have lots of people coming from US who wanted to be trained in ERCP, and many times we used to tell them that sorry, you cannot. So that is up to you to tell them that your skill level is up to this, and you can be trained up to this. Your complication rate will otherwise go up. So I think that specialized endoscopic procedures, which are quite clearly classified, need to be trained to limited people.
Yeah, Nikhil, you will agree with that Dr. Sood thinks not all. How do you assess the aptitude? See, given the choice, everybody would learn to be master. Everybody would learn like to be Surya Kumar Yadav or Virat Kohli, but you can only test and try and see what happens.
So one is, of course, the inclination shown by the trainee towards the pancreatobiliary endoscopy, because I don't see US as a separate field. I want to consider it to be part of your combination of US and ERCP training. So if the mentor feels that the guy has the finesse, the spatial organization, the hand skills and the stability in ERCP, then of course he should be supposed to learn EUS. And the kind of volume he is working in, what is his private practice setup? It's a private individual practice or a group practice or academic center. So based on that, it is a mutual discussion between the mentor and the mentee, and then has to take forward. I just wanted to speak on the adverse events and the complications corporates. So from my point of view, we work in a corporate hospital in Kolkata, and we have to give options to the patient. If we are offering any therapeutic interventional US procedure, what are the alternatives and what is the comparative cost analysis and if things goes wrong. So we have to be open, and you may lose some patients for that, but then long term it pays. So give alternatives to what you are doing.
A final question to Zubin before we summarize. Zubin, up to what extent do you go and explain in details? Because patients will counter question. If bleeding up occurs, then what will be the expense? If pancreatitis occurs, how long will you have to stay? There are no answers. So what do you tell them? What will be the impact of the bleeding or pancreatitis? How long do you stay in ICU?
Sir, I usually what I do is I tell them the values that I have for my patients, like my level of post ERCP pancreatitis, all the departments level, original data. I don't go on to depths to tell them that what expenses they will end up paying, because that is unknown territory. Because once somebody lands up, we don't know how much they're going to expend. So it's a value depending on our own experience at our center, what is our complication rate, and that's primarily what I explain, not more than that.
Thank you. We'll try to sum up what we have discussed since morning. I think after the advent of EUS way back in 1989, and with subsequent interventions pioneered by Professor Bin Moeller and others in terms of therapeutic intervention, there is a rapid increase in the number of the people who need to be doing good advanced therapeutic EUS. But surprisingly and unfortunately, we have practically no center in India who is imparting good quality training. So I'll address this question to big wigs like Dr. Sood, Pankaj, and Mohan, that we have good quality of centers. We have excellent endosonographers who are at par with anybody in the world, but unfortunately there is no training for our own people. Outside we are treated as foreigners. If inside also we treated as foreigners, where do we go? I think it is high time that we end up having structured training program with the help of anybody and everybody who is doing this procedure. And I am thankful to all my panelists who have risen and have learned all the trials, and you have gone through all trials and tribulation before becoming successful in that art. Thank you so much, Rajesh and Manoj, for giving me this opportunity.
I would like to thank the experts and moderators for the views shared by them. It is mind-boggling in the initial few years to see the vast amount of learning that is still there, and impressive discussions like these help provide a clear understanding as to how and when to proceed in this course. Moving forward to phase 6 of the conference, that is endo-oncology, it will comprise of short discussion sessions, with each session having 12 minutes of talk by the speaker and 3 minutes of discussion with the audience. There will be please follow the timeline strictly. There will be a bell at 11 minutes of the talk and final bell at the 12 minutes of the talk. For the first 2 sessions, I would like to invite as chairpersons, Dr. Sridhar Sundaram, Dr. Nitin Bair, Dr. Rajiv Grover, Dr. Rinkesh Bansal, Dr. Sahej Rathi, and Dr. Rajneesh Monga.
We start with the session on intraductal biliary RFA, for which I want to invite Dr. Randir Sood, Chairman at Medanta.
Thank you, Rinkesh. First of all, I would like to all those who are doing intraductal RFA, intrabiliary RFA, to raise their hand so that I know how many people are actually doing it. And then I know that how much will you actually understand. So there are only 3 or 4 people in the audience who are actually doing this procedure. And it's not surprising because this is a specific procedure which involves a specialized equipment. And also this requires still the evidence to come up for its utility. Now, just touching on the principles, because I realize that many of you are not doing it. So touching on the technical points, this is basically taking a catheter, which is specially designed inside the bile duct, positioning it precisely over the intraductal tumor or malignant stricture, and heating it, and it gets heated because there is alternating current which flows through the tissue, which generates resistance and increases the temperature. The ideal temperature is between 60 and 100 degrees to cause coagulative necrosis, and this hyperthermic injury is coaxial. So there is a core of tissue which undergoes this damage. This happens because of irreversible damage to the mitochondria, cytosolic enzymes, and histones between 60 to 100 degrees. Central zone of necrosis is surrounded by a peripheral zone, which is about 1 to 2 millimeter of thermal distress. Now, this zone, some of this tissue will undergo necrosis, some of this tissue will regenerate. And the most important thing is that not only there is a physical damage, the damaged products like heat shock proteins, the fragments of RNA and DNA, they are liberated into the systemic circulation and the interstitium, which act as the systemic antigens, and they are supposed to create initiate systemic immunity against the tumor, which may be an important component of how this modality works. There are basically 2 types of catheters. The conventional was the Habib catheter, which most of us have been familiar with, and the other is a newer catheter by Taibung, which is ELRA catheter. The advantage of ELRA is it's slimmer. It's 7 French. It has option of various lengths according to the tumor size, and it also has a a loop which controls the temperature of the tissue at the tissue level, so that there's no charring and over necrosis of the stricture. This is how diagrammatically you take out this catheter, which is about 8 French in size, and this has 2 stainless steel electrodes. This is a diathermic. This is a bipolar cautery. So there are 2 electrodes, 8 millimeters apart, and this covers a total area of coagulative necrosis about 24 to 25 millimeters. And you position it under fluoroscopy over a guide wire like any other stent. But you have these radiopaque markers which tell you where the position is, and you have to have the position of the stricture very clearly demarcated before you use this. You have 2 settings. This Habib is compatible with the RB generators via 200 and above, and you have 2 settings which are important. One is the power in wattage, and the other is the duration. Power is 7 to, you fix up between 7 to 10 according to the thickness of the tumor. Now, the tumor characteristics like how fibrotic it is and how bulky it is will determine how much power you want to give. And duration is normally 60 to 120 minutes, but normally most of the times it's 90 seconds. And when you do that, you see that there is a thermal injury to the core tissue, and that if you give it 60 seconds to cool off, then remove the catheter, because there's evidence that if you remove it when it's hot, there could be peeling of this and more incidence of bleeding. Subsequent to that, you place stents. This is an example of a hilar cholangiocarcinoma where both the sides have been RFA'd and subsequently self-expanding stents were placed. Now, the first question is, does endoluminal RFA work? That there is evidence that it does work. You can see that there is physical evidence that this is the stricture before RFA and this is the stricture after RFA. There's a significant increase in diameter. because of circumferential thermal necrosis. But the problem is that you can't leave them without stenting. Why? Because if you leave them in 4 weeks, these will become strictured again, not by malignancy, but possibly by fibrosis. So you have to stent them, and you choose then to stent them with plastic, uncovered or covered metal stents. I'll tell you why there's a difference. And the goal of RFA, why we do it, is to increase the stent patency, because stenting is a must, and possibly increase in survival. So let's look at what is the efficacy of ERFA in increasing stent patency. Now, the studies in red are the randomized controlled trials, and the studies in black are the retrospective analysis. So you can see, you must understand that what is the evidence of stent patency. If you put in a plastic stent, exchange it after 3 months, you don't know whether this prolongs the stent patency, because the mechanism of stent blockage is not in tumor ingrowth. It is basically the biofilm formation and blockage of the stent. Similarly, the blockage of the fully covered metal stent is due to formation of sludge, the migration and all, not due to tumor ingrowth. So the only stent where the tumor ingrowth matters is the uncovered metal stent. So if you look at it, you find that only one study in the plastic stent, one study which was, which had all the types of stents, plastic, uncovered, covered, showed benefit. But one study of plastic stent, which was randomized controlled, showed benefit. The other did not show benefit. And on the other hand, when you see all the 3 studies in uncovered self-expanding metal stents showed no benefit of prolongation of stent patency by endoluminal RFA. Does it increase survival? Why do we think that it should increase? By tumor debulking, I told you, improving stent patency if it does, so that you have less complications, and systemic immune response. There are 7 studies till date, 3 randomized controlled trials and 4 prospective studies. 5 show that it does increase the survival, 2 show that it does not. But the problem is that you are treating heterogeneous group of tumors. You are treating cholangiocarcinoma, you are treating pancreatic carcinoma, you are treating malignant metastatic disease, you are treating hepatocellular carcinoma. So it cannot be, it cannot be applied to all the tumors. And there's only one meta-analysis, available till date of 505 patients of comprising of all the heterogeneous tumors, which did show some benefit of survival and better stent patency by using endoluminal RFA. Again, I told you that the problems in interpreting this data. But let's look at specific tumors now. The 2 randomized controlled trials on extrahepatic cholangiocarcinoma are there, and there's definite survival benefit with endoluminal RFA. This one study is by Yang et al. Now listen to this very carefully. Yang et al. Did ERFA versus no RFA before placing plastic stents. They put in plastic stents, and there was significant increase in survival. But what did they do? They exchanged electively the plastic stents every 3 months and did RFA whenever intraductal ultrasound showed the thickness of the stricture more than 6 millimeters. So it was a repetitive RFA, if applied, did benefit these patients. So it was not that first go, you do RFA, you put in a plastic stent and then just change it. You have to do it according to the, tailor-make it according to the tumor width. But and the Gauss, randomized controlled trial, again, they did RFA at the first time, put in a plastic stent, then at the first exchange, they did RFA again. So minimum 2 RFA sessions. Yang, this is what I have already told. So in extrahepatic cholangiocarcinoma, at least 2 RFA sessions are necessary for any survival benefit. So let's look at CA pancreas. There's no randomized controlled trial assessing the outcomes in CA pancreas. There are 2 retrospective studies in CA pancreas, but they do show some survival benefit. And you can see the figures that this was Kailis study showed 226 versus 123, and Reem Shirai's study showed significant. But this was comparison against SEER data group, where they retrospectively they saw the survival in the previous patients who were not given ERFA, but there was definite evidence of survival benefit in cancer of pancreas. So ERFA with stenting in malignant bile duct obstruction due to CA pancreas results in survival benefit. So these 2 evidences we have got. Now, survival benefit of endoluminal RFA with chemotherapy in extrahepatic cholangiocarcinoma, because you are not only going to do ERFA and put them on stents, you are also going to do a adjunctive chemotherapy. So what is the evidence that it doesn't add to benefit? And in fact, this study by Mariah, there was retrospective study. They studied from in Bonn. They took about 40 patients who were given endoluminal RFA and subjected to standard chemotherapy gemcitabine regimen, and the other were only stented and given chemotherapy. And the overall survival, the progression-free survival, was definitely better in patients who were given endoluminal RFA. Benefit was more evident in locally advanced tumors, not in systemically advanced tumors. And hematological toxicity was same in both groups because that was dependent on the chemotherapy, but there was higher incidence of cholangitis where ERFA was done, which did delay chemotherapy in some patients, but overall outcome was still in favor of ERFA. So a combination of endoluminal RFA with standard chemotherapy in extrahepatic cholangiocarcinoma is well tolerated and improves overall and progression-free survivals. Now comes the the heartbreaker. This is the study published a couple of months back. This was a very nicely designed randomized control trial, and again from Germany. This was purely uncovered metal stents. But they were patients of cholangiocarcinoma and pancreatic carcinoma both. There were 44 patients in SEMS only, and 44 patients in ERFA, and 42 in ERFA plus SEMS, and 44 in SEMS only. And they did the standard of care, and you can see there was at 3 months and 6 months, there was no difference in overall patency rates, in mortality rates. So according to this randomized control trial, there was neither benefit in stent patency, nor there was any benefit of survival by the endoluminal RFA. So then the other question comes, the endoluminal RFA and occluded stents. I'll finish in 2 minutes. So this is, there's one study of 25 patients where uncovered metal stents were RFA'd, and only 56% patients could achieve more than 80% luminal restoration. And the other study of 7 cases with ELRA catheter, only 26% of the patients could actually achieve luminal patency. So it's not a very good modality for clearing occluded metal stents. Adverse events, there are 5 series comparing adverse events of ERFA and stenting alone. They showed similar incidence because this was predominantly related to the ERCP and stenting. But cholecystitis incidence is much higher in patients who undergo endoluminal RFA because of injury to the cystic duct. But there have been rare incidences of serious adverse events like fatal bleed, liver infarction, and hepatic encephalopathy and biliary perforation. There are some technical glitches because a coaxial catheter, which is only 8 French or 7 French, may not oppose the tumor very well. And a tumor is not supposed to be smooth. This will have bumps, and you may end up debulking the portion which is coming in contact and leave the tumor which is not in contact. To circumvent this, there is a new catheter which is being designed by Inouye et al., which is a balloon with which is about 22 millimeter in length and has strips of diathermic bipolar diathermic strips, which can this balloon can be inflated to 3 millimeters, 3.5 millimeters, and can come in contact with even tighter strictures, and where it is not opposing the linear catheter. And the more important thing is that the depth of injury is more predictable with this as compared to the routine catheters. To summarize, endoluminal RFA is increasingly applied to malignant biliary obstruction prior to stenting. It acts by local debulking of tumor and stimulating systemic immunity. There is evidence of survival benefit in extrahepatic cholangiocarcinoma, CA pancreas, and particularly patients of extrahepatic cholangiocarcinoma on chemotherapy. And there is only conflicting evidence of increase in its ability to increase stent patency. Utility in clearing SEMS occluded is limited. mostly a safe procedure with rare serious adverse events, and we still have to see how the new balloon catheter behaves. And in the end, I would like to invite you to the Endoscopy Premier League. We are hosting, Medanta is hosting from 30th September to 2nd October. So, this is an action you can't miss. So I invite you all. Thank you.
Thank you, sir, for I think shortage of time. Maybe we'll not take questions right now. I think the questions can be asked directly to you.
Sure.
Gives me pleasure to introduce the next speaker. I guess Professor Ken Binmoller could not make it yesterday, but today he'll be discussing hot tips for hot lamps. Professor Binmoller doesn't need an introduction to a crowd of pancreatic biliary endoscopists. He is an expert in EOS, and I think he'll be discussing the lamps that he developed.
Thank you so much. It's really a pleasure to join you today. My humble apologies for the disruption I've caused. I wish I could have been with you yesterday, but I look forward to spending today with you and interacting with all of you in the audience. It is said that there's a silver lining in everything that happens in life, or at least I always try to find or look for the silver lining. And one of the silver linings of some of the disruption that occurred is that Rajesh and I have bonded and become very close friends. And I want to thank him personally for accommodating me with some of the challenges I faced with my travel to this meeting today. But I'm really happy to be here. So let's wait to see if my slides are up. And I just might make a comment then as we're waiting for my slides. I want to congratulate the organizers. Meetings like this really allow us to fulfill our calling as doctors. So of course we think of doctors as caregivers, but actually the origin of the word doctor is doctore from the Greek, and it means teacher. So we are also teachers. As much as we are there for our patients, we are there for our colleagues, and especially our young colleagues. So we are fulfilling that mission with courses like this. And so this is really a great privilege to be able to teach in meetings like this. And while we get these slides set up, I might also mention just a few words about the topic of my talk, which is on hot lambs. I'm going to specifically address hot axios. I'm not familiar with the other lambs that are emerging. I'm sure we're going to see many, many versions of lambs in the future. But I'd like to just share with you a little bit of history and the origin of what has become part of our colloquial vocabulary, right? Hot axios, hot lambs. But where does that term hot come from? And at least for me, it derives from the time when we could not get the FDA to approve the electrocautery enhanced version that we had created. And therefore, we were limited to using the cold axios. So that did not have electrocautery built into it. So later, we did get the FDA clearance, and we could then evolve to the hot lamb. So today, I'd like to share with you some hot tips on hot lambs. The emphasis is on that term enhanced. So what enhanced means is we are using micro wires that run radially on both sides of this nose cone bougie tip, and these micro wires converge at the tip itself. These micro wires comprise only 3% of the surface area, and that is what allows us to achieve a maximal cutting effect while minimizing the coagulation effect. So we want to minimize the collateral thermal damage that we get when we use diathermy. And this took a long time to develop. And I worked a very long time with the engineers to find a modality that would allow us to have more of the cutting effect like a scalpel. Also importantly, the platform is endoscopist controlled, which of course we endosonographers are used to when we perform FNA. It is a one hand platform, a one device platform, and one puncture platform. It's not necessarily one step. There are several steps during the procedure, but we called it within our company, Exlumina, we called it the Obi-Wan. Well, those of us that are Star Wars fans, the Obi-Wan with emphasis on one hand, one device, one puncture. So the development of this handle was because it required great focus and ingenuity, because there's no room for error when you're placing a 10mm saddle across two walls. And in hindsight, I'm actually quite pleased that the original 3D printed mold, which you see here, this is over 10 years ago, really hasn't changed. And so it has passed the test of time. And even after Boston Scientific acquired Exlumina, it still looks the same, only the logo has changed at the bottom. So let's deconstruct that Axios handle, because I think it's very important for the audience to understand how this was constructed. And even though you have the steps that you're taught, I think you need to understand what's inside. So we have these two hubs, the black and the gray. That black advances and retracts the sheath. I put that in quotes because technically that's not really what happens. It's able to advance the sheath only because there's a coupling with the gray hub. So as long as the gray hub here and the black hub are coupled, then the sheath can be advanced as one unit. But the black is actually advancing an inner catheter. As long as it's joined coupled with the outer sheath, it moves as one. The gray then deploys the flanges. We have two locks for the respective black hub and gray hubs, and there's an added yellow safety pin. We added that later because it's so critical that the gray hub is locked. If it's not locked, you cannot advance the sheath as one unit. And then you're all familiar with the forceps, which are actually printed on the handle itself. So if you're ever flustered, you can look at those 4 steps. I won't go into the steps right now. I think you're familiar with it. But what is key is that you pay attention to the locks. And using those locks conscientiously is key to safe deployment. So basically, you're alternating lock and unlock the entire time. So if you have something locked, you must have the other unlocked and vice versa. So the gray lock keeps the sheath and the inner catheter coupled, as I mentioned, and it allows the black hub to advance the sheath into the target as one unit. It also allows the black hub to be retracted to deploy the distal, to snug up the distal flange to the wall. So you're using that distal flange like a retractor and you're pulling it up against the wall. The black lock is what prevents movement of the inner catheter during flange deployment. There is a 2-stage release of the distal and proximal flange independent of one another. Now, this is the very critical part because there is no room for error. So we built in these safety measures, safety features to ensure that these steps are done completely independent of one another. Stage 1 is to release the distal flange in your target, gallbladder, for example. And so here you see that we've retracted the gray hub, and that has deployed the distal flange in the target. And here up here, you can see the distal flange deployed. Now we built in an auto lock, so you don't even have to think about locking this because it's so critical that we now immediately lock the gray hub. And there's an audible click that tells you that gray hub is now locked. And then we can move to stage 2, which is to release the proximal flange in the bowel. So here you see the entire axios deployed. And the proximal flange has been deployed by pulling that gray hub fully back. But what's important is not to forget that step 2. That's step 3 between step 2 and step 4. That is to retract the black hub to snug up. And here you can see the number 3. Now, often we don't have to conscientiously pay too much attention if you have a smaller space, a tighter space, let's say 3 to 4 centimeters, because the distal flange usually automatically snugs up. But it is very critical that you snug up, pull back the distal flange if you're in a more capacious space. If you ever get lost, look for the black band marker. So we created this so that you can always identify the distal tip of the sheath. That's what you always need to know. Where is the distal tip of the sheath? And you can identify that endoscopically, you can identify that with ultrasound, and you can identify that on fluoroscopy. We're really integrating all of the 3 imaging modalities that makes our work as endosonographers and ERCPists so exciting. So here you see the black marker. That means the tip of the sheath is here, and now we need to deploy the proximal flange. Or you can see the black marker here, and also this radio opaque marker here on fluoroscopy. So look for the black mark. Now I'm going to share some hot tips and we'll start with number 1. You need to know your target. And that really starts with reviewing the imaging studies before you do the procedure. So you should be reviewing the CT scan, if there's an MRI done, looking for the amount of necroses, for example, in walled-off necroses. And you need to know the lumen dimensions and their contents. You need to interrogate for the interposed tissue, the distance and the vessels, and you need to have some appreciation of adherence. So the lumen dimensions, and I say dimensions, not just size, because you need to look at the cross diameter, and you want that minimum cross diameter to be greater than the flange diameter. And the minimum longitudinal diameter, which should always be measured in the trajectory of your puncture path. I call that the runway. I'm going to show you what I mean by runway. That longitudinal diameter here needs to be longer than the projected runway. So here, you're familiar with this, the saddle length. It comes in 2 and 50 millimeters, shown here. The lumen diameter of the axios comes in sizes from 6 millimeters all the way to 20 millimeters. And you have the flange diameter. So you all know the lumen diameter, but you don't know the flange diameter. The flange diameter is a multiple of the lumen diameter, and it's a 1.5 to 2-fold multiple. And it's actually inversely proportionate to the lumen diameter. So if you have a 10 millimeter lambs, the flange is 21 millimeters. So it's 2 times. But if you have a 20 millimeter lambs, it's really 1.5 times. So it's not 40 millimeters, the runway that you need, it's 30 millimeters. So the runway for distal flange deployment is just something that you have to keep in the back of your mind. So here you can see we have deployed the distal flange. This is the runway. This is the extent to which that inner catheter needs to be extended from the tip of the sheath to release the distal flange. So you can see, for example, with a 10 by 10 lambs, that runway distance is 32 millimeters. So the runway, if you want to give an approximation, it's the lumen size times 2 to 3-fold. So as you're inspecting the lumen, you have to anticipate how much runway you're going to need to deploy that distal flange safely in your target. Lumen contents, you need to have a sufficient pocket of liquid for distal flange deployment. I emphasize liquid. It has to be liquid. It has to be hypo or anechoic. You should avoid thermal contact with solid shadowing content because calcium present in wand, obviously present in stones, absorbs current. You need to select a lamb size that's proportionate to the contents requiring drainage. For ward-off necroses, I always use a 20 millimeter. Now, one of the tricks that you should always use is to pre-infuse with saline if you need to increase your target size. I use a 19 gauge FNA needle that's primed with saline so you don't inject any gas into your target. So here you see the syringe attached to the FNA needle. And as soon as you're inside of your target, you switch out for your water pump, and then you infuse saline until you achieve the desired target size. So here in this contracted gallbladder, which is very frequent after patients have had a percutaneous cholecystostomy, we are distending that with infusion of saline to then place a 10 millimeter axios. Review or interrogate the interposed tissue, measure the distance, and look for vessels that are in the trajectory of your FNA path or your puncture path. And here you can see the distance exceeds 10 millimeters. So you may need to select a 15 millimeter saddle length. Target adherence. Firstly, be aware whether the patient has ascites. You may not see it when you on ultrasound, but it's always possible as soon as you're starting your puncture that ascites may come in the way. So look for an interposed ascites. Here you can see the gallbladder is literally floating in ascites. This is not a gallbladder you want to drain internally. Look for the echogenic layer, which represents fat that is between the target and the wall. That is not really adherent. It is fat tissue. And you can press on the abdomen, jiggle a little bit to see if the target moves independent of the wall. So get some appreciation of the target. Now, hot tip number 2 is know your cautery. You always use pure cutting current. Remember, we want to use this like a surgeon's scalpel. You can increase the voltage if there is difficult penetration, a lot of fibrosis, for example, or if the wall is very thick. You advance your catheter into the target slowly with steady pressure. I call this the SSS technique. Slow, steady, smooth. This is not FNA. You're not thrusting your needle in. You're very slowly advancing. I think that is the most common error that's made. We're used to doing FNA and pushing very forcefully. This needs to be slow, steady, and smooth. Stop and retract if there's any interposed gas that impairs your ultrasound view. Look for bubbles. Bubbles is the indicator that you've entered your target. That's the diathermy effect on fluid. Then immediately stop your advancement. And you should immediately disconnect your cautery cable after you enter into your target so you don't accidentally cause any injury to the opposite wall. As happened to me in this example, I drained the gallbladder and I had perforated the opposite wall. I could see, you can see this looking through the lambs, that perforation. Fortunately, I was able to close this with just a single clip and the patient did just fine. So you need to be aware that perforation of the opposite wall can occur, but if you go inside of the target, you can usually treat that. Know when to preload with a guide wire. I don't often do this, but the beginner certainly should. It's a safety net to retain access if for any reason there's maladeployment. It will deflect your nose cone away from the opposite wall. So if you're in a more restricted space, for example, the gallbladder or the bile duct, then you may want to deflect your nose cone into the axis of your target organ, the bile duct, for example. This is where the guide wire is very helpful. It will orient the direction of the distal flange deployment. And hot tip number 4, know when to manage maladeployment. So I just want to spend a few extra moments emphasizing this. you need to already prepare before you start your procedure. Consider, what will I do if there is a maldeployment? You need to be prepared. The most common in 2/3 of cases is what's called type 1. And I differentiate a type 1A from a type 1B. Now that's my classification, but the type 1A would be where the proximal flange has not yet deployed. So it's still inside of the sheath. Here, you can actually resheath the distal flange. It's open, but you can resheath it. What's important, though, is that after you've resheathed and pulled it back into, let's say, the stomach when doing a gastroenterostomy, that you don't pull it immediately into the working channel. You need to make sure that the sheath and the nose cone are flush with each other. Otherwise, it'll get stuck in the working channel. Type 1B is where the proximal flange is already deployed. Well, then you have to remove the axios, and you can close the hole and start all over. Type 2, in 1/3 of the cases, again, I have two types, 2A and 2B. Type 2A is where you placed a guide wire. You were smart beforehand as your safety net, and you can just insert a second stent, typically a tubular stent, although you could use now a longer saddle LAMS. Type 2B, you have no guide wire, you have to remove the axios. You should definitely give your surgeon a call, because it's possible that you're going to get some leak, although usually these holes do close on their own. And finally, the type 3 is the most dreaded. This is where the proximal flange has released into the peritoneum, and you may then get drainage of contents into the peritoneum with contamination. There, you really do need to have your surgeon on board. This is just how you resheath the distal flange. It's actually very simple. We created a safety latch here so that you don't accidentally resheath when you're doing the procedure. But if you need to, you can press here on this latch. Here's the gray hub, and it will automatically lock. So you leave it locked, and then you just depress that latch on the side and advance the sheath forward. Perhaps during the live, I can show you how that's done. It's a very simple maneuver, but just remember that you need to be sure that it is fully retracted before removing it through the working channel. So here you can see that the gray hub is now below that latch. Finally, you need to be prepared to close that hole, and you need to close it robustly. My preference is to use the over-the-scope clamp. I found that this gives me the greatest reliability in terms of robust closure. Yes, you can use clips, but I really do recommend over-the-scope clamping. And you can see here, this is where a gastroenterostomy went bad. I removed the axios. I wasn't inside of the small bowel, and you can just close that hole very quickly and start all over. These patients almost never have any issues afterwards. Finally, primum non nocere. That's what our father Hippocrates taught us: first, do no harm. The high surgical risk patients, these are the patients that are sent to us. These are the patients who will benefit the most from these interventional endoscopy procedures that we perform, but they are also the patients who fare the worst if they need emergency surgery. So we must always keep in the back of the mind that we really have to have a close to 100% success record when we're doing this. Otherwise, we haven't done our patients a favor. And I leave you greetings from San Francisco. And here I am with my mentor, Albert, sitting next to me. And I look forward to sharing with you other innovative ideas during the meeting. Thank you.
It is an excellent talk from the masters, because everybody is a whole fan of hot axios. We are lucky to have you here. So one question regarding your runway. If you're planning US CDS, the one is we can put covered stent. Second way, to hot lamps, even if 8 mm, the runway should be 24 mm. But we are not lucky enough to have runway of 24 mm of CPD. So what are the tips and tricks? Because that is a chance of misfire.
Yes, yes. So
Yeah.
this is exactly the perfect example where you really should place a guide wire. So you have your guide wire preloaded. All right. So your nurse has already, your assistant has already loaded it up to the tip. You're not puncturing first and placing the guide wire. You're doing freestyle. But as soon as you're in the bile duct, you advance the wire. So the wire is going to then deflect the nose cone in the direction of the hilum. Of course, this is where you want to use fluoroscopy and confirm that your wire is going towards the hilum and not the opposite direction towards the ampulla. And you're going to need that guide wire anyway to place a plastic stent through your lambs. Everyone should be placing a plastic stent through the lambs for a colodocal duodenostomy. That should be a given now. And I think the evidence, especially after this year's DDW's presentations with multiple randomized controlled trials, that should be the standard. Always place a plastic stent through the lambs. And you have your guide wire there already in place for that.
And second is because when you put lambs in hot and warm, the problem is the bleeding from inside. When the cavity collapses, in this case, why that inner flange is not covered? Because it is very traumatic.
Yes. So I can give you share with you just a little bit of history. The original design of lambs was without that lip. We called it a lip where you see that the mesh everts outwards. That's that part that's relatively sharp. I would have preferred it to be completely flush with the flange, but we needed to integrate that lip to give it greater pull-out strength to really make migration risk as low as possible and yet still enable removability. So it's a fine line there between it's removable, but it won't migrate. All right, so yes, it's true. You do have lots of vessels because it's a pseudo wall. And in the wall, if you look with ultrasound, you actually will be quite amazed how many vessels there are, and it will give you great respect for what you're doing. So you need to place, I think, a double pigtail stent through the lambs here as well. So that's, I think, becoming also a standard. And the idea is to keep that opposite wall from abutting against the distal. The purposes are different. In the bile duct, we place the lambs to prevent the opposite wall from occluding the flange, all right, and preventing a subsyndrome. It's not to prevent bleeding, but in the walled-off necroses, we place the lambs because we know the opposite wall is full of vessels. When those vessels fall up against the distal flange, that lip, it may cause trauma and bleeding.
So house is open for discussion.
I
For
need
questions.
to conclude now. Very sorry, need to conclude. We are just. Thank you very much. Thank you.
And I'm here all day to answer all of your questions. Thank you.
I would like to thank the speakers and chairpersons for their invaluable contribution. Moving forward to our next session, that is a board discussion, for which I would like to invite as chairperson, Dr. Saurabh, Dr. Dinesh Garg, Dr. Bhagwan Thakur, Dr. Bir Singh Serawat, Dr. Hemant Kumar Nayak. The tumor board discussion is discussion making in higher blocks, ERCP versus EUS versus percutaneous. How do we simplify our options? The panelists are Dr. S. Bajal, Dr. A.S. Soin, Dr. Mohan Ramchandani, Dr. Pankaj Desai. The moderator for this both session will be Dr. Zubin Sharma.
Good morning, everybody. And I'm here with my close friend and colleague, Dr. Soumya, and we both will be taking up this a tumor board discussion with our expert panel. We have a very esteemed faculty here with us for this tumor board discussion. We have Dr. Soin available to us. Dr. Soin is a world acclaimed liver transplant and resection surgeon. Currently, he is the chair at Medanta. We have Dr. Bajal sir, who we all met yesterday, and we all see his brilliant work. We have Dr. Pankaj Desai sir, whom we all know, and he's an expert in endoscopy and EUS. and Dr. Mohan sir also, of course, we all are very well. He's a world famous endoscopist. So Dr. Soumya and me, myself, we'll start with a simple case. I'll brief the case, and during this case, we will ask our expert panel on what are the problems that we usually face while managing a case of a hilar block. And hilar blocks, we all are aware is a problem area for us endoscopists. It's an area where the interventional radiologists, surgeons, gastroenterologists, they all argue a lot, discuss a lot, and we can't reach a consensus. So let me just start the case and then we take it forward. So, sir, this is a case. A 53-year-old female, a resident of Haryana, belongs to a tier 3 city. And her only history is painless, progressive jaundice since 2 weeks. There was some cholestatic features, no fever, and no other significant symptoms. And she came with a report of a dilated intrahepatic radicals with distended gallbladder, no ascites, and some liver enlargement. And these were the basic, the initial lab panels of serum bilirubin around 5.5, some enzymes derangement, but rest essentially okay. CA19-9 was 17 and IgG4 levels were normal. This was the initial scan done. I'll just play down the videos gradually. So I have written the report also, which was given to us because on a moving video, it's sometimes difficult to come to a diagnosis. So this was the report that was given to us, was an intense plaque-like enhancement involving the primary constituents extending into right anterior and posterior, involving the common hepatic duct for a length of 1.8 centimeters. And bilobar IHBRD was, of course, noted. So I'll ask Dr. Soumya to take over from here. So the first question now comes, we have seen the scan, there's a hilar mass. What do we do now? So
being a gastroenterologist, we see this type of cases very often. So my first question is to Dr. Mohan. So this is a case with hilar obstruction raised CA 19.9, and so what additional investigation do we need to do prior to refer it to a surgeon on the imaging if it appears resectable?
So I think this is a 53-year-old lady who is quite young. And so now we should have a question whether to go upfront surgery where we have good imaging evidence of malignancy. We can take help of tumor markers. And if a very good operable case with a good evidence of malignancy on imaging, if we have other differential diagnoses like IgG4 disease on imaging, you have pancreatic sausage shape or other organ involvement, which raise the question of alternative diagnosis, then I will go more into the other investigations. But if there is a good evidence of malignancy on surgery, patient operable, patient does not require any preoperative biliary drainage, no cholangitis, bilirubin is 5, patient may require right hepatectomy. I will, if I am the only decision maker, I will go for surgery immediately. But if I don't have the imaging evidence of malignancy, the bilirubin is high, patient require right hepatectomy, may require assessment of remnant liver, I may have to do more, the investigation in the form of tissue diagnosis, preoperative biliary drainage. But in this, I will give more weightage. If I am only the decision maker, to call my surgeon that, look, this is the patient with a very high possibility of malignancy. Why don't we go directly for surgery?
So, sir, the common practical scenario we all face is sometimes the patient wants a diagnosis. In some centers, the surgeon can ask for a diagnosis, and oncologists will always ask for a diagnosis. For them, until there's a tissue, there is no issue. So how do we, proceed with that? So if you talked about the upfront surgery, we have the resectability criteria, but how do you answer this question that we need a diagnosis from a patient or somebody else.
I think. So your question is, if no upfront surgery is required, I
No, even if it is required, we may have a patient who is asking for a diagnosis.
Yeah, so I think if the patient requires diagnosis, I think that is another issue. But if our surgeons and if our radiologists also feel so, if the patient is completely resectable, there is no involvement of the vessels, there is no extension of the tumor into the both secondary radicals, there is no atrophy, there is no portal vein involvement. I think this patient may be taken for directly surgery, but yes, there are certain issues. Surgeons want for before major resection, they want a biliary drainage to be done. Yes, we may require tissue diagnosis, but otherwise I will not in this case. But at all tissue diagnosis required, I will go for a first good CT scan and MRCP. Both are important to have a look on what is the extension of the disease, what are the biliary radical involved, and we'll see that which are the biliary tree which to be drained. I will give. Well, I would like to see a good MRCP in this before going ahead.
So my next question is to Dr. Soin. So in this case, so if with bilirubin around 5, raise CA99, and on imaging patient it appears resectable. So is it okay for you to take for surgery, or any additional investigation do you want from the gastroenterologist?
Well, this patient is, first of all, I'd like to see an MRCP as well, because I'm not clear what the type of the tumor is. Of course, it's a hilar tumor, but I'd like to see an MRCP to see which systems are involved, which is not involved, whether I'm going to do a right hepatectomy, left hepatectomy. So that's the first thing. Second, I'm not happy to do a hepatectomy with a bilirubin of 5. So I would definitely like a biliary drainage. My general threshold for accepting patients for a major hepatectomy would be 2.5 bilirubin or less. It's been clearly shown that the incidence of post-hepatectomy liver failure is definitely higher with bilirubin more than 3 in large series from Japan, Korea. So I would not go ahead with a bilirubin of 5 if I was planning a hepatectomy, which I don't know right now because I haven't seen a proper MRCP.
Dr. Pankaj, you wanted to add something?
Are there any different thresholds when you're dealing with a hilar cholangio versus a distal CBD for bilirubin for going ahead with the surgery? So maybe if we have a distal
Yeah,
CBD,
sure. Because if you're not doing a hepatectomy and if you're doing a distal CBD tumor resection, then you basically want to do a Whipple, in which case we don't really need biliary drainage at all. Some people like to do it if the bilirubin is more than 15 or 20 mg%. But generally, we are not very fussed about it unless there is cholangitis.
Just an extension of this question. Do you have a different cutoff for left hepatectomy versus right hepatectomy?
Not really.
One small interjection. What are the CA19 levels?
I think 18 or 17 or something.
It was 18.
Normal?
It
Is it
was normal. It
So
was
they were
normal,
normal.
sir. It's normal.
Yeah.
So some of the hilar blocks where we are planning for the surgery. This is for Dr. Soin, sir.
Beg your pardon?
So over there.
Yes, and we find them, many of them inoperable. If we find them operable on imaging also, when we go inside them. So how to convince the attendants regarding diagnosis? And sometimes we get surprising diagnosis also. So don't we need a tissue?
So generally, if the imaging is typical, and if the CA19 is elevated, then we do not insist on a biopsy. But here, the CA99 is actually normal. And imaging, I'm not very clear what it showed. So yes, I would prefer a tissue diagnosis at this point. Now, the other thing is that you made a little statement there saying that sometimes you find that intraoperatively things are not operable as you thought preoperatively. I proudly say that hardly ever happens in our system. We usually, almost always, I can't remember when, and I explored cholangiocarcinoma and did not come out after a resection. And we do,
but I think
we do close to 30, 40 such resections every year.
that may be because of expertise, but I go with the opinion of house like don't we find them inoperable when we suspect operability in especially hilar malignant blocks?
So, I mean, you can have it, but that's what I'm saying. I think if your imaging quality is good, then you will almost always predict what's going to happen during surgery. I mean, we go to the extent of diagnosing vascular involvement to the nearest millimeter. We decide whether if you're going to do a left-sided resection and the right-sided artery needs reconstruction, we see where the anterior and posterior sectoral arteries are coming out, how many millimeters they are outside of the liver surface. We do all that before we actually go in for the surgery.
Only thing is sometimes the R0 resection may come down because the cholangiographic evidence may show that the tumor is extending up till here. But if you see the cholangioscopic extension may be slightly longer. So what you think is R0 resection may not come out to be R0 resection ultimately, though it is still operative.
So, I mean, everybody that does cholangiocarcinoma resections does intraoperative frozen, right? And we do a distal frozen and we do a proximal margin. And obviously we make sure the margins are free. Again, can't remember in the last 80, 100 cases if we actually had a positive margin when we didn't expect it, because you know all that from preoperative assessment. But yes, occasionally you can be caught out where the margins are not free. So you've done an R1, but not an R0. Or in a case where the frozen is negative, but the actual histopathology is positive. So those are rarities. I don't think people should go back with the impression that happens usually. It does not usually happen. So I would say 9.5 times out of 10, you know what you're going in for, you do the resection, you come out with free margins. That's the way it goes with us.
So, sir, moving on to the next few, because we have some more slides coming up. So, in case this you need to take a biopsy, so what we normally do is we do an EUS biopsy. If there's a mass forming lesion, we can do a cholangioscopic biopsy. If it's not a mass forming, only a stricture. And I want to ask Dr. Bajal, sir, is the radiological diagnosis alone sufficient or the criteria clearly defined?
No, one can never say that it's substituting pathology. There's no statement that can go that far. But there's no doubting it that in the absence of any other suspicion, plaque-like disease, persistently retaining enhancement, some diffusion restriction on MR would be criteria which would definitely tilt very much in favor towards malignant etiology.
One more thing I would like to ask Dr. Bajal, how and on radiology can you make out the longitudinal extent in these diseases? Because sometimes what you see, the distal extent or a longitudinal extension of the disease, is it possible to make out the exact accurate diagnosis on radiology imaging?
So I think that the proof of the pudding is what Dr. Soin finds at surgery. So if the preoperative planning, which is purely on imaging alone, is confirmed at surgery, that means that we are doing a reasonably good job.
So, Dr. Pankaj, how would you differentiate between IgG4 related disease and cholangiocarcinoma in a hilar mass without pancreatic involvement?
The IgG4 related. So the actual tumor, I think, would look on. We are asking me on cholangiocarcinoma.
Sir, not on sir, on endoscopically, EUS, cholangoscopy, and on other modalities. How will you differentiate between IgG4 versus cholangiocarcinoma in a hilar mass without pancreatic involvement?
I think one should see full CT scan and see first of all the other organ involvement. Moreover, IgG4 disease is sclerosing disease where there will not be much of intrahepatic biliary ductal dilatation. It's more closer differential diagnosis to PSC. If you have a hilar stricture with massive upstream dilatation, no other organ involvement, pancreas is normal, pancreatic duct is not dilated, or if there are kidney lesions which show up, these are the things which will make you suspicious about IgG4 disease. Otherwise, for a isolated hilar stricture is very, very rare to have in IgG4.
I think all the postgraduates should make a note of that. That's a very pertinent point.
So our patient did ask for a diagnosis and we had to do a cholangioscopy. We took biopsy, you saw the video. And now, after we have done a cholangiscopy, we had to put in a plastic stent, of course, to drain it. Now, there are 2 points in draining. We have one, a preoperative drainage. Also, I think sir already answered that for level of 5, he would want a preoperative drainage. And he is plus for palliation, we all are aware. So there are multiple options. I think I'll discuss in the subsequent slide. We can do a direct ERCP or an EUS guided, and of course, percutaneous options are always there. So I will directly go on to the case for the sake of time. So this for the first ERCP, we put in a plastic stents, we took biopsies. We had to take an air cholangiogram, we did not put a dye. Now, after that, patient did develop cholangitis. We had to manage with IV antibiotics, and MRCP was now done after the ERCP. So this is the MR, sir. As you can see, the right posterior is still persistently dilated. So what next would you do now, Dr. Pankaj sir? Anything else that we can do now? Can we still think of a surgery, or we should be?
In presence of cholangitis, I think surgery would be definitely out of question. And once you have this stent, I think segment which has been left undrained, I think we have to drain that segment first, settle the cholangitis, and then and only then we can go ahead and plan surgery. So probably we'll have to drain that right posterior duct again, and you can do it either maybe a PTBD. That I think or if those stents previously placed are blocked, you can just remove exchange and then put in either a plastic stent or a metal stent for the time being. Now, because there are reports that even after metal stent surgery is feasible, I'd like to have Dr. Swain's opinion, but then I think definitely you need drainage of the right posterior duct here.
Right, sir. So that's what we did. We did an ERCP. We put in one additional stents in the right posterior segment. For the course, the biopsy finally came out to be a hilar cholangio type 3A block. Now, we had a multidisciplinary team meeting, sir was there, and we thought of that this it's still resectable, and we should at least do a volumetry. And we were still on that plan of, yes, this patient may be resectable. So we did a volumetry, the volume was insufficient, and we planned for a portal vein embolization. So I want to ask Dr. Bajal, sir, in your, what's a broad area where you would do portal vein embolization in such cases, and anything that we as gastroenterologists should know when we assess volumetry?
Sorry if I just go back a step. I think the decision to do biliary drainage and the way biliary drainage is to be done, which part of the liver is to be drained, what can be left undrained, should all be done in discussion with the surgical team who's planning the surgery. So it's imperative to really come to the MDT at that point itself, rather than doing the endoscopic interventions. And now we are always salvaging and then preemptively actually do what is the best required. As far as the portal vein embolization is concerned, we again talk to the surgical colleagues. If they are planning only a right hepatectomy, then we just need to do a right portal vein embolization. If they're planning to do an extended, then we need to hypertrophy only the left lateral part. Then we extend our embolization to the segment 4 as well. 4A and 4B, we normally do separately using different methods. That's probably more technical.
So yes, sir.
I'll add a word here. So yeah, absolutely. Sanjay is spot on. So if you're planning a right hepatectomy and you need the left-sided liver to hypertrophy, then you would do a right portal vein embolization. On the other hand, if you're keeping the right side, then you would do left portal vein embolization. But usually the right-sided hepatectomy requires a right portal vein embolization much more often because left lobe is smaller, so you want it to regenerate and hypertrophy.
So in this case, the patient did undergo a portal vein embolization, so we had to wait for a couple of weeks, 3 weeks, and she was on plastic stents. So of course, she again developed cholangitis. We had to put in. So again, we had a discussion with our surgeons. We were still on the track, and now we thought that we can possibly go, do with the SEMS in the right anterior and right posterior, but leaving a plastic on the left side. So after 3 ERCPs, the ducts were finally decompressed and cholangitis settled. The patient was still on for a surgery. Reassessed after 3 weeks with this much volume. The volume had increased, that the end FLR was now more feasible, and patient did undergo a resection at our center. Finally, the final diagnosis was again a moderate differentiated cholangiocarcinoma, T1, all margins for free. Dr. Swinser's team and Dr. Belser's team was with us when we made up 4 months follow-up. Patient is doing well, and at 6 months she is on a single drug capecitabine. So I just want to conclude is that this case highlights why we need a team management. This case took us for almost a couple of months for us to manage as gastroenterologists with Dr. Bejal sir, Dr. Swinser and team, and we have all the armamentarium in place. But what to choose in which patient is definitely needed. So thank you so much, and I think I'll close for the sake of time. Thank you.
Thank you very much to the panelists or the esteemed chairperson here.
Can I make one little comment?
Please.
On the surgery. So traditionally, everyone understands that in hyalocholangiocarcinoma, there is involvement of the caudate lobe. And because caudate ducts are involved because they are basically at the confluence. So traditionally, you would resect the caudate lobe. And it's also the reason why sometimes a part of segment 5 is resected if you're doing a left hepatectomy, or a part of segment 4, a complete segment 4 is resected if you're doing a right hepatectomy. So what we tend to do is, in this particular case and in general, we were doing a right-sided resection for type 3A. We would do a right hepatectomy with a sliver, about 2 centimeter sliver of the inferior part of segment 4. So you basically get the entire hilum and the adjoining liver tissue and the caudate. So it's not strictly a right hepatectomy, it's right hepatectomy with caudate lobe resection with a part of segment 4B resection.
What about metal stent problem in the hilum?
I mean, you guys are so enthusiastic about putting stents, so sometimes we have to deal with metal stents, and we are able to, cut the stent and then gouge out the bottom, maybe half or 1 centimeter of the stent from the part that needs to be anastomosed. We are able to manage. It's not a big deal.
Your preference for preoperative drainage, PTBD or ERCP, NBD, PTBD, ENBD, or stents?
So it's always endoscopic first, right? But oftentimes you have to do PTBD because systems are separated, so you're not easily able to do it. And you generally try and drain about 2/3 of the liver, and the bilirubin would come down.
Thank you, sir. Thanks all the esteemed panelists and the chairperson. So we are moving ahead with the next session. Thank you, sir.
For the next session, I would like to invite as chairperson, Dr. Gaurav Patil, Dr. Ramesh Garg, Dr. Srihari Anikindi, Dr. Nikhil Mahajan, Dr. Devendra Singh, and Dr. Saurabh Mukherjee.
So we'll move on to the next session, and it gives a great pleasure to introduce Dr. Philip Matthew to start with the next talk. He's going to start on US guided management of neural blocks in pancreatic diseases.
Thank you, Chairpersons. First of all, I would like to thank Medanta team for giving me this opportunity. We know that pain is a major and distressing symptom in patients with pancreatic cancer and chronic pancreatitis. And it's also noted that pancreatic pain actually reduces the quality of life, and even it is considered to be a prognostic factor. Generally, we start with the pharmacological therapy, If it fails, moving from NSAIDs to opioid drugs, then we change or take up these patients for interventions, especially celiac plexus intervention. What is the principle of celiac plexus intervention? We know that celiac plexus is located at the origin of celiac axis artery and around the superior mesenteric artery. It contains ganglia and also interconnecting nerve bundles or neural rami. And this is primarily responsible for transmitting pain sensation originating from the upper abdominal organs, especially the pancreas. And when you interrupt or block or create destruction of these ganglia and nerve bundles, it can actually prevent the pain sensation going from this organ to the spinal cord. So in fact, in neurolysis, what we do is an irreversible ablation of the celiac plexus. Looking at the celiac plexus neurolysis, it's a chemical ablation of destroying or blocking the celiac plexus nerves. In 1914, this was initially introduced by surgeons during an intraoperative procedure. But later, radiographic, fluoroscopic, CT-guided, ultrasound-guided, and lately, it is endoscopic ultrasound-guided technique was introduced in 1996. This is basically because EUS could precisely image this area and access this area. When you use EUS, we can see that this is the endoscopic ultrasound, and this is the area of celiac trunk, aorta, and this is the celiac plexus, and you can see the celiac ganglia also. So this is an easy accessibility with that. When you look at the interventions of celiac plexus, you have got two procedures, only celiac plexus neurolysis and celiac plexus neuroblock. And neurolysis, we use a combination of chemical agents like an anesthetic agent like bupivacaine or along with ethanol or phenol, mostly ethanol. Block, we use bupivacaine plus steroids, either triamcinolone or dipamitrol. And one is used for, neurolysis basically used for inoperable malignancy, and celiac plexus block is used for chronic pancreatitis, especially in a situation of intractable pain. My discussion will be focused only on celiac plexus neurolysis. I'm not going to touch on block. So basically we use chemical agents like ethanol for phenol. Commonly used is ethanol, or you can even try, people have tried using radioactive molecules injection in that, or thermal like radiofrequency ablation. Basically what we had to look at is we had to identify the anatomy. You have to see the aorta and identify this angle, and this is the origin of celiac trunk, and that is the area of our interest. So the needle should come to the central area, and you require a Doppler, and once you start injecting, it should be under clear vision. So basically, again, you have to see the crest of diaphragm, and then you see the origin of celiac trunk arising from the aorta, and you place the needle at the angle of that. So visualization is very important. How do you do the procedure? It is the assessment of the patient properly, and then use deep sedation or IV propofol. Mostly we use IV propofol, and patient is in a left rectal defecatus position. You adequately hydrate the patient, very important. IV fluids prior, during, and after procedure. This is basically to reduce the chance of hypertension. And if you are using, block in chronic pancreatitis, prefer to use antibiotics. You use a linear EUS, locate the celiac artery, take off from the aorta, confirm with Doppler, try to locate the celiac ganglia if it is visible. You use a combination of local anesthetic agent and a neurolytic agent that already we discussed. The quantity is quite variable, but I'll tell you what we do. You use a needle puncture. Usually I use a 22 gauge needle, but there are people using 19 gauge needle. And when you do a broad plexus, you use a 25 gauge. Aspirate for blood to make sure you are not in a vessel. And you use a sequential injection of bupivacaine and followed by ethanol. Again, you have to see where the needle is, very important, and make sure that when you inject, the Doppler is stopped. And these are different types of needle. What you use a aquative needle for alcohol injection, and for CPN. And there is actually a dedicated needle, it's a 20 gauge needle, which is not very commonly used by people, but it is there, we can use it also. So what are the contraindications of CPN? The absolute contraindications are, you should not use CPN in a patient who is otherwise likely to be operated. Coagulopathy, then low platelet count. Relatives are when there is actually esophageal varices or gastric varices or in a patient with a portal hypertension or previous gastric surgery when the access of this region is not possible, or when there is anomalies of celiac trunk. This is just to show you a video of celiac neurolysis. You see the pancreas, then identify the aorta, come back to that area, see the anatomy there, put the Doppler, make sure this is actually a adrenal artery coming from there. So you identify location, the needle is coming out in good location, you enlarge the image, and then you start injecting there. Make sure before also that it is not in the vessel, aspirate and confirm. You can also, that is, you inject the central area, then you can actually inject on the side as well. Identify the location, then you tilt the needle on the side and then inject. So what is the efficacy of neurolysis? It's found to be variable results of short term and long term, but long term means after 30 days, short term means within a week. How do you improve the outcome? There are different areas where we can look at. One is the types of approaches of neurolysis, or whether it is a celiac ganglion neurolysis or a plexus neurolysis, or it's a broad plexus neurolysis, which is a conventional one, the quantity and agents used in neurolysis, and timing, early versus late. Patient-related factors, even sarcopenia is found to have a decreased response of pain by CPN, visibility of ganglion. Unless we see the ganglion, we cannot actually target the ganglion. It is not seen in everybody. Then there are tumor-related factors like celiac plexus infiltration. Once the celiac plexus is already destroyed by the tumor, there is the pain mechanism may be different. There is no point in giving aggressive celiac plexus neurolysis in those patients. Then also a proper targeting of the ganglion plexus. While doing, you may be able to see that. If the patient develop hypotension, that means you have targeted it well. Or the patient developed tachycardia. There is a study from Orlando that showed that probably the targeting was right. Then predicting the response. So what are the different types? You can even go as a central one, that is a classical one. You inject at the root of the celiac trunk origin from the aorta, or it can be bilateral on either side of aorta. Afterwards, many people combine that, or you directly, the ganglion is injected, or you use a broad spectrum, it's broad approach that is along the celiac, supramesenteric artery. So it can be a central, unilateral or bilateral, or a broad plexus one. What are the evidence of this? Actually, the studies have shown that there are no major difference between these two, but there are two meta-analyses probably showed that this bilateral approach could be beneficial. And what is a broad technique? Where you tackle the nerves around the celiac trunk and also on the superior mesenteric. But be careful that these areas were technically demanding on when you inject on the superior mesenteric artery region, and you have to use a very thinner needle like 25 gauge. And the studies have shown that two studies have shown that probably this could be beneficial in patients with pancreatic pain, but it is not really generally practiced, and many people are not practicing it. And we need more studies on that. So what is celiac ganglion neurolysis versus celiac plexus neurolysis? One is that we know that you identify the location, which I show you, and this is actually on the region of celiac plexus, not targeting on the ganglion. But in other one, ganglion CGN is actually you target the ganglion, then inject. Many times we combine both. You see the ganglion, inject on the ganglion, and also do a injection on the surrounding region. So identification of the ganglion is important, and you can target it with that. The DD comes that sometimes it may be a node, but many times even if it is suggestive of a ganglion, we inject in that region. This is another case where we actually see, you can see the crus of diaphragm ending there, and put a Doppler, and you see there is a ganglion there. You target the ganglion and then inject. Similarly, another case where we combine, you inject the ganglion and finish it off as a CPN. So we combine both. This actually produces good results. That's what we use. So what is the evidence of ganglion neurolysis versus plexus neurolysis? There are variable studies, and some studies have only one study which include both chronic pancreatitis as well. But it is found that probably there is no major difference. But some of the studies suggest that at least in the early part, That means in the first week, there is a good response if you have a combination of CGN plus a CPL. So what about early versus late? Suppose you diagnose chronic pancreatitis and you do an FNA, the ROS has shown its malignancy and the patient is inoperable. So if you do it at this stage, or you try opioids and then later try, but it studies say that probably if you do early, it is beneficial. And what about the new techniques? There are two other new techniques introduced. One is that you use radioactive iodine particles injected into the, using fiducials injected into this region, and gradually that produces radiation, or an RFA, which has come like that. This is actually a study from Orlando, and this has shown that probably RFA could be of benefit. I think this is beneficial when you use it on a targeted ganglion. What are the predictors of response of CPN? There are so many factors looked in, but they found that 3 factors which are found to be of almost finishing. And this is showing that there is independent variables which actually showed a negative predictability. That is, invisible ganglia, invasion of celiac plexus, and distant metastasis all had negative result. And what is the impact of CPN on survival? Does it really improve survival? Yes, there are some studies says that if your efficacy of CPN is good, survival is also much better. That there are, fortunately, the major complications are rare, but minor complications do occur, but it's manageable most of the time. The take-home message would be that significant pain control is achieved with CPN in the setting of pancreatic cancer in majority of cases. But the long durability of pain relief is not commonly seen. And the safety profile is very good. Ganglion neurolysis probably could be could potentially give a better benefit in these patients. Various types of CPN are comparable in efficacy and outcomes. Early neurolysis could be beneficial. RFA is a new technique, you need more data. Predictors of response could select patients who are likely to benefit, and quality of life and survival benefits need to be focused in future studies. Thank you so much for your kind listening.
Thank you, Professor Nathan Philip. I think because of the lack of time, we'll go on to the next talk. I now invite Professor Malay Sharma for his talk on US-guided variceal management. Professor Malay is a prolific gastroenterologist, and he's been a mentor to most of the young gastroenterologists in this country. So, Professor Malay, please.
So, I would like to talk on portal hypertension and endoscopic ultrasound, what is new. So we must know that there are diameters which are important, taken with the formula of 12 portal vein, 10 superior mesenteric vein, 8 splenic vein, 6 for inferior mesenteric vein, and 4 for the left gastric vein, which are the cutoff point for deciding that this is portal hypertension. And then we decide whether these left gastric veins and all where they are adjoining, and we can measure them. But what is more important for portal hypertension, to be able to identify how these veins are becoming what they are when they come to becoming paraesophageal, paragastric, periesophageal, perforating before they become submucosal into the circulation. So this is the sequence of events that happens, and that is how we come to find out that there are inflowing perforators and outflowing perforators which are going outside the wall. So be clear, you must decide that these are the perforators and all. And be clear that EUS has little role in esophageal varices, and the more role it has involved has been in gastric varices. And this is where we start our talk first one. We have to identify where the gastric varices are by finding they are present in the submucosa. Of course, they are in the submucosa. And then you have to see, you will be troubled lifetime many times right now with recurrence problem. You are seeing this glue, but that is not the end. You are having more problem. So that is why, dear friends, it is important to be able to identify that these varices have 3 types of varices in the stomach. They can be cardiac, fundal, and isolated gastric varices, as is seen in this picture. This is an isolated gastric varices masquerading as a submucosal tumor. But when EUS was done, you could identify that there are inflowing perforator, there are submucosal, as well as there are outflowing perforator. The question is, it is easier said than done to identify inflowing perforator, and what exactly is an inflowing perforator, and where exactly do you look for when you are looking for inflowing perforator? But that is a difficult question not to answer. See, in this case, you see glue. And when you see glue, along a path. And what do you see in this glue is a hypoechoic appearance. So this glue had tracked along an outflowing perforator, and to be able to image these type of thing along the path, along the outgoing path will be important in future, because you will be doing EUS, you will be putting in coil and glue. That will not be a difficult job. You will identify the muscularis mucosa of the duodenal wall. You will identify, more importantly, as a beginner, the falling curving muscularis mucosa of the gastric wall, because that is the end point up to which you want to enter. You want to push your needle all the way to the opposite wall. You can go through, and remember, there is nothing called going through curves of diaphragm. You remain within the lumen. You cannot go out of the gastric wall. You have to remain within the lumen. And when you remain within the lumen, you puncture, you put in coil. In this case, it was a smaller coil that has been put in. Be careful, measure the size of the varix. A bigger coil, a larger diameter coil, put in 1, 2 coil, 3 coil. Never use color Doppler as I did in the first instance, because color Doppler is not important. And in this case, you are seeing the coil, you are seeing the curve of the varix, as you can see. And here you are seeing so many imaging defects, imaging artifacts because of the coil, because of the flu, isoechoic appearance, thrombus appearance, echogenic shadow, comet tail artifacts. And that is why I said coil, soft shadow, hyperechoic, comet tail artifact, coil along the track. So these are the appearances that you need to know. But there is a small thing. When you touch sometimes these varices, they don't appear as hard because they are not totally glued, but don't worry, because there is no flow in this. What is wrong? These are the varices, and this 30% will have rebleed despite that normal gluing. And these are the important rebleeds that we need to tackle by putting in more coils, small micro coils. And as I said, there are 7 types of appearance, but there is limited time. Involved in the lumen, outside the wall, different type of appearances, different reasons to have these appearances. And that is how you decide. More and more future will not be within the lumen. It will be outside the lumen, injecting paragastric. And this is an instance where a paragastric varices has been injected with glue. Just 1 ml paragastric varices has been glued. Do not try, in my opinion, to inject coil paragastric, but inject glue paragastric. Very good. 1 ml will be sufficient. Recurrent varices, we didn't inject in the residual varices. So single glue 1 ml will be possible and will be 1, 2 ml, and there will be studies in future. What about duodenal varices? Be careful. Their duodenal varices flow goes all the way to the shunt, the veins of Regius back towards the vena cava, and these are the duodenal varices. You can be mistaken. Sometimes they can be so small that in a single place there is an inflowing as well as an outflowing perforator. But these you have to bend, and you have to do hemodynamic evaluation, bend from below upwards, and do bend just like in the esophageal varices do, and they will do well. You can do bend. This is a case, duodenal varices, complicated, but we are not sure. No bleeding was demonstrated. EUS was done. And when we did EUS, in this case, we found that there was duodenal varices, and this duodenal varix was injected again with a coil. And then US guided microcoils were placed. However, this may appear, do not panic. Sometimes people say that they will leave half coil outside, half inside. No, there is nothing like this. It is your technical difficulty in the placement of the last part of the coil that is making you disturb, and these coils may be left outside. Do not worry. Half of them have gone in, they will do as good a job. And this is, we can do later on the intervention as happened in this case. And then we can decide about what to do about this case. So, however, when we placed a stent in the bile duct, there was torrential bleed. And once this kind of bleed starts, I do nothing. We place in a guide wire and we place in a stent, and we worry about things later, do a cholangioscopy. And in this case, we could find the patient had intracholedochal varices. The coil previously placed in duodenal varix was there. And then So coming to the last part, rectal varices. Remember, esophageal duodenal varices flow is from below upward. Rectal varices flow is from above downward. So when you're thinking of rectal varices, be careful that you have to see the flow. The superior rectal vein comes down, divides into two, and then it keeps on flowing down along the pararectal before it decides to perforate into the submucosal intrinsic rectal venous plexus, where between a distance of 10 to 3 centimeter, they are going to form rectal varices. But remember, the flow will be from above downward. And that is why there is an inflow zone, there is a downflow zone. And then there are two outflow zones of rectal varices, one in the 6 to 4 centimeter, and one is the 1 to 4 centimeter zone. And this is the inflow zone, not the outflow zone. Never band a rectal varices, never coil a rectal varices at the lower end, band it at the highest. And when you are going to do band it at the highest point, remember that you can do band sometimes submucosally. Do not intend to see, do not see, because if you are interested in seeing the rectal varices, you will inflate the rectum and it will be deflated. So do not try to inflate so much that your intention. You see, demonstrate the rectal varices on rectal ultrasound, and once you're sure that the rectal varices is where, you just place the band, anterior wall or lateral wall. Blindly rectum is a big structure. It will be single rectal varices entering from 7 to 10 centimeter lateral wall of rectum, spreading submucosally into the intrinsic rectal venous plexus of the rectum. And that is why you apply a band first above. And if there is a rebleed, you band it lower down. No, sorry, bend it up or down, because the rebleed will be happening above. So conclusion, we should document that this is a varix which is bleeding. Never assume. Identify hidden varices. And US is more sensitive. Manage it. Thank you very much.
Thank you, Dr. Malik, for the excellent presentation. Then we have one or two questions. In sir, which cases of gastric varices you decide for going for the endoscopic management versus EUS management of gastric varices? What do you recommend? I mean, which patient subgroup or select the patient?
There is no subgroup. Whatever the patient can afford, that is the limitation. Patient can afford, but I believe I will be able to reduce the affordability by following up this theme that you put in only 1 ml varix outside paragastric inflowing perforator.
Sir, any advancement in the EUS guided tips placement in the what is the present scenario? What is the present status of that?
US guided tips.
Yes, sir.
Okay, simple thing. You have to kill 2 birds with 1 arrow. And what is the first bird? The first bird is IVC. The second bird is left branch of portal vein, or maybe portal vein. Okay, that is possible. But you need to do a lot of animal model punctures. You need to find a right kind of axios stent, if you can design it, which will expand into the portal vein and which will expand into the IVC.
So whenever there is an isolated gastric varix or duodenal varix, when to decide only glue or glue plus coil?
This is a big question, debatable. How much are your skills? How much your skill? And what is the bleeding patient? Remember, sometimes when there is nothing you can't see, do not assume that you will be able to see varix on endoscopy. Go by US, quicker, faster. If you have nothing, put in an US. Do not retroflex. You can never retroflex a US scope. What you need is retroflexion, and you do not know how painful it is sometimes to retroflex and not able to see a bleeding fundal varix. Whoever you are, you have faced this situation. So you have all the tools available. If I have emergency, I will go with EUS, get in, within 2 minutes, put in a glue or coil, whatever, and get out. You don't have time.
But if there is no emergency, it's a bleed from duodenal varix because volume is very small. There is no place for glue as well as coil. So in duodenal varix, they are linear.
See, sometimes speed is the issue. Sometimes eradication is the issue. Sometimes bleed is the issue. What is the issue? Do not look at the virus is not the issue. Sometimes what is the issue? It is not a simple question, not a simple answer, not a one-way answer.
And in rectal varix, if they are
I
not
think we can
bleeding,
discuss this on the later on.
Yes,
because
yes, yes.
organizers are asking
So you
for
are
the-
moving ahead with the next
Yeah,
talk.
yeah.
Please invite the speaker.
Yeah.
Thank you,
The
sir.
next-
Thank you.
Thank you, Dr. Malik, for the excellent presentation. The next presentation is by Dr. Vikas Singla. All of us know him. US guided ablation of pancreatic cyst. Where do we stand in 2023?
A very good morning to all of you. At the outset, I'm thankful to Dr. Rajesh Puri for the kind invitation. So I will be discussing the role of EUS guided ablation in pancreatic cyst. So this beautiful plant produces a very toxic substance which is called paclitaxel, and that's the backbone of management of pancreatic cystic tumor. It inhibits the microtubule formation and arrests the mitosis, and it has become the backbone of management of pancreatic cystic neoplasm. So the most of the pancreatic cystic neoplasm, they are diagnosed on the CT or the MRI. Earlier, the most lesions were the pancreatic pseudocyst or the wall of necrosis. Now our threshold for CT has reduced, and mostly we are diagnosing the pancreatic cystic tumor in the middle age or the elderly female. So these are the differential diagnoses. We all know serous cyst adenoma, mucinous, IPM, and solid cystic, and sometimes they can be NET or the adenocarcinoma. And barring serous cyst adenoma, all the other lesions, they have a definite malignant potential and they need treatment. And with the EUS guided ablation, we should be targeting only the mucinous cystic neoplasm or the BD IPMN. Other lesions should be sent for the surgery. First is the mucinous cystic neoplasm. 15% of mucinous cystic neoplasm, they can be malignant. They don't have a communication with the MPD. And the lesion size is less than 4 centimeter, and if there is no nodule or the solid component, it's likely to be benign. Mostly these patients are young female and they require a long surveillance. So the Fukuoka guidelines in 2012, they recommended surgery for all the patients with the mucinous cystic neoplasm. And for the BDIPMN, the decision making is more complex. We have to go by the MRI finding, clinical finding, and the US finding. We have to look for the high risk factor. We look for the worrisome feature. Then we make a surveillance program for the patient, or we recommend surgery for these patients. So far, the things appear simpler, that we should be diagnosing mucinous cystic neoplasm and the BDIPMN, and we should be treating. But the main issue is how to diagnose MCN or the BDIPMN. The gold standard for diagnosing is the surgery. And in short of surgery, we follow these investigations. First should be the history and the examination, then MRI, US morphology, and then we tend to aspirate the fluid. At few centers, there is availability of confocal endomicroscopy and through the needle biopsy. So when we have a EUS and the MRI finding, we can divide lesion into the 4 categories. Type 2 is the serous. It's a microcystic tumor. It's a serous cyst adenoma. Doesn't require any intervention. Type 4 is a cystic lesion with the solid component and the large nodule. It's a malignant lesion, requires surgery. The first and third, they can be managed with the endoscopic ultrasound guided ablation. So the differential diagnosis vary from it can be either a inflammatory lesion, pseudocyst, it can be a mucinous cystic neoplasm, or it can be a oligocystic serous cyst adenoma. And for the further evaluation, first and third lesion, they should be aspirated. So when we aspirate, we send the sample for the amylase, CEA, glucose, and then we do the mutational analysis. High amylase goes in favor of pseudocyst, high CEA goes in favor of mucinous cyst, and the low glucose favors the mucinous neoplasm, and the presence of mutation again favors the mucinous neoplasm. But they are far away from the perfect. If we see their sensitivity, high CEA more than 192, sensitivity only 58% to confirm a diagnosis of mucinous cystic neoplasm, but there is a high specificity. If we increase the glucose value to the CEA, it will increase the sensitivity and the specificity. And further, if we add the KRAS and the GNS mutation, it will again increase the sensitivity and the specificity. And then if we add the confocal laser endomicroscopy, the sensitivity again will be increased to more than 95%. Unfortunately, at most of centers, we don't have a confocal endomicroscopy, and we go by the CA and the amylase report. So if the CA value is less than 5, it can be either a serous cystic neoplasm or the pancreatic pseudocyst. There doesn't require any intervention. And if the CA is more than 200, it can be a mucinous cystic neoplasm. It should be treated. The CA between 5 to 200, it's a indeterminate type of lesion, can be serous or it can be a mucinous cystic neoplasm. So once we have presumed, we presume because we are not sure about the diagnosis because limited sensitivity and the specificity. So we presume it's a mucinous neoplasm, and the Asian EUS group recommend EUS guided ablation if the lesion is unilocular or oligolocular. Oligolocular means there are between 2 to 6 locules, and if the diameter is more than 3 centimeter or the cyst is enlarging by a speed of more than 1 centimeter per year. This is an indication for surgery. The EUS guided ablation can be attempted if the patient refuses surgery or if there is a high surgical risk, but the life expectancy should be more than 5 years. It should not be attempted in the moribund patient with the expected survival less than 5 years. And they are the absolute contraindication: pregnancy, coagulopathy, pancreatic necrosis, acute pancreatitis, and pancreatic malignancy are the absolute contraindication. Enhancing moral nodule and significant solid component is a relative contraindication. Similarly, dilated MPD or communication of the lesion with the MPD on MRCP or ERCP is a relative contraindication. And thick wall septa or the thick wall lesion are relative contraindication for the EUS guided ablation. And these are the most commonly used agents. Alcohol with or without paclitaxel can be used, or paclitaxel alone or with the gemcitabine can be used. There is a limited experience with the RFA and the loromacrogol. We will first discuss the first three modalities. So what's the technique? Either the 19G or the 22G FNE needle can be used. If the fluid is thick, we should use the 19G needle. There is a risk of fluid leakage with the 19G needle, and sometimes it's difficult to use in the head region. So once we aspirate the fluid, whole fluid should be aspirated, and we should leave a small rim of fluid around the needle. Otherwise, needle can come in contact with the cyst wall, and there is risk of bleeding inside the cyst. And then there are out of 4 steps. First is the aspiration. We should completely aspirate the cyst, and we should measure the volume. Then we do the lavage. Lavage is done with the alcohol. We leave the alcohol for 3 to 5 minutes. Then alcohol is re-aspirated. If there is a thick septa inside the cyst, we can leave the alcohol for 20 to 30 minutes. And paclitaxel is infused. It's left in situ. We don't re-aspirate the paclitaxel. It is a thick substance. It stays in the cyst. Doesn't go outside the cyst. So it should be left in situ. Alcohol has to be re-aspirated. Otherwise, it can lead to the local complications. So this is a large study which compare this single arm study, prospective study. It evaluated the efficacy of alcohol plus paclitaxel. So we can see in this study, inclusion criteria were confirmed mucinous cystic neoplasm. They aspirated the cyst and did the ablation in the same session. So they involved both MCN and the indeterminate lesions were included in the study. So they were the combination of serous and the mucinous and the pseudo-6. 164 patients, and they used 99% alcohol, which was used for 3 to 5 minutes lavage, followed by injection of 1.5 to 30 mg of paclitaxel inside the lesion. Same session, aspiration and the treatment. Median size 32 centimeter. Most of the lesion were the mucinous cystic neoplasm, but then there were 16 serous cystic neoplasm and the 63 indeterminate lesion also in the study. So this can be a type of over treatment. We are treating the benign lesion also with this strategy. And if we see the efficacy, the complete resolution was defined by 95% reduction in the size of the cyst. It's not the diameter, it's the volume of the cyst, which has to measure by the formula 4/3 pi r cube. If there is a reduction by more than 95%, it's called a complete resolution. And we can see 72% of patients, they have a complete resolution of the lesion. And after 6 years, only 2 had a recurrence. And there are partial resolution or failure was seen in 25%. And 13 patients were subjected to surgery. And out of 13, we can see 7 patients had a complete epithelial denudation. And there were 3 MCN, 2 SCN, and the 6 indeterminate lesion in this study. So we can see efficacy of alcohol and paclitaxel is around 70%, but there is a serious issue of a complication. Mostly, this is a benign condition. We don't want any complication. And we can see there are 16 complications. 1 patient had a fever, 1 patient had a hemorrhage, 1 had a spillage of the alcohol outside the cyst, 6 patients had a acute pancreatitis, 2 pseudocysts, 2 abscess formation, 1 patient portal vein thrombosis. So there can be a serious complication while handling a innocuous benign lesion. And then it was thought that it can be the alcohol may be the culprit. Alcohol may diffuse outside the cyst into the surrounding parenchyma, and it can lead to the local complication. So so we can try alcohol-free ablation of the lesion. This was a CHARM trial. So in this, only the mucinous cystic neoplasm were evaluated. The first aspirated cyst, CA more than 200. Next session, they were subjected to the cyst ablation. It's a randomized control trial, 39 patients randomized to 80%. First arm, 80% alcohol with the paclitaxel and the gemcitabine. Other arm, saline, followed by paclitaxel and the gemcitabine. So second arm is alcohol-free ablation, only mucinous cyst. At 1 year, it's a similar resolution in both the groups. Alcohol-free group 67% and the alcohol group 61%. Adverse events occurred only in the alcohol group, no complication in the paclitaxel gemcitabine group. So it seems that alcohol is the main culprit behind the complication. And the same group, when was followed for the next 5 years, we can see that there is further reduction in the size of the cyst and hardly any recurrence. So do we need the follow-up once we ablate the lesion? So we have a limited long-term data. So there is reduction in the size, but that doesn't confirm there is a epithelial degeneration or epithelial denudation. So surveillance has to be continued once we do the EUS guided ablation. And for the BD-IPMN, there can be occurrence of adenocarcinoma at other site. So even after ablation, we have to follow these lesions for the reoccurrence. And there are case reports of malignancy developing even after the 5 years. So the lifelong surveillance should be done in these patients. So do we have any survival benefit after the US guided ablation? Unfortunately, we don't have any comparative data with the surgery or the long-term follow-up. So we only have the indirect evidence of reduction in the size of the cyst for the evaluation of efficacy. So this is the proposed algorithm. So this may be the future patient having pancreatic cyst. Those who are having symptomatic lesion, they should be subjected to the surgery. Asymptomatic lesion, high risk factor like a mass formation, large nodule, they should go for surgery. And low risk feature, we can do the EUS guided ablation and then we should do the surveillance. So to summarize, EUS guided cyst ablation is an important modality. Only the mucinous cystic neoplasm or the BD-IPMN, they should be subjected to EUS ablation, provided the diameter is between 2 to 5 centimeter and they are oligolocular. So it's difficult to diagnose, confirm the diagnosis. So we have to improve the diagnostic accuracy to confirm the preoperative diagnosis. Alcohol, paclitaxel, and the gemcitabine are the mainstay. Alcohol may be related to the complication. Alcohol-free regime may reduce the complication. They have the similar efficacy and the lesser complication. And we can expect a remission rate of around 70%. Effects are maintained for the long term, but yes, they require the long-term surveillance. Thank you very much for your patient hearing.
Very lucid talk, Dr. Vikas, with very clear message, but the way organizers are looking anxiously at us, we don't think there is any time for question.
Thank you. Thank you.
Thank you.
Thank you.
Conclude the talk.
Thank you, Doctor.
Thank you.
Thank you, sir. Thank you.
I would like to thank the speakers and chairpersons for sharing their experience and knowledge. Before proceeding further, I have an announcement to make. The hotel checkout time is 12 p.m., after which extra charges will be levied. The luggage can be kept at the bell desk. Next up, we have a hot topic for forum discussion, for which I would like to invite as chairpersons Dr. Varun Mehta, Dr. Mayank Gupta, Dr. Saumin Shah, Dr. Itish Patnaik, Dr. Sumit Bhatia. The topic for the forum discussion is ERCP GB stenting versus percutaneous cholecystostomy versus EOS guided GB drainage. When, why, how, and which. The panelists for the forum discussion are Dr. Anubhav Khandelwal, Dr. R.K. Wadhwa, Dr. Professor Kenneth Binmoller. Moderator for the discussion will be Dr. Ajay Kumar.
Yeah, I'll try. I'll try. Thank you, the organizing team, Vedanta team, for this wonderful meeting. Well, friends, we have, as an endoscopist, we always been talking about the bile duct drainage or the PD drainage. This is a relatively new topic to our field, that is the gallbladder drainage. I'll straightway go to the topic. There's a time shortage. I've been already been given advance notice for that. And let's start with a case capsule. 78 years, male, CKD, diabetic, hypertensive, coronary artery disease with a stent inside with a history of TIA. Patients with acute cholecystitis. Patient is febrile, classical pain, febrile, tachycardia, Murphy's positive, oliguria. Patient is in organ failure. Patient has hypotension, azotemia.
Ultrasound shows acute cholecystitis, gallbladder wall edema more than 6 millimeter, and there is a localized perforation of gallbladder. Well, we all clear that this is classical acute cholecystitis. And if we go by the diagnostic criteria of the local signs, systemic signs, or findings on imaging, all fit into that. Now, it is a definitive acute cholecystitis in a high-risk patient. Dr. Vadva, will you take up this patient for surgery, or you will like to consider alternate ways to drain the gallbladder? What's your?
Before I proceed, I would like to assume two things. Acute cholecystitis means you are mentioning that as an acute calculus cholecystitis.
Yes, it is acute calculus. So sorry.
And number two, if he is on inotropes, I'm sure he is in the hospital. If he is come to emergency in this situation, I would like to spend first time in stabilizing the patient with antibiotics and fluid resuscitation. If I don't get an antibiotics and fluid resuscitation stabilization, then I will consider the alternate drainage because of the age, multiple comorbidities, and a very sick patient.
So as you said, that the decision depends upon three broad things: severity of cholecystitis. In this patient, it is a severe by all the criteria. Overall clinical condition of the patient. Patient is in organ failure, multiple comorbidities. We should never forget available local expertise. And that's what the data shows. This is by Todd Barron's article in NEJM, beautifully shown that you have patient who is an operative otherwise, not related to gallbladder, otherwise operative candidate or a non-operative candidate. And the severity of cholecystitis, if you look at this, if you go down, then the only option then you're left with is the alternate to the surgery, there's the conservative. So combination of all this and combine it with the available local expertise, and that's what the Tokyo guidelines tell us, that if you have a grade 1 cholecystitis, you are going for early lap chole. If you have grade 2, then again, if you have here your advanced laparoscopic cholecystectomy technique available in your setup, still you will prefer urgent or early laparoscopic cholecystectomy. But the problem comes here is the grade 3 cholecystitis. And when you have favorable organ, when you don't have a favorable organ system failure, and also the performance status is poor, combination of these two will ask you for an urgent early gallbladder drainage. Otherwise, almost all the patients will go for laparoscopic cholecystectomy. This patient had a grade C acute cholecystitis, poor performance status, and no functioning organ system failure. And decision was taken to go for drainage procedure. And we all know today's topic is how to drain. So we come to the topic whether to do percutaneous, endoscopic transpapillary, or endoscopic ultrasound. Dr. Khandelwal, what are the different ways? Let's talk about the percutaneous before, Dr. Khandelwal being the leading interventional radiologist. What are the different ways that you do percutaneous drainage of gallbladder?
Thank you for the picture. I think that's the two basic ways in which you can do it. One is transhepatic and the other one is transperitoneal. So gallbladder drainage is done under ultrasound guidance, hardly ever requiring the additional fluoroscopy, which is usually done when it's emphysematous cholecystitis. Otherwise, ultrasound is good enough, and the route which is most commonly preferred is transhepatic. And there are various reasons for it. Maybe we'll discuss this in, later in this meeting. So transhepatic is the one which we choose, and it's usually through segment 5. We just take a percutaneous puncture, put the needle inside the gallbladder, and secure the access over the wire, and then dilate the tract and place a pigtail catheter.
So calculus cholecystitis, in addition to that, there are certain other conditions where you do that. In a calculus cholecystitis, an intensive care setting, emphysematous, hemorrhagic, gangrenous, or acute cholecystitis in pregnancy, probably you like to do that. And a perforated gallbladder is the most important thing. So there are hardly any absolute contraindications. These are relative contraindications, out of which ascites comes across as a most important contraindication to this modality. So the technical success, almost 100%, favorable clinical outcomes, 90%. Any of the chairpersons, anytime wants to make a point, please let me know, because I'm just rushing up. I've been told that to cut down the time. So complications are many, but I just for sum up that a significant morbidity, which is basically different requirement of change of drainage tube frequently. It gets dislodged. And the second is the pain. And third is the recurrent cholecystitis, which are very common in this. And 1 month mortality due to biliary complications is 3.6%, and directly related to the procedure is negligible. So Dr. Khandelwal, what are the precautions? Like you have put in a drain, say in this patient, and what precautions, when will you decide that I have to take out the catheter, and what precautions do you take? What steps you take before you remove the catheter?
So the precautions that cystic duct patency is one of the most important thing before we remove the catheter. Second thing is we also want the tract maturation. So usually we like to keep the catheter for up to 3 weeks, if not 4. But 3 to 4 weeks is an ideal time when we expect the tract maturation and minimize bile leak by removing the catheter. So those are the two things. Cystic duct patency and maturation of.
Should all patients undergo cholecystectomy after percutaneous gallbladder drainage, or will you sometimes consider not doing the cholecystectomy at all?
Well, this is a great seg to emphasize that the alternative approaches to cholecystectomy are all complementary. They are not competitive. So percutaneous drainage, external drainage, cholecystoenterostomy, internal drainage, and transpapillary drainage by ERCP are complementary. And we have to individualize for each patient. As to your question, should the patient undergo cholecystectomy? That's a possibility if the patient's status has stabilized and the patient is deemed to be a good surgical candidate, then absolutely. On the other hand, though, I would strongly consider if the patient is deemed not to be a good surgical candidate, despite stabilization, and we heard about all the comorbidities, then I think this would be a situation where we should consider internalization so that the patient has a better quality of life.
Okay. So what is the ideal time for cholecystectomy after this? As you have already mentioned, the patient stabilizes. So after you remove the tube, or you will remove the tube first, or you will go in later? Like,
yes, well, so we just heard that that in terms of external drainage, we should wait 3 weeks. And these rules apply also for internal drainage for a tract to mature. We can certainly do internal drainage within that 3-week period, but we should leave the percutaneous external drain in place for at least 3 weeks so we don't have a leak. I will make one comment, and that is that the evidence is showing that the fibrosis and adhesions that occur after drainage are less when done internally compared to external drainage. And therefore, if the patient actually is considered a good surgical candidate, delayed, that could be an argument for proceeding with internal drainage.
Okay. But in this particular patient, when drain was removed after 3 weeks, so patient became stabilized hemodynamically and organ failures recovered. Of course, patient had a chronic kidney disease. That's not a acute injury. Do you foresee any major difficulties for the surgeon while doing cholecystectomy?
That's to me, by the
Oh,
question
yes, yes.
or to the surgeon.
We are not surgeon. Any surgeon in the audience wants to point out that, we can most welcome. No surgeons in the audience. Oh, well.
I think the feedback I get from my surgeon.
Oh, yes, that's exactly what it
Is
is.
that the issue is leak. And so we heard about the transhepatic approach, and the reason why that's preferred is because the liver acts as a sponge, and like a sponge, it resorbs the bile. There's going to be some leak, but when the leak goes into the peritoneum, it will create a lot of scarring and adhesions. That's when surgery becomes more difficult. So the potential advantage of internal drainage with the LAMS is that there should be ideally no leak whatsoever. And what the evidence is showing now, when patients who undergo surgery after LAMS, is that there is virtually no adhesions. And in fact, if you remove your LAMS before the surgery and you give it a few days, maybe 1 week, the fistula is actually closed, and the surgeon can easily peel off the gallbladder from the duodenum.
Okay, we'll come. Okay. So friends, carry home messages as comes to the percutaneous gallbladder drainage. It's a conventional procedure, maximum publications on this particular modality, used in very high-risk cases of acute calculus cholecystitis, which pose high risk for surgery, not only calculus, even acalculus high-risk patients, and it's widely available. Now, but it has issues, high risk of recurrent cholecystitis, high number of interventions, drain exchanges, and of course, the drain-related issues. Preferred, the key most indication, if you are suspecting perforation, at that time, we are not looking at internal drainages. Stent, US guided modality is absolutely contraindicated in a situation like that. And so it's a preferred in a suspected perforation, as was it in this particular patient. And if patient is unable to tolerate sedation for the endoscopic procedure, we will still go for a percutaneous method. Well,
excuse me.
yes.
Can I make
Oh, yes, please, quick.
I just want to quickly ask Anubhav, whether if the patient is still not a surgical candidate after 4 weeks, what do we do with the external drain? Do we leave it inside, or do we have instances wherein
I think it already mentioned that we can internalize it as well.
But internalize radiologically
No, endoscopically. Endoscopically. Okay. I give you 2 case capsules. 60 years old, cirrhotic, MEL 22, decompensated, gross ascites, coagulopathy, patient develops acute severe cholecystitis. Obviously, not the right candidate for surgery. The second case is it's a slightly different situation. Young patient, severe cholecystitis with a sepsis, organ failure, and associated CBD stone with cholangitis. Dr. Vadwa, what would you like to do in these patients? They may sound different, but when it comes to the management, you may have a different.
I think these are the 2 classical indications for transpapillary drainage. We need to understand that presence of large ascites is a contraindication both for percutaneous as well as an ultrasound, endoscopic ultrasound guided. So preferable method in this is transpapillary. And those, if we are already intervening for CBD, we might as well place the stent in the same sitting in the gallbladder. So these are the 2 classical indications. Other probably is a coagulopathy where percutaneous and US will be a little more cautious, and we will prefer to have a transpapillary in these settings. So these are the 3 classical indications for transpapillary.
Would you like to also simultaneously mention the difficulties faced technically, and what are the technical tips to add into that?
Technically, when I do a gallbladder drainage, I instantly come to know whether I will be having a quick drainage of gallbladder or I may not be. And the cystic duct, if I can see on the C-arm, then I can cannulate the gallbladder. If I have a difficulty or after the injection of the contrast, I can't see the cystic duct, I can't put the gallbladder, that's the time when I have a difficulty. The second time when I have a difficulty is if the patient is a malignant obstruction, has a pre-inserted metal stent. Again, the access to the cystic duct is pretty difficult in these situations.
And maybe we are talking about the transpapillary, because in that case, obviously, you will not opt for this approach.
No, I'm just saying that these are some of the difficult situations. The other thing which I find is if suppose it's a spiral cystic duct inserting medially, then also sometimes you may have a difficulty tracing the guide wire up the spiral duct into the gallbladder. So based on the anatomy, based on the impaction of the stone in the cystic duct, if the stone is tightly or densely impacted in Mersey syndrome, then also you can have the difficulty in gallbladder. So technically, it is probably the most demanding of the three procedures in such situations. How do you cannulate it? As I said, majority of the times, if you can see the opening of the opening of the cystic duct, take your catheter right near the opening of the cystic duct, passing the guide wire is easy into the gallbladder. If you can't do that, then you have the alternative methods of doing the cholangioscopy and selectively cannulating the cystic duct.
Yes, we have been doing that more so, I mean, quite frequently in a post-right lobe liver transplant biliary strictures where we face a lot of difficulties, but the same sort of a problems you use for cystic duct cannulation and quite often difficult cases can be managed like that. Well, so carry home messages for transpapillary gallbladder drainage is it's widely available, but relatively technical challenging, low success rate, and secondly, in follow-up may require stent exchange and a risk of pancreatitis like any other ERCP. Yes, Raj?
I just want to highlight here, generally, I will require a longer stent and I will prefer to place 2 stents instead of 1.
I think they're very good point. Very
one
good.
stent tends to get blocked very easily.
Yes. I think that's a very valid practical issue. These are what the experts mean, that you can get the right practical hits. Put 2 plastic stents. Of course, sometimes even 1 is difficult, but it's preferred when there is an associated ascites. This may become the treatment of choice if you have ascites or associated CBD stones. And that's the reason, 2 reasons with these 2 case capsules, which I pointed out, that's the reason it fits into that. And future surgery is contemplated. It's absolutely no problems with that. And if you have coagulopathy, if you are not doing a sphincterotomy, you can manage that. That come to the last case for the today's this thing. 75 years old, inoperable cholangiocarcinoma, cystic duct infiltrated by the tumor, presents with acute cholecystitis, and has a hugely distended gallbladder. Professor Ken, what will you do in this patient? How will you drain this gallbladder? This is your favorite.
Well, this would be the textbook ideal candidate for internal drainage.
Yes. And which modality of internal drainage? I mean, it's not you will like to go for a endoscopic ultrasound guided.
Yes, endoscopic.
Yes. And when you are on that, when this video is running, this I borrowed from Dr. Sandeep Lattakia, and I'll like to, you like to tell the audience the technical tips and what stent for when you like to have a stomach or the duodenal drainage, and what specific things then should look for so that they.
Okay, well, there's a lot here, but let me first emphasize that we are doing EUS, obviously to look at the gallbladder, but we also see the bile duct. So let's just say that we see a stone in the bile duct. Then I would argue there's actually an indication for ERCP. And then in that situation, why not at the time that you're extracting the stone from the bile duct first, why not try to get a guide wire up into the gallbladder? You're there anyway. And so if you can do
But in this case, you have a cystic duct infiltrated by the tumor, number 1.
Yes, that's correct.
Yes.
I did forget that.
Yes.
You're correct. All right. So now their next question is the type of stent. So I think there, the size of your lambs, and I think a lambs would be the appropriate stent to choose for this. Because we really want to minimize any risk of a leak. So it's not just about the stent itself to have some leak, but it's really the entry into the gallbladder with the hot lamp.
So as we are running short of time, I'll ask you 3 quick questions here. What should be the distance, maximum distance between the gastric or the duodenal wall to the gallbladder?
Depends on the saddle length.
Yes.
So if you have a 10 millimeter, then obviously that limits you, but we also have 15 millimeter length.
Which will you prefer from the patient's point of view? That is a duodenal or a gastric? Provided you have a right distance between the.
Only go transgastric if I cannot go transduodenal.
Okay. So the advantage is the gastric one, food tends to block that very often. That's the reason you prefer the duodenal, but the surgeons believe that the gastric is better because they can close that easy on the table if there is required. And as Ken mentioned earlier, that if you give them enough time, then sometimes you don't have difficulty in closing the fistula. You will just separate them out. That's what you said. But our surgeons are pretty reluctant to take up that because they are worried about the fistulous leak from the gastric or the duodenum. And they feel they can close the gastric fistula faster. So friends, the distance between the lumen and the stent should be ideally less than a centimeter. And lamb is preferred there, and duodenal is preferred over the gastric most of the time, but the key criteria will be where the distance is ideal. So after, okay, so this is I'm not going to details. This is a recent study, they're not so recent, which had compared that in that unresectable malignant cystic duct obstruction, prophylactic gallbladder stenting prevents acute cholecystitis. They were talking about a prophylactic gallbladder stenting. So I carry home messages that in US gallbladder drainage, least number of interventions required. Once you do that, you don't face much difficulties. Can clear even the gallbladder of the stones if from that through the same thing. It requires fistula closure if surgery required in future. Food can block the stent. Large ascites again will be a contraindication in this group because the distance between the lumen and the gallbladder will be high. And of course, you require the right expertise. Everybody does not boast of the expertise of Professor Binmola. It is ideal for malignant cystic duct obstruction, ideal for patients with cholecystitis secondary to biliary metal stent for malignant jaundice. And that's another indication which we did not have a case capsule. There is enough data in the literature. Siddiqui et al. 2019 compared the three modalities, and they have shown that same what we talked about, that the adverse events with percutaneous and the additional surgical procedures or a change of the tube is more common with the percutaneous. Otherwise, so of course, and the success rate is slightly less with the transpapillary approach. To sum up, this is something which is published in as late as 2021, that summary of the whole thing, that it's in a trial comparing the three. US gallbladder drainage is a higher rates of clinical success and low rates of recurrent cholecystitis. And transpapillary gallbladder drainage is the lowest rates of reintervention, lowest unplanned admissions, and lowest mortality. Percutaneous drainage, high rates of technical success, but highest rates of subsequent interventions and highest rates of unintended hospitalizations. And this is the final slide. I hope I have not, I've stuck to the time. And this is a very good, this is published in 2023, last month, in Clinical Gastroenterology Hepatology. This is more like a consensus guidelines. And if you can go through that by Shyam Irani et al., that if you have an acute cholecystitis, poor surgical candidate. So the first thing, the key point is poor surgical candidate. And if you have a perforation suspected on imaging, patient unable to tolerate sedation, you go for percutaneous transhepatic gallbladder drainage. There is no perforation on imaging and patient is able to tolerate sedation. If you do the transpapillary drainage initially in patients with uncontrolled ascites, potential future surgical candidate, undergoing ERCP for other reasons like CBD stone and cholangitis. Gallbladder more than 10 millimeter away from the GI tract wall. And a gallbladder, and if in this patient, if it fails, then you go for US guided. And if it fails, then of course percutaneous. And you will select US guided drainage initially in a duodenal obstruction or a gastric outlet obstruction, indwelling metal stent occluding the cystic duct, or there is a growth which is obliterating the cystic duct and a large stone burden within the gallbladder. And if it fails, then you try transpapillary, and if it fails, go for percutaneous. I hope the panelists and chairpersons agree with this final approach. Thank you very much. If the organizers allow, we can allow one or two questions, otherwise, yeah. Two questions allowed. Anybody, these experts are there. Questions will not be answered by me. They are there to answer the questions. And if the chairpersons wants to put that.
Professor Binmola, is it your preferred approach in patients who have benign conditions, just acute calculus cholecystitis, to go ahead and put in US lamps Will you prefer that or will you go in for an alternative kind of a drainage if the need arises?
It's a loaded question you're asking, and we're trying to answer that now, and we definitely need the randomized controlled trials to give us an answer. But I will say this, the one person who is not in our panel here is the anesthesiologist. And again, to emphasize, these alternative modalities are all complementary. So very often these patients are so sick, they will not tolerate what's called sedation is with us, propofol, general, even general often, because there is a risk of aspiration. So that will often dictate that the patient should undergo percutaneous, which can be done at the bedside under ultrasound guidance and with just local anesthesia. So that's amazing. So that's always something to keep in mind. And you can always then later convert to internal drainage. But yes, I developed LAMS actually to save the gallbladder. And I feel if the gallbladder is otherwise healthy and the problem is just stones, which is an epiphenomena, if we can treat the stone disease and provide an alternative pathway for bile to drain so that stones will not recur, resulting in the need for cholecystectomy, I would prefer to save the gallbladder.
While you were asked this question, there is a single controlled trial comparing the US guided gallbladder versus surgery. It's not, I've not taken up that because right now that's not accepted. It was published last year and results are, but then it's very too early to say a small number. You have to have a much more data for that. Well, friends, if there are none, I hope you enjoyed the discussion and thanks everybody for active participation in that. Thank you very much.
After dealing with the elephant in the room with such intense and powerful discussion, let's now proceed for live demonstrations with a working tea break. For the first live demonstration session, as experts, I would like to invite Dr. Manish Agarwal, Dr. Varun Gupta, Dr. S.R. Mishra, Dr. Sandeep Pal, and Dr. Gopi Shrikant.
Am I audible in the hall?
Yes, sir. We are ready, sir. We are ready.
Yeah, good morning, everyone. And we are starting the live demonstration from Medanta Endoscopic Suite. And we are going to demonstrate 9 cases, bilateral hilar cholangiocarcinoma. We are going to show pancreatic RFA. We are going to show the gastrojejunostomy by the freehand technique, coil and glue in the fundal varices, and so on. So I request Dr. Bimal, my colleague, to start the history with the first case, which Professor Dr. Nageshwar Reddy is going to demonstrate. So I hand over to Dr. Bimal, please.
Thank you, sir. Good morning, everyone. So our first case is 66-year-old male without any comorbidity, presented with pruritus, jaundice, and clay-colored stool, with significant loss of weight and loss of appetite. On PET CT, it shows a FDG-avid hypoenhancing mass in the pancreatic tail with mass at the hilum. USFNAC of the pancreatic tail mass revealed adenocarcinoma. His bilirubin is 24.4. So the plan MRCP shows type 3 hilar block. Plan is CBD cannulation, biliary RFA, and bilateral SMS placement if possible.
Hello, can you, yeah,
Ready, sir.
be on the screen?
Yes, sir.
Can you let us know who's moderating?
Sir, Dr. SR
I
Misra.
think you have to be louder. You're not very loud, so we have to be louder.
Sandeep is there, sir. Sandeep, please talk.
Because Sandeep, what? Sandeep, there's so many Sandeeps now.
Sir, Sandeep Pal.
I'm Sandeep Pal, sir.
Oh, Sandeep
From
Pal.
Kolkata.
Yeah, Sandeep Pal is very recognized. Okay, Sandeep, so this is a very interesting case. But before we start the case, let me introduce all the people around here. The anesthesia, we have a very competent anesthetist here who's helping us with anesthesia. Your Pankaj, yeah, Pankaj is helping us. And of course, the most important person here is Bhagwan, the God. So he is helping me with the accessories, and therefore I'm very comfortable that he is here. Mohit is assisting him. But again, I'm supervised by Saurabh, who's going to tell me right, left, which way to go exactly, so I don't make mistakes. Behind him is Telpati, behind him is Mohan, behind him is Philip. So that's a huge army of people here. So hopefully we'll succeed. And now this case is, again, I'd like to congratulate Rajesh for putting up this fantastic show. Very nice cases, and of course, all the debates that are going on. Now, this case is interesting because if you've seen the MRCP, you'll notice that one, there's a pancreas divisum. The second is the lower end of CBD is little narrowed, and there's a very flat papilla, indicating that there are going to be certain difficulties when you're going to cannulate. So for cannulation, I have taken, of course, we're using Olympus 180 scope. I'm using a Boston spintrotome, and in the Boston spintrotome, very wisely, Bhagwan has actually put in a angle pterymo wire. Always difficult cannulations use an angle pterymo wire because that helps you to get in the lower end. So we have already gone down into the duodenum. I'll get to the papilla now, and then we will see the papillary anatomy first.
So we don't have the image, endoscopic image we don't have.
Yeah, so can you have the endoscope image?
Yes, sir, now you got.
Okay. So now what I'm doing is slowly pulling back. Can you see the fluoro also, Sandeep?
No, we have not got the fluoro, only
Now?
endoscopy. No, no fluoro.
This is very important to have both when you're doing.
Can you have the fluoro also?
Okay. So fluoro is there, see?
Yeah, but we lost the endoscopic image now. So we want both fluoro and the endoscopic.
Yeah.
Yeah, okay. Now we got it. The
Fluoro, endoscopy, me and Bhagwan on the picture.
You are lost now, sir. We can't see you now.
Yeah, that's problem. Now we have to have all. So some way they can put in all the people. I don't want Bhagwan to miss it because it's very important. Because hand movement, you have to keep watching. Pankaj, maybe little Buscopan you can give. I'm asking Pankaj to give Buscopan. With elderly, we give glucagon because you can see the contractions that are going on. Okay. So shall we start? Are you getting all the pictures?
Yes, sir. Yes.
Okay. So now I'm right in front of the papilla, and it's very important that you study the papilla a little before going in. See, I'm just studying the papilla carefully. I'm also looking at the fluoroscopic picture to show that I'm in a J-shaped manner so that it's in a correct position, not long root. There's a lot of contractions. So I've asked Pankaj to give Buscopan. Now, if you look at the papilla, you can see that the papilla has got a very short hood. Papilla are divided into 4 types: type 1, type 2, type 3, type 4. Type 1 is a very small one. Type 2 is the optimum one like this. Type 3, you have a very long intraduodenal segment. So these are the different types of papilla, and the difficulty is based upon which type. Now in this thing, the good thing is you can see some bile coming in. You can see an orifice on the top with papillary projections. Can you see that, yes. Sandeep?
Yes, sir. Yes.
So that's an indication that probably that's a bile duct. But the bad news is that the lower end of the CBD is very narrowed. So if I can't get in very easily after 2 or 3 attempts, I'm going to the pancreatic duct. I will then put in a pancreatic stent and do a pre-cut, because this can be, a pre-cut can be done. So I'm getting in with my spintrotome, which is, I said, a Boston spintrotome. I'm going a lot of contraction. Pankaj, again, Buscopan.
Can we have the endoscopic image enlarged, please? Now here the fluoro image is enlarged. Can we have the endoscopic image enlarged? Yeah.
So Buscopan is given, so how do you know what happens? Anesthetist often tells us, I give in Buscopan 2 ampules, 3 ampules. One of the ways to know whether Buscopan is acting on, look at the heart rate. It's 78. That means something wrong. You have glucagon, yeah. You have that? Yeah, can you give that? Because heart rate 78 means either the Buscopan is not working or this is some other this thing.
So expect the heart rate to go up?
Yeah, that little go up at least, because there's always conflict between an anesthetist and me. I say, no, Buscopan is not acting. He'll say, I've given 2 ampules. But then when you look at the heart rate, you know who's right. So in this case, the heart rate is low, same as it was before.
So, yeah. So Philip has come up with suggestion below. So much of contraction. I don't want to unnecessarily poke the papilla till we get a calm feel. Importance in endoscopy, yes, especially, I think Saurav will agree with me, is that everything should be calm, quiet. There's no hurry. There's no time pressure. Things should be done in a proper way, because once you do it wrong and produce pancreatitis, that's it. That rest of the one of the fortunate thing for this patient is pancreas divisum. So if you produce pancreatitis, you are a really bad endoscopist. So we'll give a little glucagon now, and okay. Now I come back to the papilla. Yeah. So now I'm getting a good picture there. I'll put my spindletome out, and then you see what I have to do is to cannulate that portion which is spouting out there. Okay. Saurav, this is the portion. No?
So do you have any preference for any sphincteromes, or doesn't matter to you?
Doesn't matter actually. Whoever is sponsoring, I use that particular one. So now I'm trying to get particularly into that area where we'll see whether Bhagwan prayers that helped us. Bhagwan, I think you're in the PD or in the CBD. Can you? No, no.
We have fluoro image also in large.
You feel it's CBD? PD. Bhagwan says PD even without fluoroscopy. So let's see. Fluoro, please. Okay. So we seem to be getting into the
coiling
in the PD. So one of the things I'd like to do at this stage is come back a little, and I'll inject some amount of I'll come back, take off the spindletome completely, take off the guide wire completely inside Bhagwan. Guide wire. Huh? No, not in this. In the guide wire, in the MRCP, it looked like that. So that's why. Now try once, and if you don't, we'll inject some. So I'm going. See, I twisted. I twisted it, bowing it a little up towards 11 o'clock, 12 o'clock position. And now let's see what happens now. So this is a curved wire. So Bhagwan is also twisting it a little. I'm giving a little right and left movement to that side. See, you can go in now. Right and left movement.
So what's your threshold for putting a PD stent?
Three times. I do, yeah.
Is the risk
I
of
do 3
pancreatitis
times.
more by injecting into the PD during cannulation?
So now at this stage, we'll put in a little contrast, Bhagwan, small amount of contrast.
So
no, that's PD that we're getting. So again, I come back, I'll go again above. Just at this stage, Bhagwan, what we'll do is I'll bend the spindletome completely, and then. So Saurav, any mistakes you can correct me. So I'll bend the spindletome completely, and then ask Bhagwan to try and pass the guide wire again. So now I keep it here. Now Bhagwan, can you bend it now? Bend the spindletome, bend. Yeah. So I bend it completely. Now it's in an angle which is towards the CBD.
we can see the intraduodenal portion of the bile duct just up there, no?
Yeah, just the small portion you're seeing.
Yeah.
So I'll see if I can get through now. Can you get through now, Bhagwan?
So typically, I think biliary stones are sort of relatively easier.
Easy. Hilar obstruction, always there is a problem. There's a problem because of this problem.
Right.
And this is good because then you can show different techniques.
Yeah.
Fluoro.
You're nicely engaged though.
Yeah, it looks very nicely engaged, but the problem, of course, is that the lower end is very narrow. No, Bhagwan, you're not going. So what I would suggest to come out further.
So does changing the scope position help? Like if you go in a long route position?
Yeah. So that's a very good suggestion. That's what we're actually doing now. So we're thinking alike actually. So now again, I'll go this way and then try, and now Bhagwan, now see. We can, this time the wire is going into the pancreatic duct. I'm going to put a pancreatic stent.
Okay.
And then do a spindletectomy.
And are you concerned about edema, which may happen if you inject too much contrast?
Yeah,
while you're
exactly.
trying?
So I don't want to do that. I'll go into the pancreatic duct. And fortunately, it was not a divisum. Initially, I thought it was a divisum, so it'll be difficult. But because it's not a divisum, screen, fluoro, please.
You're going somewhere.
Yeah,
that's nice.
Yeah,
That's
go.
fine.
Now, exact. Now, see. No claps from there. I can only hear clicks. Yeah. Okay.
Good.
So it was a series of different movements that we used. And because we have Bhagwan here, he's already answered our prayers. And he knew how to handle this wire. How to twist it. So, okay, now the next important point is I don't do anything till I go very deep inside. Okay. So now take out the wire and see if we can go selectively into right or left, whichever doesn't matter. Left is preferable if we can get into, but even right is okay. So selective cannulation we'll discuss a little later, but right now we have to go above the obstruction into one of the ducts. So I don't want to inject till we are above the duct. We're going into some duct there. Probably the right anterior, Saurabh.
Yeah, looks for right anterior, but I think we are, yeah, that's it. I think that's right anterior.
Yeah, that's right. And no,
be
this
left
may be
also.
left also. Yeah.
Left,
So this
yeah,
is the problem with the ductal anatomy sometimes. Okay. So what we'll do is we'll now, because we're deep inside, we'll inject some contrast, Bhagwan.
Sir, is always your preference to inject contrast or air cholangiogram? When do you do, sir?
I prefer contrast. This is the left. Nicely, you can see all the segment and some way. Yeah. This is a abnormal anatomy. So what we'll do is we'll leave the guide. So what I suggest is you change the guide wire to a long guide wire. We'll come back later. We'll get the anatomy. Patient is flat. I want to be sure. Sometimes the anatomy is not very clear. We can get the patient onto supine position. So it may be that left is definitely seen very nicely. It may be a very large fourth segment 4 which is seen. So I'm now in. I want to now see if I can get into the longer segment, that large segment there. Oh, okay.
So why
can
do
you put
prefer air
more superior
instead of injecting the contrast to decrease the chances of cholangitis?
Segment 3, yeah. Inject. Yes, I didn't get your point. What were you saying?
So the question came was that is air cholangiogram a better option to prevent cholangitis later on, or in a bile hilar block, we should there is a school of thought that contrast should not be injected higher up.
Yeah. So yeah. Okay. So okay, that's a point. Good point to discuss. There is a study, I think, which came from Randir's unit only, which showed that air cholangiogram may be better in terms of decreasing the cholangitis. The problem with the air cholangiogram is the quality of the picture is not so very good. You must have a very, very high standard fluoroscopy to actually get a very high air cholangiogram. So I think air cholangiogram in general, in our experience, has not been very good. Whereas with contrast, there are no large studies showing a difference in terms of cholangitis. But because we are going to stent all these cases, I don't think cholangitis is going to be a problem at all. So we in fact did a small study where we looked at the differences. When we are doing adequate stenting, there's no difference at all.
Right.
So I prefer that way to get a good picture.
You're getting good drain. I think the other thing is, in this case, you're doing RFA, so it'll be nice to have a clear
Good picture of
delineation
where the upper end of the segment
picture
is.
as well.
So now what I'm going to do, I'm going to do a sphincterotomy. We are going to do a sphincterotomy standard technique. And what I'm doing is the camera can focus on me and my hand here. I am now holding sharp. Can you see me? Sandeep, can you see me and my hand?
Yes, no. Yeah, we can see your hands, yes, sir.
So I put the elevator up of the sphincterotome. I'm using the right and left body movement. I'm using the shaft is in my right hand, and I'm going to put an endocut current. And then I'm just moving lightly to the left. See, I'm doing a very little movement there, slightly to the left. And then I'll just move up and down, and then I will require a little more smaller cut here to open it. That's enough.
It's a nice demonstration.
Okay. Yeah. So this is completely cut now. So what we'll do is, once this is over now, I'm going to re-put the sphincterotome and get into the second duct. And as we do that, maybe if Rajesh wants to move to another room, because he wants to show 10 cases today, 9 he said, but I think 10 can be shown, so that we can have more variety here. So I'll put in a second wire just to show you the technique of the second wire. You can see the anatomy here. I think what has happened is that although the MRCP shows type 3, it may be even type 2 evolving into 3, because what I'm seeing in the big duct there may be a right posterior duct, and I'm seeing a faint anterior duct. But anyway, we'll go selectively. So Chalpati, I think it's maybe the anatomy is a little different. Yeah.
You want to take few more minutes, or should we shift to the another room?
Just to show them how to cannulate the right side, and then we'll shift to the next. Okay. Just 2 minutes. Yeah.
Okay.
This is a thermo or regular wire? Thermo. Okay. So again, we are putting back a thermo, and then I think we will go to the right side. Now the technique of right side is easier than the left side, because you just have to hook very close to the right side. You should not hook down, because then you go, okay, so.
oftentimes the right posterior is the most
Difficult one,
challenging.
challenging
Also
one.
to stent it as well.
Yeah, you're right, Saurabh, because keep going, keep going, keep going. I think you're in the right now. No, yeah, so that's where the
Can we have
narrowing is.
fluoro image.
Fluoro, can you enlarge that fluoro there? Yeah, going to the right. Now see?
Oh, nice.
Yeah, see that? Where the right. So the technique here, yeah, this time at least some claps locally.
Yeah.
But I can't hear from the hall. So the technique here is that we don't bend the sphincterotome. Paradoxically, unlike going to the left where we bend the sphincterotome, you should not bend it. Goes to the straight sphincterotome up to the point where the junction is, and then what we'll do is we can get the wire in, and preferably use a straight wire for this, not a curved wire. So some resistance for the thing going in because the tumor is there.
Thank you, Dr. Nagi.
Sure, thank you.
Going to the room number 2.
Yeah, so we'll keep the RFA ready so that you don't waste too much time. And
Professor Anthony. Professor Anthony, room 9. Hello. And I'm presenting the history.
Yes.
A 53-year-old female who is diabetic, known case of chronic liver disease, portal hypertension, and had a GI bleed. EVL was done 3 times, thrice in April, March 2023. No history of jaundice, ascites, hepatic encephalopathy. Her liver parameter shows SGOT and SGPT were high. Ultrasound shows coarse ecotexture with a portal vein of 13. Viral markers was negative. ANA is positive. Now, etiology-wise, we are not sure because the complete workup was negative, except that patient has an ANA positive. The plan is to do the EUS-guided liver biopsy and the portal pressure measurement because patient has bled twice in spite of adequate beta blocker and endotherapy. Over to Dr. Anthony Theo.
Hello, so I have Sandeep with here right now. So the plan for this patient is to do a portal pressure measurement with the new device, followed by a liver biopsy. So do you have the endoscopic image?
Yes, we have that.
I'm just gonna hope to try to quickly let you see the lower end of the esophagus, which we haven't seen yet. It's right here. Maybe small varices. And we could quickly screen with the EUS. I don't see, maybe just some right here. These are some portal venous system right here. All right. So to do a portal pressure measurement, we need to measure the pressure at the left portal vein as well as the hepatic veins. So there are various ways that you can access the portal venous system, either the left or the right. So the difference between the main portal vein and the left portal vein is actually quite similar. So it doesn't really matter where you measure. For the hepatic vein, if you do it transjugularly, they usually suggest to measure at the bifurcation, like 1 to 2 centimeters from the bifurcation. For US, we can access many parts of the different hepatic veins. So from my experience, it doesn't really, again, make any difference on where you measure. And sometimes because of the liver anatomy with cirrhotic patients, they change. So some parts of the liver may hypertrophy and then they may be very heterogeneous. So the anatomy will be different. So sometimes we may not be able to access the hepatic vein totally. So we can also puncture the IVC, which is through a hepatic way. So the most important aspect, when you puncture the vein, you have to go through the liver parenchyma. And the liver parenchyma acts as a tamponade and helps you to prevent bleeding from the puncture site. So my scope is in the OGJ level. You can see the liver right here. So if you're not sure, you can always trace the portal vein from the neck of the pancreas, which is around here. So here is the neck of the pancreas. You can trace the portal vein. And all the way here, you can see the main portal vein entering the liver. So we can measure the size of the portal vein first, around 1 centimeters. And then from here, we can also measure the distance from the liver parenchyma around 3 centimeters. Can we take a picture? So this is the main portal vein. If we trace the main portal vein, it should bifurcate out right here. But here in this patient, the view is not great. You can see the left portal vein here trying to bifurcate out, but we are encountered with a atrophic left lobe. Here, you can see. The ducts are a bit dilated with the main portal, the left portal vein around this area. So this is not a great position for puncturing. There isn't much liver parenchyma. So in this level, maybe the main portal vein is a good target for puncture. And we go to the remaining of the left lobe of the liver. So right here is the IVC. So if we do have to puncture, we can go through the intrahepatic portion of the IVC. Let's measure this distance. So this, we have a significant amount of liver parenchyma. So we can puncture through this and still get a reading from the systemic pressure. And if we trace the IVC, you can see the first branch. It's quite far here. It is the right hepatic. And if I talk left, this is the middle here. And I've talked left some more. This is the left hepatic. So not much parenchyma again around here. And the middle hepatic right there is quite far. Can we measure this distance from the okay, it's 6 centimeters. So not 100% sure I can target this, but yeah. So we can target somewhere around here maybe, but it's very far. So we can try once. If we can't get into the vein, the middle hepatic vein, we can puncture the IVC, which is right here.
The IVC looks very exciting and very close by.
Yeah. But the IVC, I'm sure I can take it. But we can try once. Okay. And then we can always go to the duodenum because we can access the right system. So here is the main portal vein. Sometimes we can have a nice target of the right, branching around here. So you can see the gallbladder, which is right here. And then the right portal vein is around this level. But unfortunately, in this patient, the right portal vein doesn't look very good. And we can take a look at the IVC. Sometimes we can see the right vein.
Is presence of ascites can cause some problem while measuring the portal pressure gradient?
If patients have ascites, they are not indicated because they have a definite high portal pressure. So we will try not to measure those with ascites. You know, child C cirrhosis, we would exclude. So child's AB, where it really makes a difference, we would include. So we cannot see the right portal vein from the right hepatic vein from this area. So not much choice in this patient. Let me see here one more time. So I'm in the stomach right now. Might be a hepatic bunch. Not 100% sure because you need to trace if possible. Yeah. not 100% sure. All right. So in this case, we have some anatomical constraints. So I would try to puncture once for the middle hepatic vein. And if it doesn't work out, then we can puncture the IVC. Okay. So can we have the needle? So this is the pressure gauge measurement. So it's attached with a tube all the way to a 25-gauge needle. We prime the entire system with saline, and then we stick it at the right atrial level. So you can zoom out. We stick it around here. Tape. Sorry. Maybe like this. Tape. 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 Yeah.
One of the syringe?
Yeah, on the syringe. Yeah. Is it okay? It just needs to be stable, fixed. Yeah. Thank you.
Pressure is moving too much.
Yeah.
Okay. Okay, now you fix it.
Now we fix it. Okay. And we can flush it a little bit. Mhm.
Want more flash?
It's okay. It's okay. Yeah, it's okay. I think it will. Okay. So before starting, we need to just fix it. It's just a tape. Really far. So I need to target the middle hepatic vein, which is here. Yeah. I don't know, man. It looks very far.
IVC straight away.
Yeah, we could do IVC.
I think let's do IVC straight.
Okay. To save some time, we can do the IVC first here.
It's almost equivalent pressure. as-
Yeah, just. All right, so you can see the IVC right here. I will overshoot a little bit first and then pull back.
Yeah.
Okay, I'm in. Can we flush? You can see when we flush, the fluid is in the IVC.
What is the size of the needle you are using?
25 gauge. So once you flush, I will flush a bit more because during my puncture, sometimes the liver tissue is stuck at the tip. It's just a normal saline.
Can we have
And
the
then-
picture of the pressure management measurement? Can we have that?
Cameraman, can you focus this? Thank you on this.
And then we wait for around 1 minute
Yes.
It measures 23, 22.
to stabilize. So you see it's quite sensitive. When I move the needle around,
This needs to be at the level of the heart or something. Like where do you place this?
Right atrium.
yeah, we're at the right atrial level. So you can see it's moving a lot. It's because maybe the patient is moving. The breathing is moving. I'm going to withdraw the needle slightly.
Not much. It's 17, 18, 19 every day. 15.
So it should stabilize in one level without moving.
So which number do you take after waiting for 1 minute? Number that you get, like which number do you take?
We wait till it's really stable. So now it's
That's 17.
stabilizing. So this is, if you remember your physiology, when you breathe, there is a diurnal rhythm. So it actually moves up and down, and the pressure gauge measures the average of this movement.
It's between 17 and 18 now, almost.
Okay, we'll take it for 17 and then you flush it one more time. We'll do this 3 times.
So you take average of 3 readings?
Yes, correct. Yeah, I saw it.
Yeah. The tip has to be within the lumen and not.
Yeah. So for, yeah, it moves with respiration. So for this vein, it's easier because it's a big vein. Sometimes the hepatic vein is like 4 millimeters. So with each breathing, sometimes the tip is inside the parenchyma. So you need to take some averaging.
Is it the average of the various readings, or is it the most frequent reading which we see, and more the reading which is persistent for the maximum time that we take?
Average of 3 readings.
Average of readings.
After 1 minute each of stabilization.
Yeah, keep the needle in the same position.
There's no point making 3 punctures. 14.
Yeah. So sometimes the first reading may be a little bit off. So we measure until we get a good pressure. Okay, can we flush one more time?
3rd time flush.
Yes, yes, correct. So now it's around 14, 15. So usually it's very accurate. It's around 1 millimeter mercury for difference in each readings. Okay. So if we take this 14, we'll do one more time. For reading, yeah. So we'll take the 3 closest one.
So how do you reset the value? Just to push in some saline inside the IBC, like how we are taking new readings?
Push in the saline, and then the pressure will go up. So for the last 3 readings, it's very similar, around 14, 15.
Can you see the gauge there on the screen? 15.
Okay. Okay, now to 14.
Don't take the best. Don't take the best.
Yeah, when I do this measurement, I try not to breathe as well.
That holding time must be good.
Dr. Sandeep,
Yes, Rajesh.
can we
Hello?
shift to Dr. Nagi room?
Yes, yes.
Yeah, shift to
Okay,
Dr.
So you are with us now?
Just 14.
Yeah.
Okay, yeah.
Should we
So
show how
what
the
we
needle
thought
come
is briefly, we'll just spend 2 minutes, you can go back again to show you what we did was we
we
used
show
the
needle coming
radio
out or
frequency
wait?
ablator catheter. This is ELRA catheter,
Okay.
which comes from StarMed. Can you start it now? So we have put this catheter in
we
different
pull
segments.
this
You're showing the
out
last
under
segment now.
US.
You can see that the
The
wattage
Doppler.
is 10
So
millimeters,
make sure
10
there's
watts, but
no
it's varying now.
tracks.
The time is 2
Overlapping of
minutes.
voice, we can hear 2 voices.
If there's
Can you
crack,
now?
leave the needle for
I think you have to put one voice. Huh?
We can still hear
Okay.
Dr. Anthony's voice.
Anthony is very loud. Sometimes you can hear him from Hong Kong also. Yeah. Okay, now it's better?
Yeah, yes, sir.
Okay. So we watch the generator. I put the catheter inside now. I'm at the site of if the fluoroscopy can also be shown. I'm at the site now of the fluoroscopy. Is Saurabh is seen? So fluoro is on. You can see the fluoroscopy now. I'm exactly at the site, lower end part of the stricture. You can see those rings, 4 rings there.
Yes.
So it gives a 2.5 centimeter burn. We did it up also, but just observe the generator. In the generator, there are 4 things. One is the time, 58, 59, 60. That's important. 1 minute. But the wattage was kept at 10, but now it's fluctuating 0 now. So it doesn't matter. Wattage can go from 0 to 11 to 12. And now it's 9, 12 also. But look at below. That's the most important. Temperature. Temperature should be between 75 or 70 to 80, typically around 75. This is the best temperature. It's slow cooking, produces coagulative necrosis, and all the benefits of RFA. Also, on the top left, you are getting impedance. Impedance should not go very high, above 100. So all this is a very intelligent machine which controls everything. And that's the reason why, compared to older machines, this is a much better machine. It controls everything now. And you see, we are done 1 minute, 40 seconds. We are continuously keeping the temperature at 75, 76, because if we go too high, you produce charring. This is the optimum temperature.
So
The
do you
voltage
have different settings for intrahepatic and the CVD? The
The
intrahepatic.
right hepatic duct has sometimes decreased the setting and keep only 1 minute, not 2 minutes. Now it's over. 2 minutes, okay, and then everything is set now. So I'm going to withdraw this catheter, and you can go to another room and come back. We'll just dilate both the ducts and keep it ready so that we can show you the final stenting. Rajesh, you want to go to Sandeep's room?
Yeah, we will shift to the room number 2. Anthony Theo room. Yeah, Professor Anthony, you are online.
So we have removed the needle from the IVC. So on removal, we should do it under Doppler ultrasound. So anyway, we will show the measurement of the main portal vein now.
Dr. Anthony's voice is not audible.
Hello, hello, hello.
Hello. Have to
Hello,
speak
hello.
a bit loud.
Hello, hello.
Yeah, it's okay.
So we will puncture the main portal vein now. So just now we have removed the needle from the IVC under Doppler ultrasound. We will show again later. So here you can see my needle going in quickly. So pretty sure it's in the main portal vein. We flush again.
Can you show us the picture of the readings?
So it's okay because once you flush, the reading go up. So you can see now the reading is going up.
No, it's not visible here in the hall. Can you
No,
focus
you
the
locked it.
camera?
You locked it.
Cameraman, please focus the manometry.
Yes, fine.
So you can see the reading really going up. Just now it's 14. Now it's like 38, 37.
Can you see that? 34, 35.
This is you have to keep it closed or no, this is this side is closed. This is locked here.
Lock, side port. It's got stuck there.
Yeah. Okay, so around 34, 35. Okay, let's take this 35. Okay, flush one more time. So the difference between 35 and 14 is 21. This is very high. A normal pressure should be this side is locked.
So Professor Anthony, we are going to the room number 3. And when you come back for the liver biopsy, we will show.
So it goes up.
Oh.
I've got it.
Okay, so you can hear us?
Yeah, we are showing the history, Professor, just for a minute.
Okay.
So
This gentleman presented with significant loss of weight for 3 months.
So a young boy presented with a history of weight loss, low-grade fever, night sweats. His CT shows a multiple mediastinal and intra-abdominal lymphadenopathy. These are the image shows the large lymph node, both abdominal and mediastinal. Plan is to do the EUS guided lymph node biopsy because we have a suspicion of either tuberculosis, sarcoidosis, or lymphoma. So over to Professor Mustafa for the demonstration.
Okay, good morning, everyone. So again, it's my honor and pleasure to be here and to perform this case under the supervision of Dr. Philip. So I started my examination. Now I'm 40 centimeter from the dental arch. I'm using a linear scope from Olympus, the UCT 180. You can see this is the aorta, and we start to have a small lymph nodes here para-aortic. I will do the examination very slowly. Again, I'm descending down just tangential to the aorta. Again, another lymph nodes. And then I will just, yes, you again, yes, the pointer is here. And then again, smaller lymph nodes. And then I will push a little bit. So this is the area of the head of the body of the pancreas. Again, you can see a lot of lymph nodes here downstairs. So I will follow the body of the pancreas, rotating my scope clockwise. There is nothing in the pancreas. So the pancreas for me is clear till the tail, till we are here at, so this is, we have the left kidney and we have the spleen hilum without also any splenic lesion. So till now, we have multiple lymph nodes, different sizes. We have nothing in the spleen, nothing in the pancreas, and nothing also in the left kidney. So I will continue, but yes, please.
Dr. Mustafa, how do you select the lymph nodes if there are multiple lymph nodes? So which
I
one
will,
you target?
I will select the easy one. So I will
Easy
select
one or the largest one?
the big one, and I will avoid any lymph node with central necrosis.
That
This is
also quite
this is
important.
yeah, this is important. So I think we have here we have a lot here to puncture. And then I will also continue my examination, just checking also the liver, the left lobe of the liver.
One minute, I would like to introduce our anesthetist, and the patient is on IV propofol. Dr. Anu is here, and the technician is Mr. Manoj.
Yes, we have the dream team in the room. So again, I will go now. So I finished here in the first station what I would love to see. So I have multiple lymph nodes. I will select one of them, but I will go to have another look here in the first part of the duodenum. So I'm now in the first part, and you can also see here we have a very big lymph nodes. Just very close to the portal vein. A lot of them. There is another one here. So my first suspicious with the history was being a very young patient with the night sweats. And this is also very, so for example, just an example, this is a very good lymph node because you don't have any central necrosis
There is no necrosis in this one.
to puncture. However, always if I have the option to choose from the gastric station or the duodenum, I will go for the gastric because this is the scope is straight. We have no of anything. So I will puncture this one. So this is the first one. So I'm using.
This is a fairly large lymph node.
Yes.
Do you want me to?
Yes,
measure?
please.
So sonographically, what do you think? What is the what can be the cause?
I will vote number one for TB. Personally, in Egypt, if I will be able to do this, I will do contrast EOS. This will help a lot when you see when you can you differentiate by lymphoma.
Nearly 20.
Yes, for 1 minute, we are going to Dr. Anthony Theo because he want to withdraw the needle. We are coming back within 1 minute.
Okay, I will wait.
So over to Professor Anthony Theo.
Okay, can you hear me?
Yes. Yes.
So I'm going to pull out the needle.
Stent ready now. Open.
So you can see the
Yeah, left.
guidance. And if there is no tract within the needle tract, then you can withdraw it slowly. Usually there's nothing.
So what do you do if there is a track? If you see a track, what do you do?
Then you keep the needle there for a bit longer, like 30 seconds, a minute.
Meanwhile, we just show the recording that we've got. Gentleman can focus that. That's Radhika's
Okay.
handwriting.
So I think that is the reason 31 portal pressure is very high, 21.
Yeah.
And that's why patient is not responding to the endoscopic therapy.
So anything more than 10 is already portal hypertension. And if it's more than 12, the risk of bleeding is very high. So right now, you can see no track. So I'm happy to remove the needle altogether.
So
All right.
thank you, Professor Anthony. We are going
you.
to Professor Mustafa room. Professor Mustafa, yeah, you can go ahead with the biopsy.
I'm using 22 FMB needle, the acquired needle from Boston Scientific. So you can see this is my target lesion. I'll put first, so we don't have any vessels on my way. So normally I'll just open my elevator a little bit to push the external sheath outside, pull it back, just to have the tip of it only, and then I will fix it. After that, I will pull the stylet for just a few millimeters back, open my needle, and I will start. You can see now my needle coming. I will aspirate, suction, suction, suction. No, wait. So it's very soft.
Can you see the needle sheath is coming there?
Yes, it's here.
Sheath, you know?
I will
You're
just
trying to puncture?
rotate a little bit.
Yeah.
Like
Let's see the
this. This is the needle. Yes.
Yeah, it's going
And I'm inside now the lesion. So what I will do always the slow pull. So you pull very slowly.
You have to push the stylet first.
Yes, push it. And then I will do the slow pull. So I'm making my movements very slowly, while here he's pulling back the stylet. The stylet.
Expanding technique also.
Yes. So what we can do also that we can always change our direction by the big wheel like this to have it from another parts of the lymph nodes. So the good thing of FMB needles like this one, you really don't need to move a lot. So normally I do 4 or 5 movements, and then we stop. So I pull back. So in my home,
How many actuations you have done?
how many?
How many actuations? How many movements?
7 or 8. So I will do now normally this is again. So the guidelines are clear that technically you don't need for such lesion really aspiration. What I do in my country on everyday basis, I will do the first one by the slow pull, and then I will see the content on the slides, and then if it's okay, I will do another 2. If still I need if it's not enough material, I will combine between the slow pull and aspiration a little bit. So we have the control of Professor Bim Moller in the room here. So I'm under control. I'm under full control. Okay. Yes. Yes. Could you?
Camera. Now we are expelling the tissue into the slide.
Can you focus the camera on the material? Yeah.
Okay. Yes. So I put the needle out, and I push
The stylet.
the stylet. Yes.
Yes, there are good tissues coming out.
Stop. Stop. Yes. And then I will ask, remove the stylet. Remove and a syringe of air. So we have 4 slides. Yes. One more. Okay. So I will just this is already good material. So I will go for another 2 more FMBs, mainly because this patient needs to have a core biopsy for immunophenotyping, especially for if it's lymphoma and for the treatment of lymphoma. However, my suspicion more is with the TB, not lymphoma. So we have another very big one here, which I'm going to puncture now.
Mustafa, you want the PS for shall I take it for?
Yes, please. Yes. So I don't know. I don't know in here in India. In Egypt, we do the first only on slides, but I always have an on-site pathologist, which will help you tell me, Mustafa, okay, I have enough material, and the rest I will put it for cell block. So
Professor Mustafa,
yes,
we are going to Anthony Theo room.
Okay.
Shift to Anthony Theo room.
With a liver biopsy. So I'm trying to find an area where there's a lot of parenchyma. So this seems to be a very good area without any veins or ducts. So I'm using a core biopsy needle right there. So we're gonna take big strokes. Okay, that's big strokes. Okay.
Which needle are you using for the biopsy?
So we're using a 22 gauge acquire. So we can do like 10, 20 strokes. And then
19 gauge needle for biopsy also.
you can use a 90 gauge, of course. Yes, of course. So the idea is to have enough portal tracks within which
There are different ways of doing it. I think Anthony is in a fast forward mode. Several people do it very slowly and 3 or 4 actuations in different directions.
okay. So I think we're okay. So
Once again, you would like to have? You really rub the hard liver.
Sandeep and Anthony, Amol here.
Hi.
Hi. A bit of a controversy regarding the liver biopsy controversy or this thing that many people say that a single stroke or just 3 strokes are should be done, and now Anthony is demonstrating multiple, like we would do any other FND. So what are your thoughts about that?
I think the idea is to have enough portal tracks as much as possible. So you can take a look.
We'll have the look at the tissue. Cameraman can focus there.
So once Sandeep shows the specimen, will go to Professor Nagareshwar Reddy room. So Sandeep, if you can demonstrate the specimen.
Several bits are there. The cameraman can focus here.
Okay. These are long cases.
Enlarge the camera to the specimen.
Too much time. For
Camera person, zoom the camera.
And I'll take and so luckily there's no biopsy involved. Other rows you have to do and then do. Yeah, sometimes colonoscopy.
Okay, we are shifting to Professor Nagareshwar Reddy, sir. Dr. Reddy, sir, you are online.
Okay. So now what we did was, when you're away from the camera, we did a radio frequency ablation of the whole segment completely, so that all the tumor was RFA'd. We followed it with a balloon dilatation. This is very, very critical in hilar strictures. Don't be overconfident. Always do balloon dilatation. We used a 6 mm Titan balloon because that contains a through and through wire. So we used that. And now we are ready to stent left and right. What I'm using is, if the camera can focus here, you see both the stents are loaded onto the wire because I want to do it very quickly before the other stents open. On the left side, I'm using a Boston microvascular stent. On the right side, I'm using a 90 stent, which is a little more tapered. Now, why left side first? Always the angle in the left side is difficult. So I would recommend that if you're doing this type of stenting, take the left side first. So the Boston has got a side guide wire, and this is sometimes a little difficult to get it through, but let's see, it should hopefully get through this. And then
Can we have the fluoro image? Fluoro image?
Fluoro, please. So can you see the stent going up now? It's going up smoothly. And now there is going to be the difficulty, but fortunately, yeah, no, so at this point of time, I'm going to use the shaft of the scope to see if I can push the stent inside,
There's a 90-degree angle.
Yeah, angle there.
So that's a little hard.
So, but sometimes when you open it up, because you're past the stricture there, if you open it up, it jumps up also. And anyway, that is past the stricture in that area. So I'm just trying to again adjust that in such a way, maybe a little more sedation will require. And Bhagwan is helping me with the guide wire. I think it's going in there.
It's making its way. Yeah.
So one of the tricks at this point is to open it partially,
Mhm.
and then that sometimes makes it way through.
I think it's a short wire also, which is making
Yeah,
it a
that's
little
making it.
challenging there.
See, I'm just pulling on the scope there. So now we are past the bend now. So at this point, Bhagwan, I suggest that you open it up. It doesn't matter. Part of it is in the scope, but it'll open up. Yeah, deploy.
Maybe even push the catheter as blowing, so it
Yeah,
deploys further up.
that's what I'm doing that.
Yeah.
See that now it's going in, it's moving forward,
Right.
Good. But that's the okay point to deploy because you're covering the whole left duct now. You're finding it difficult to get it out? Now see, I'm depressing the elevator a little so that it goes in faster. Yeah.
Oh, yeah.
See that how it went in nicely? So this is an important trick. If you can't get across the bend, keep it there and then it'll get pushed by itself and you put a tight form. Now keep releasing, Bhagwan.
Yeah.
So keep releasing. No, wait. Now I want to pull it back a little because it's too deep. Yeah, now keep releasing. So the important point at this is to look at the fluoroscopy, the second marker which is there. Just stop. If once it comes a second marker, it's not going to get reconstrained. So I want to pull it back a little more so that I get a view of what is happening. Yeah. Yeah.
Yeah, I think
Good. Can you show me the fluoroscopy down, the second marker? I'm looking at the second marker and I have to come to the second marker before the reconstrainment goes off. So now I'm at the second marker. I want to adjust this stent a little more so that I can see part of it outside.
Yeah.
Okay. I think it's outside. Yeah, good. Now release it completely. Now I'm pulling back as is releasing it. Pull back. Excellent. So now we have to remove this part and then quickly I'm going to now put in the other stent, which is the 90 stent. And it's important to place it. You can see now if I want to go in anytime, I can go into the stent. The second stent is tricky because it's already occupied by other stent. So we'll have to use certain other maneuvers to see if it doesn't get in. Bhagwan is here pulling on the guide wire. This is a full length guide wire. This is a little more tapered stent. So hopefully it should not have too much problem, but you have to be careful. And as I'm using the elevator in this case to push it up, Bhagwan is pulling back on there's some resistance there already. He's pulling back on the back.
I think we have 3 or 4 diamonds, which is appropriate for the first one.
Yeah. So again, I'm doing this movement. There's a lot of resistance there. So I'm doing this movement to push it up. There's a lot of resistance. So I put a constant pressure there, use a screwing movement, left and right. See this? The screwing movement takes it up again. And then constant pressure, screwing movement, push it up. Again, a lot of.
Also, it's the right posterior one, so it's a little bit.
Yeah. So now again, there's a lot of resistance there. So again, I pull the scope up, get my elevator on the top, pull the scope up. So Saurabh, you think there's some progress there? Yeah.
I think so. I think we are making some progress. I think we are going to cross the stent. Although this seems a little
more tough. Yeah.
Encountering resistance here.
Yeah. So now again, screwing movement is very important at this point. Right. And as I'm doing this, Bhagwan is actually putting pressure on the wire.
Yeah. I think having a more negative traction allows the stent to get more support. And thankfully, we have a long wire here, so it's allowing that to happen.
So I'm just at the junction there where we have to. So a little more will be through Bhagwan.
Yeah. I think it does require the shaft and overall pressure as opposed to the elevator just.
Yes. There's the elevator, won't push it. Now you see, we are almost there.
We're almost crossing that.
Yeah, almost crossing the stand now.
This is.
So it requires a lot of constant pressure that keeps coming. Again.
Yeah, it's nice.
So we discussed before whether to put the right or the left first.
Right.
We felt that left also a lot of resistance, so we put the left first. And now you find the right also a lot of resistance, but it's just crossing that.
But I think also this anatomically, this is more right posterior, so it's also usually right anterior.
Exactly.
Usually the easier one.
That's a good point that Saurabh is. The right posterior, so a little curve is there, and hopefully with this technique.
No, but I think you have made very good progress considering it was very tight. Yeah, this is usually the right maneuver.
Yeah.
I think the camera can show how this body is he's moving his body to get the
twisting movement. Yeah.
And get the stent once. Now the stent is actually crossed.
It just crossed that area. So now actually again, if you open up, the same thing will happen. That you will just.
Can you focus on the hand movements of the scope?
Yeah. It's really the whole shaft of the scope that's required here. Nice. It's crossing.
So it's a very slow movement that we are doing, crossing this, and Bhagwan is constantly putting pressure. So these are the most difficult cases, if you can notice, because of the toughness of the stricture, very fibrotic stricture that are there. And also, if you can see now it is slight, just cross across.
So I think the tip is also to go in a bit of a long position in the scope.
So that
allows the force to be transmitted straight as opposed to a short scope position. You see, Dr. Reddy's got a, right. Yeah, it's slightly longer.
Yeah, it's gone in through.
So it's
So before
across.
we open, we'll go a little more, so that it,
Yeah, true.
yeah, I
So,
think we're.
Would you consider being very close to the papilla to advance it?
Yeah, so it's another point we
Otherwise,
can
you
do.
just shorten and be very
Ah.
close and do gentle
Yeah.
ups. Yeah. So I think this works better.
Yeah, this is okay.
Okay.
Yeah, now
Yeah.
you should just cross the opening.
So I think worst-
Again, yeah, we can open it here and see also what happens. And then you,
Since we're already inside the duct.
yeah, we can open it up.
okay.
Yeah. It open a little.
Yeah.
Op- Yeah, keep opening. Excellent. See
Oh,
that?
nice.
See,
Yes.
stop.
Wow.
See what happened now.
I think
Can you
jumps
see that?
Once
How it
further.
happened? Yeah. So this is a very important technical point. Now what we'll do is that to see that you keep the lower end here so that you can have both the lower end seen. Okay. Now can you slowly open? Keep opening. Slowly. Wait. Just I want to see the lower end. Go to the lower end, please. The fluoroscopy. Yeah. Now you can see the yellow marker there. Are you getting the endoscopy picture?
Yes.
You see the yellow marker there, which is the lower end. So the upper end of stent is nicely in. Lower end, we are trying to keep it out also so that we can recandidate. Open now, open. Bhagwan is opening. Opening. I want to keep it parallel there. So that if you want to re-enter, you can always enter. Keep open, quickly open up, Bhagwan. No, not, I mean, if it's outside, it's enough, good enough. Wait. I'm just thinking, yeah, nicely positioned. Very good.
Good position.
Open, keep opening. Open up fast. Yeah, so we are opening it very fast at this point. So you don't want the stent to. Yeah, keep opening. Excellent. So you see that this is the second stent, where you can see outside is the first stent. And you can see the fluoroscopy picture. Can you see the fluoroscopy picture, please? Can you have?
I would like to
Small
thank the
karke,
chairperson.
take a
Now for
picture
the
there.
annexation, I would like to invite
Yeah.
Dr. Kapil Sharma, Dr. Mahendra Singh Rajput.
Okay.
Dr.
So
Neem
you can
Kamal
see this
Yadav,
now.
Dr.
Okay.
Deepak Lahoti and Dr. Hatinder.
Okay. Okay then. Thank you.
Great. Wonderful.
Thank you. I think we're not on the camera any longer.
We are now.
So we finished the procedure, and you can see on the fluoroscopy the nice right and left duct drain. And fortunately, we could show you many maneuvers in this case, in a difficult hilar case, how to enter selectively into CBD, how to selectively enter in different ducts, the technique of RFA and balloon dilatation, followed by technique of putting in two difficult stents. Okay, thank you very much.
Thank you, sir. Excellent demonstration.
Thank you. Okay, good.
Good. Thank you. Screen.
Yeah, what's your thought on radio frequency ablation and some recent data contradicting it? But then there is earlier data which did show improvement.
I think there's a lot of controversy still in RFAs.
Yeah.
So two randomized control studies that came from China showed very clearly the benefits in terms of the stent patency and survival of the patient.
Yeah.
Subsequently, there have been other data which haven't been, but I think it's very important patient selection.
Yeah.
A very high hilar tumor like this is the one which benefits.
Right.
We have just actually published a small series where we took hilar strictures like this and then found that there was definitely a survival benefit and also stent patency benefit. Survival benefit may be linked to stent patency also because cholangitis can cause death in this patient. So I think this is an
I think we encounter gallbladder cancers which are not going to be of benefit because they're mass forming.
Very important.
And then and some of the studies took pancreatic cancer patients. Again, not. So this looks like the ideal candidate, which is intraductal. Which may.
So I think that's a very important point, Saurav, that if you take gallbladder cancer, which are very common in this part of the world, and do RFA, is not going to be effective because it's a mass outside the RFA zone. Not going to be effective. So, and pancreatic cancers have always been against. I don't think they're going to benefit. So the ideal in the cholangiocarcinoma, typically like this, where you have the ducts involved, especially if it's a very fibrotic tumor, it is so tough. Even after RFA and dilatation, we have difficulty in going in.
Right.
So that I think these are the type of tumors that are very, very ideal. And this patient, I have a feeling that he's going to survive long. And that's the reason why we left both the stents out. Because if intervention has to be done after 2 years, 3 years, sometimes 5 years,
Yeah.
if you have these stents out, it becomes easy to go inside and clean these
So,
stents.
Dr. Rajesh sir,
Yeah.
can we shift to the other room?
Sure, thank you.
Sure,
Thank you,
thank you,
Rajesh.
thank you.
Rakesh.
Bye-bye.
Thank you.
Thank you.
So we are going to the room number 2. Bimal is going to present the history.
Okay.
So our next is a 56-year-old female. Our next case is a 56-year-old female who is a known case of EHPBO presented with doubtful history of 2 episodes of melena.
Will be asking questions. Is that okay?
Of course, of course.
Okay. Radhika.
My name is Dr.
Nikhil.
The slides.
Please, slide.
Okay. So a 56-year-old female who is a known case of extrahepatic portal vein obstruction presented with doubtful history of 2 episodes of melena 10 days ago. On endoscopy, you found large gastric varix. So our plan is to do US guided coil and glue.
Okay.
So Professor Kenneth Bin Moeller. We shift to Professor Kenneth Bin Moeller. You are online.
Okay. Good. So I literally just found myself. There's a little bit of an echo, so please forgive me if there's a little delay. So we have our therapeutic curved linear array echo endoscope that we're going to use. You do not need to use the therapeutic channel. You can use a diagnostic. In fact, I prefer the diagnostic. So we'll go ahead and start inserting. It's called endosonography because we have both endoscopic as well as EUS imaging. Going to very gently advance into the esophagus. I'm here now. Is the gas on? Are we using CO2, by the way? Okay, that's great. And I'm trying to give a little bit of gas here to see. So as we go down, actually, I got down pretty fast. You see the esophagus very nicely. And I think actually the oblique viewing optics of the CLA are very nice for looking at the cardia, looking for junctional varices. It's important to distinguish junctional from non-junctional varices because they're very different in terms of their management. So here at the cardia, I don't see any varices at all. And I can go here into the stomach. We're not going to spend a lot of time cleaning this off. I'm just going to distend with gas. You can see there's very little portal hypertensive gastropathy here. You can see the rugal folds. Of course, there's always the possibility that some of these could be varices. We'll be able to distinguish that better with EUS in a moment. This is just to show you that you can go in retroflexion usually with the CLA. You can see I'm giving gas and you can look back on yourself and we should be able to see the fundal varices. I saw pictures and it was very impressive. It's just that it's a little bit dark here, but here you can see in the fundus area. Just wait till things, there are the varices down below. I think you can appreciate them down at the lower part of the image. Obviously, we're not going to treat these in retroflexion. The beauty of using EUS is that it doesn't matter whether your stomach is filled with blood or food, you can still do the treatment. So now the first thing to do is to aspirate all of the gas out. I usually have a water pump attached to the working channel because you need to fill the fundus up with de-aerated water. You need to distinguish exactly where these fundal varices are. So the best acoustic coupling can be achieved and the demarcation of the fundus if you fill the fundus with water. This is one reason why I do prefer to have the patients intubated. This patient is non-intubated, but the patient is in the left lateral position. And our assistant here is aware that we need to be prepared with suction to suction out anything that comes up because we want to avoid aspiration. Primum non nocere. All right, so now I'm going to, let's switch now to the EUS, or you can see the EUS, so just swap. So the EUS is large and the endoscopic view is small. Now I'm going to have my assistant, oh good, so he has the BioShield, I think right here, which allows me with a water pump to fill the fundus up myself. And we really need to get good distension. So this is a very critical part of this procedure. If you want to identify the perforator, you want to distinguish the
the varices from collaterals. So varices are different from the collaterals, which are outside of the gastric wall. The varices are inside. If you could swap the EUS for large, please, now. All right, so now let's mag up one. So all I'm doing is I'm slowly pulling back. Let's mag up. And where's the water pedal? Can I control that myself, or you're doing it? Okay, that's fine. Please mag up a little bit more. So I'm slowly, you can see there are lots of bubbles. This is why it's better to use de-aerated water. You can put some simethicone inside as well if you have trouble. Looks like little fish in the pond. But I'm just basically pulling back towards the fundus. So it's worth taking some time to look at this. You can see there are lots of little varices here, small diameter varices. So a lot of those, what look like rugal folds, are probably varices, but the risk of these bleeding is very small. We want to focus on the IGV-1 type of varices. So again, I'm coming slowly back, and we're going to look here into this area. So this is the part that takes a lot of patience. You have to slowly pull back. And what I'll do is I'll pull back till I see the cruce muscle. You see the cruce muscle at the top? I don't know if maybe with calibers I can show that very quickly. The reason for identifying the cruce muscle is, so it's going to be up here. I'm going to show it to you right now. Can you mag up for me? How do we mag up? Yeah, there we go. And again, and one more time. All right, so this is near the cruce muscle. So this is the left limb of the right cruce muscle. And what we're seeing right here, it's very nice, is you're looking transesophageal into the fundus. So the fundus is down here. See, this is the fundus, and we're going to look for our varices here. So the idea is not to do a transgastric puncture of these varices. We want to do transesophageal, ideally transcrural, because that provides a backboard so that you don't get any bleeding, any back bleeding. In fact, if you do this correctly, you won't see a drop of blood afterwards. So we're looking transcrural, and this is also a great way to find the perforator vessels. So I'm just going to advance very slowly. So you can see very nicely the fundus here, and I'm just kind of pushing forward, looking for these varices. So it's important, and you heard this very nicely in the lecture this morning, that you can identify the muscularis mucosa of the gastric wall. If you can give a little bit more water, please. Fill it a little bit more. So you really want to distend this very aggressively. Okay, and a little bit more. So take your time. All right, that's good. And just be aware that there is a risk of some aspiration. So the varix that I'm probably going to target now is going to be here. I'm going to try to follow this and see if I can identify where the perforator is. How do you find the perforator? The perforator is going to be where you see it going outside and often connecting with gastrorenal shunts. You don't really want to start injecting into gastrorenal shunts because the risk of embolization is very high. So now here, as I turn down here, now we're getting a nice view of those bigger varices, right? Look at this. That's what we want to target here. So this is where I need an assistant holding the scope. And so here I'm kind of in a difficult spot where I'm torqued like this. If the camera can show, I'm going to see whether it's possible. So this is a beautiful view. This is the view that I want. And you can see how it connects with the perforator out here, which will join with collaterals. So you can see the muscularis mucosa here. You can see the outline. This is where the water filling is so important. And we can also freeze just for a moment so that I can measure the diameter where the calibers, okay. Let's just measure the diameter of one of these varices. Okay, that's the distance. But in fact, this varix is only this size, right? So it's really just 7. In other words, even though they look very big, if you put a 20 millimeter or a large coil, you're going to have some difficulty getting it to fill that. So you have to realize what looks endoscopically like a single varix is actually a convolute of varices. They're smaller diameter, and that's the the why I think EUS is necessary, because you don't really have quite the appreciation. Now, let me just very quickly see, because my assistant is going to be assisting me on this side. It's going to be difficult torquing the scope like this. I'm going to see whether I can just turn everything over like this and just see if I can get into the same position, but be closer for my assistant. It may or may not be possible. I'm going to just see if it is. So pulling back like this here, and I'm going to see if I can get into that same position where I can see the bigger varices down here. And yes, I think I've got it, right? So this is much better. You see the scope is straight, right? It's going to be much easier. This is how you should be working with your shaft of your scope, always straight, not forked, because there's going to be more resistance. All right, so I think we're ready to get started now, and we're going to place a coil. And, you know, I think in terms of size of the coil, we'll use a 19 gauge needle. I'm going to have an assistant holding my scope, though. Yes, please.
Good afternoon, Professor Binmoller.
Yes.
Good afternoon. Now we can see the conglomerate for varices with the multiple septa. So where we have to target, and how you decide where to target, and how you calculate the size of coil.
So, you know, ideally, you'd like to get as close to the perforator. I'm just trying to look here a little bit and sort of see which one I want to go for. Sometimes you have no choice and you just have to go. So this is what I like. I just slip back into the stomach. Hold this right here, please, just like this. So you see the cruce muscle again up here. I don't know where, can you put the arrow back on here? Where's the arrow? All right. So the cruce muscle is up here. Yes, I've slipped back into the stomach. You're looking across you're looking across to the fundus. So this is what I want to target here. This is the perforator right here, right? You can throw Doppler on there. You can see it very nicely, but this is what I want to target here, right here. If I can get my coil in this area going transcrural, this is the cruce muscle, into the varix, that's the ideal. And this is where my assistant is helping me by just stabilizing the position of my scope. And once again, if we look and we measure, that is, I think we measured it already. It's just about 7 under, you know, so I think we're going to use a smaller coil, not a big coil. You can use a 12. Yeah. So it's nice when it's a little bit larger than the diameter of the varix. So this is the part where your assistant plays such an important role, because it's very easy to suddenly start going outside, because we're targeting the junctional. So now I'm in the stomach again, right? So I'm going to pull back till I feel that. You can feel it when it slips into the esophagus, and that way you know you're really going transcrural. You can hold it just like this, please.
You're going to target the intramural part or a feeder?
I'm going to target the feeder as best I can. In this case, you know, I can just sort of tell you where I think the feeder is. It's
So, Professor Binmoller?
Yeah.
Till you are fixing the needle, I'm shifting to room number 1.
Okay.
And shortly we are coming back to you once you are prepared. So over to Dr. Mahesh Goenka room, please.
Good.
So this is a 75-year-old male.
So this is from room number 1. This is Mahesh Goenka, and I have Dr. Mohan Ramchandani with me. I think with him around, there's no tension whatsoever whether we'll succeed, fail. I'm sure he can suggest the ways to go proceed further. And
Dr.
we have
Goenka?
one. Can you hear me?
Dr. Goenka?
Can you hear me?
Yeah, we can hear you. Just wait for a history. We are just presenting history.
All right, okay.
So 75-year-old male who is a known case of post laparoscopic cholecystectomy 20 years back, presented with abdominal pain. Our routine investigation shows bilirubin of 2.1 with significant raised GGT and ALP. Ultrasound shows dilated CBD with IHBRD, and MRCP shows 2 stones in lower end. So plan is ERCP and CBD clearance.
Or online, sir.
Yeah, so I have Dr. Mohan Ramchandani who is with me. So I have no confusion whatsoever that I'm sure will succeed. He'll suggest the ways forward. And of course, we have experienced Bhagwan, we have Darshan who is going to show the fluoro, and Dr. Pankaj who is assisting us with the anesthesia. So I have already focused the papilla. You have seen the picture. It looks like a moderate sized stone. And we are going with a very open mind as to what maneuver we'll do to take out the stone. There are various options and we'll discuss as we go through. So as in my practice back home, I always start with a terumo wire with a sphincterotome when I'm doing the biliary endotherapy. So I'm going in. So I think positioning the scope at the papilla at the right place is so important for the select cannulation. And Nagi already spoke to you about the various classifications of the papilla. There are some studies which have shown that some of the papilla may be more difficult to approach. This is a type 1 papilla, which is a normal appearing papilla. Type 2 will be a flat papilla. Type 3 will be protruding papilla. Type 4 is a fissured papilla. And type 5 now is a periampullary diverticulum. So we are going to approach at 11 to 12 o'clock position. And as we are probing, Mr. Bhagwan is going to advance the guide wire. So let's see whether we are in the bile duct.
Very nice.
So I think we are in the bile duct. Mohan? Yeah. Yes. So this is an ideal position also for keeping the scope semi-long position. What I find in my fellows when they come is that they almost try to keep it straight. I think a little bit of angle at the tip of the scope is very important rather than keeping absolutely straight. So I'm not sure whether we are entering the cystic duct or we are still in the bile duct. So I think maybe we can withdraw a little bit the guide wire. Yeah, you can put some contrast, no issues about it. So it's all bile duct.
Fluoro image.
Can you see the image?
Now we can see.
So I would withdraw the sphincterotome and Mr. Bhagwan will again, yes. Now we're in the bile duct. So it's a long cystic duct, which is almost starting from the bile duct in the lower part at the distal aspect from the left angle. So now we're in the bile duct. You can see it's a grossly dilated bile duct and we haven't seen the stone as yet. So let's continue injecting a little bit. But we'll go with MRCP picture, which we have been shown.
Sometimes if we inject a contrast at the lower end of the CBD and because of their...
yeah, now you can see the stone somewhere. At the overlapping the duodenal image. Do you think that's a stone there? Mohan? Yeah. So what I'll do is that I would change the guide wire to exchange wire. I think I can see a stone right up above the cystic duct.
Yeah.
Yeah, it's a floating stone above the cystic duct. Can you see that?
Yeah. We can see.
There may be more than one. There are possibly 2 or 3 stones.
Yeah.
So I think doing a good sphincterotomy and doing a balloon sphincteroplasty will be needed in this case. So can you change the... Yeah. So Bhagwan is rightly telling me to go a little up because this cystic duct, when we are changing the wire, we should not again struggle with entering into the cystic duct. As you can see now, there are 2 stones at least, and they look like bullet-shaped stones, at least the upper one. Now, of all the stones, the bullet-shaped stones sometimes may be a little more difficult than the rounded or oval stones, which are the easiest stone to take out. But there's enough scope for me to do a sphincterotomy and then to do a balloon sphincteroplasty.
Before lower bile duct looks like a cylindrical, so we can take out the large stone even with a good sphincteroplasty.
I agree.
But if there's a mismatch between lower CBD and stone, then some sort of lithotripsy is required, but not in this case.
So this is for the beginners, if there are few in the hall, that we keep the golden mark at the papilla, 1/3 inside, 2/3 outside while we start cutting. Don't tense it too much to avoid any zipper cut. Nowadays, with the present system, the zipper cut is uncommon. So we are using the endo cut and we are starting the cutting. You can see a flow of bile.
Yeah.
Goenka?
I think we'll stop at that.
Dr. Goenka, till you are changing the accessories,
Yeah, you
Dr.
can-
Binmoller is ready. So we
Yeah,
shift
sure.
to Dr. Binmoller room.
I'll just put my balloon sphincteroplasty balloon there.
Okay.
my scope in place. So you can
Professor
see,
Pinto on the line.
okay, yes, so we are ready. Dr. Radhika is assisting me. She's getting a hand cramp, she said, so that's why I asked to come back to me. So we're in perfect position now. You can see the needle lengthwise here. This is the Boston needle that we're using, the 19 gauge. And I have a nice trajectory, I think, in terms of, I've already measured the distance. So I've already locked in the thumb screw here at 2.5 centimeters, because that's the distance I want to go in. So I'm just going to make sure we have distilled water that we're using, because we're using N-butyl 2. Otherwise, I use the saline if I'm using 2-octyl, which is my preference. So we're going to, as soon as I'm in, we're going to aspirate and confirm that we have blood return. As soon as we have blood return, we're going to flush some water, but not with a new syringe, with just saline, a new syringe, and then we will attach the coil loader. Okay, I think we're ready now, and we have some respirations going on here, which is one of the reasons why I prefer to always have the patient intubated. So it's just a thrust like this, and I should be right in there, smack in the middle, and we aspirate, aspirate and see if we get blood return. We should. Good, we have blood
Please
return.
focus
Now
the
you very quickly switch for the, never put gas in there. Okay, flush, you're going to see lots of bubbles. There they are. All right, now we're going to switch out for the loader, and we're attaching the loader, and we're going to push the coil into the FNA needle. So we're only going to push it far enough so that afterwards we can remove the loader.
What style coil you are using, sir?
And then we can use the this stylet as a pusher to push it all the way in. So as soon as you think it's inside of the FNA needle, we take this off, right? Perfect. Make sure you take the stylet out. You're going to use the stylet as a pusher.
We are
Go
using
ahead.
a 12 mm coil.
Yes, 12 is fine. We'll pack them. Get the next coil ready to go in. Right afterwards, we're going to put a second. I always put 2 coils, at least, sometimes more. All right, so you see how we're getting nice bubbles. We have great visualization. We're going to see the coil come out now. Look at that. I may adjust my position accordingly. Looks beautiful. It's very echogenic. No question, it's in great position. So what this coil is doing is it's slowing down the blood flow. That's very important. And it will serve as a scaffold. The woolly synthetic fibers are going to serve as a scaffold to retain the glue at the site of injection. So now the assistant is very skillfully advancing our second coil in. The loader comes off.
So you want to
Remove the stylet.
How many coil and glue?
I'll put as many as where I see really that it looks like things have slowed down. So let's put at least 1 more coil, and the coils will anchor each other. So you can use smaller coils. It's okay. Just there we go. That looks fantastic. I like this. I think we have enough, right? You see it fills the lumen very nicely. We're ready for the glue. So you don't have to Doppler, but you can. So now let's put the glue in. So this is histoacryl. We're using the N-butyl 2 cyanoacrylate. And this is, I guess, mixed with some lapiodol, right?
Yes.
Okay, so we just want to make sure that it doesn't clog. Go ahead. Yeah, go ahead. Push it in. The first part is going to go inside of the FNA needle, the dead space. And then we push that in from the dead space in. Put a second one in. One more. I always put 2 cc's. Can you get 1 more in?
1 more cc?
No, you can just push. Yeah, push. You have to keep it open. Otherwise, the needle blocks. This is why I don't like histoacryl. See, if you use the 2-octyl, you will never have this problem. Now I have to pull out, but let me show you how to pull out. It's all fine, all right? But usually I put in 2 injections. So I put Dermabond or Exofin. This is 2-octyl. And the most important is you do not want to get any glue onto your scope. Now I can tell you, because we went transcrural, probably all the glue is going to stay in the varix and it won't come out in the esophagus. But just to be sure, the first thing I do is I pull back my needle like this. Okay, now I'm inside. I unlock the thumb screw and lock, so I never injure the assistant, okay? And now I'm going to advance the sheath into the lumen. Advance the sheath. And now I pull the whole scope out. I'm not going to pull it to the working channel, pulling the whole scope out. And then once the scope is out, the assistant is going to immediately clean off the tip. And you see there's there's not a drop of glue on there. That's because I went transcrural into the varix from the backside. It's the back, the transesophageal is taking the back door to the varix. And the mucosa is, of course, very thin if you go transgastric. So this is why I try never to go transgastric, because then you're going to get some bleeding. So just wipe off the tip, and then just as a precaution. But in addition, since we have a balloon on the transducer, even if you got some glue on there, the balloon, which you can take off, will protect. All right, so now we can remove the needle, right? And we can go back in and we can do another injection. It's just a repetition of the same, but you've seen the steps now. I'm just going to repeat the same thing I did. And I just want to make sure that I get all of the varices that need to be treated today treated. So I'm going back down. And, you know, endoscopic, I'll put the endoscopic on just for a moment. Look at the water. There's almost no blood, maybe a little bit from the puncture
Professor
of the
Bindagal?
esophagus. Yeah.
So Dr. Mahesh Goenka is waiting in another room.
Yeah.
So can we switch over there?
Yes, please. I'm just going to
Over
do the
to
same.
Dr. Mahesh Goenka.
Thank you, Rajesh. And am I audible now?
Back to EOS large.
So we are waiting this time with the balloon for the balloon sphincteroplasty. And as you know, these balloons come in various sizes. The exact size to be taken depends on three factors: the anatomy of the papilla, the requirement of the stone, and also what you intend to do. So if I have to do a balloon sphincteroplasty in this patient, looking at the bile duct, I'm going to go for 12 to 15 millimeters, and we will each step decide whether we are going to go further or not, depending on whether there is ooze from the apex. Ooze during the balloon sphincteroplasty, a mild ooze is not a problem, but you should always look at the apex of the papilla while you are doing the balloon dilatation. So Bhagwan. So you can see the inflating device there. So Mr. Bhagwan is inflating with contrast. Are you inflating with contrast? Or so you can see the how the papilla is dilating. And can you see the balloon there? So half of the balloon is outside and half of the balloon is inside. And this is 12 millimeter. I would do still, there may be you can see a little trace of blood at the apex. Can you see a trace of blood at the apex there in the hall?
Yeah, we can.
Yeah, but we are not worried. We'll still do a 13.5 at least. Mohan, with Mohan's permission, I'm doing 13.5. So this is 13.5. Now Mohan has to decide whether I can do 15 or not. I'm okay.
You can
I'm
still
okay.
do, yes.
So Mohan is giving me a permission to do 15. Maybe after waiting for half a minute. So the time for each balloon station varies between the practice to practice. People use 10 seconds to 2 minutes, but in general, I would use 30 seconds to a minute for dilating and to producing the desired effect. So 30 seconds to 1 minute. There are some surprising data which says that if you dilate for less time, there is higher risk of post-ARC pancreatitis. I have no logic to explain in that.
That is because the subsequent procedure which you do, like stone removal, if you have to struggle to remove the stone, that may cause pancreatitis. So if you do dilatation for at least 2 minutes, that will bring down the struggle to remove the stone, not the balloon per se. So that is why the post-procedural pancreatitis, which may be because of the process of stone removal, may come down with prolonged dilatation.
So now that we have dilated 15 millimeter, I think we are in a reasonably good position to catch the stone. We have basically two options. One is to go with a basket and the second is go to with balloon. My particular preference in this case will be a basket, and I will be using a mechanical lithotripter, maybe a trapezoid. BML, trapezoid, you have trapezoid here? Okay, so we will use a mechanical lithotripter basket only for the basket. And in the process, we'll also show you the device maybe in 1 minute. So maybe we can deflate now and take out the wire as well, because we are doing the BML. BML doesn't go over the wire, isn't it?
No.
Deflate.
Sir, sometime you have a stone at the lower end of the CBD close to the ampulla. Before you do balloon sphincteroplasty, you have to push that stone.
We were just discussing this point where we're off air, that sometimes if you dilate, it may form a pouch and the stone may lodge in the pouch. I've never seen a perforation because of that, but I've seen pouch formation, and then the balloon extraction, but the stone extraction may become a little more difficult. So I think if you can easily push it, it's all right, but nothing to worry. You'll be able to complete the procedure in
Now
all
we can
cases.
see CBD from inside.
Yes. And maybe I can show you the stone also from inside.
Yeah, just suctioning and that may come out also sometime.
Okay. So I can see the
Yeah, we
stone.
can
Can
see
you see
the
the
stone.
stone? Yeah. So there is still a small shelf-like thing which is there, about a 5 millimeter above the papilla. Doesn't matter. So you want to go over the wire? Straight cut.
Straight, yeah.
So I've taken out this. We are using the basket only because of the diameter of the bile duct. If we use a balloon, which is our usual device, then it may go by the side of the stone because of the diameter. So I'm going with a mechanical lithotripter, which is BML. And as we all know, it's a 3-tiered system. There is a basket, then there's a plastic sheath, and there's a metal sheath. I hope we will not require the metal sheath in this case. So there are two types of lithotripter which are quite popular. One is the trapezoid from Boston and the BML from Olympus. So this, you can see the basket which is inside, and then there is a plastic sheath. And I'll just put the plastic sheath inside the bile duct, and Mr. Bhagwan will now open the basket. We have to always engage the lower stone first. This is the road block. Otherwise, if you catch the upper stone, the lower stone may itself block the path. So as you can see that the basket, I think, is also going into the cystic duct.
Yeah, cystic duct.
So close it once.
Can we have a fluoro image larger?
Yeah, can you show the fluoro image?
I think that's going into that.
Big fluoro image.
Then you have to
We are in
come
the-
out a bit,
yeah.
and then, yeah, now.
Now open.
Please give us big fluoro image.
Close कर दें एक बार.
Cystic duct. So you have to go a bit below.
And
We
change
also
it.
need an endoscopy image.
Yes. So we are manipulating the angles a little bit so that we avoid the cystic duct.
What maneuver you do?
So
to
just
directly
changing the angle of the scope.
Pushing the scope down to the D3 level and then and coming from below upwards. That will make the
Kapil, sometimes what happens in BML, it's
Can you open
sometimes
now?
difficult to negotiate into the bile
No,
duct.
I think you have to reduce the scope first.
Into the bile duct. So
above the stone?
Yeah.
Below the
from the scope
Ah.
into the bile duct.
Yes.
Sometimes the curvature
Got
is
this
not
now?
there. It is
No,
more
no.
You
straight.
can loop and then.
But that's a trick.
Balloon, yeah, balloon. Maybe try balloon.
Dr. Kunal want to ask, sometimes it's difficult to negotiate this BML into the bile duct and above the stone. What are the tips and tricks?
No, see, usually it's not a problem to negotiate the BML across this. In this particular case, we are facing the problem because the cystic duct is very wide, and it has a tendency to enter the cystic duct.
Yeah,
So
no,
we are.
no, that was the right. Yes, this is the right.
No, I think we are already.
Even though sometimes the large stone, very difficult to place a basket above.
Yeah.
So then we can do some wire guided basket and.
Yeah, we will do that. If we don't succeed in this. So I intend to move from the other side. I'm touching the left wall.
Yes.
I want to go to the right wall, and then we should be there. Let's see. Oh. Yes. No.
It's preferably going into cystic duct.
Yeah.
So
So
first we'll try with the balloon because the lower stone can still be removed.
I think we will try a balloon.
Wire guide and keep the wire and then go with wire guide.
Rajesh, if you want to go to the other room, you can try that. Give us 2 minutes. Rajesh. So I think this shows some problem when you are dealing with a little more rigid accessories. Why there is complete silence? This will happen in day-to-day practice.
I think they are in different rooms.
Can we switch over to Professor Binmoller now?
Yes, sure. So I'm going with
Professor Binmalo, you are live.
Okay, so I have just inserted the therapeutic echo endoscope. So for this, you do need a large channel echo endoscope. 3.7 millimeter is with this Olympus. And yes,
Just let me present the history.
please.
So this is a very interesting case. A 48-year-old male who presented with the features of gastric outlet obstruction and obstructive jaundice. CT scan shows a poorly differentiated mass in the pancreas. FNSA shows an adenocarcinoma, and on endoscopy there is a gastric outlet obstruction as D2, D3.
A little bit of water.
His hemoglobin was 10 with a bilirubin of 14, and this is an MRCP which shows a dilated bile duct along with the dilated intrahepatic ducts and ascites also you can see, and over-distended gallbladder. We asked, first we tried ETBD, but not feasible due to presence of ascites and absence of proper window. What I did, we put a percutaneous drain into the peritoneal cavity. EUS guided biliary drainage was attempted, but there was no adequate window for choledochoduodenoscopy because of multiple collaterals across the CBD. And HGS was also not possible because of non-significant left-sided IHBRD and intervening vessel also. This patient has an intrahepatic vessels. So what I did was I did a gallbladder drainage using the hot Axios, but even after 72 hours, the jaundice was not decreased and the CBD was dilated. So what we did through the hot Axios, we put a CBD stent, and within 5 to 6 days, LFT become normalized. So now he has gastric outlet obstruction along with the two stent. One is cholecystoduodenoscopy and one stent through the cholecystoduodenoscopy to the lower end of the CBD. Now plan is to do the GJ using the freehand technique.
Sir, can we have a detail of the last case? How many coils and how much glue was inserted? There was complete obliteration was achieved in the gastric varices case.
Yes, so after I went off camera, we checked with Doppler, and it turned out that the varices were obliterated with just that single treatment. So 2 coils, and I think we used, was it maybe 2 cc's of the histoacryl? And that was enough to obliterate, and there was no Doppler flow in the perforator or the intragastric varices. So it was a good result.
Very good.
Okay, now I've inserted the therapeutic echo endoscope.
Professor
I've taken precaution not to push too far in. So you don't want to push into the antrum, because when you pull back, you may pull back your oral enteric catheter. Now, this patient already had a nasal jejunal tube placed. So we're going to use that tube actually to fill the jejunum. And I've never done this like this. Usually I place a 8.5 French oral enteric catheter, and I release the pigtail at the ligament of Treitz. And I make sure that on a fluoroscopy, I see the pigtail at the ligament of Treitz, because that's what I want to target, the ligament of Treitz. You have a natural ligament there that suspends or connects the stomach and the small bowel. So it's sort of an area of natural adherence of the small bowel. So I don't know that I have that advantage, but we definitely already have a catheter in position. And when I insert in my scope, I immediately here see a lumen. So this is the small bowel. You can see, very typical.
Professor?
And yes?
For 30 seconds, we want to shift the last part of 30 seconds.
Okay.
Shift to room number 1.
Where's magnification? Where is that? Here, okay.
Dr. Goenka, you are online.
All right.
So I think
Goenka, you are online.
And the pedal.
And what we did is that we went with a balloon catheter this time with a wire, and we are fortunate in the first go, the wire went up, not into the cystic duct, but into the hepatic ducts. And we are engaged one of the stone, as you can see, and it's almost at the mouth of the papilla. So we'll just show you this removal. And I think for the youngsters, again, the direction of pull is very important. You must pull your accessories parallel to the bile duct. rather than at an angle from the bile duct. So, and I'm moving my body to the right. And you see the first stone has come out.
This is the beauty of the balloon sphincteroplasty, how nicely the stone came out.
Yes.
So thank you, Dr. Goenka. We are going back to the
Nice
USDJ.
demonstration.
Thank you, sir. Thank you. Shift to, yeah, Professor Binmuller, you are online. Professor Binmuller, you are online.
Okay, good. So you can see there's a peristalsis in the small bowel. You can see there's some fluid there. We've already filled a little bit. And the first thing you need to do is get an appreciation of the fluoroscopic anatomy. And we've mixed some contrast in the fluid here. So the fluid is mixed with dye. That's just so that after we do the puncture, we can confirm that we entered the small bowel. And then we've added some contrast, which will create some peristalsis, unfortunately. So that's the only drawback of adding the contrast, which is the reason why I do all of this part in the very beginning through the oroenteric catheter. You know, it's basically a nasobiliary catheter, but we're inserting it through the mouth into the small bowel, not the bile duct. And I have it perfectly positioned at the ligament of Treitz. So in this case, as soon as we get good filling with contrast, we'll get a fluoroscopic image. We're all leaded in the room. And so let's take a look with fluoro. Okay. Still not seeing, let's hold off one moment, wait.
With all of you, there was no tension.
And it could just be it's so dilute. Yeah, it's just really dilute, but it's okay. We're seeing the small bowel. It's distending very nicely. We can see the oroenteric catheter there, right at the tip. This looks very good. Stop now. Okay, now I give always 0.5 milligram of glucagon first, and then when I'm ready to puncture, I'll give the other half. All right, so now let me have the 20 axios. So what we ideally want to have is a trajectory that is, and I'll use the pedal here. So let me have now the axios quickly, because we have now a fairly still, and we have a nice trajectory. You see, we want a longitudinal axis. That's the best, just like this. All right, let's have the 20 millimeter, and let's be quick, because once the peristalsis starts, it's going to become a lot more difficult. So just remember that the small bowel is very mobile. The other thing is, if you need to instill very aggressively, but hold off for a moment. We're going to wait. So let me take, or you doing it? And well, Anthony is different. Anthony knows what he's doing. Okay, so it's been lubricated with some water, so it slides very nicely. And we lost that golden moment, but we'll hopefully get it back again. What's very critical is that you don't have an interposed loop, a small bowel between your target. And don't connect that yet. We only connect the cautery when we're ready to go in, so we don't accidentally, you know, I have all these pedals down here. So here I'm getting that trajectory again, looks pretty good. And so we're going to check our settings really quickly. We have auto cut, and I like effect 7 and 100 watts. And then we can measure the distance, but I can tell it's going to be good. It should be under 1 centimeter. All right. Now, the first step is to advance the sheath out. Just make sure you're not advancing against any resistance. So there it is. You see the tip lengthwise. All right. So now is where the most important is that you very aggressively distend. So you're okay. We'll put the water. Is this the water? Yeah. Okay, good. I'm just going to very aggressively distend now. I'm going to have an assistant hold my scope just like this. You can see the feeding tube in there. So you see it's moving a lot, and that's the danger of this, is if you go and puncture at a moment that it's moving around. Did you give the other glucagon? You gave it or not? Give it now. We need a still bowel. And I just want to make sure, you want to make sure you're not tenting too much with your sheath. And then now we're ready to make it hot. Go ahead and connect. So now it's just waiting for that golden moment. Right? When you have a nice longitudinal view, hold the scope like this, very aggressively. Okay, now I'm ready to go in. You keep stepping on the pedal, please. Keep stepping on the pedal. Hold the scope. Wait. A lot of movement here. So this is the tricky part, you know? Just wait till the glucagon really takes effect. Okay, this is good. Now it's looking good. All right. We start to go through. I'm giving cautery. 1 second. I'm going to have to wait till this ends a little bit better because I'm not seeing. Slow and steady. I'm not seeing any of. I saw the bubbles. I'm in. All right, good. So now I'm going to go a little as deep as I can go. That's why good. I go as deep as I can like this. All right. So now I'm going to lock. We take off the safety pin, right? The yellow safety pin. And now we disconnect the cautery. And now we're going to deploy the distal flange very slowly. We'll just wait till we always do this under vision. Very good. Keep distending. Remember, this bowel is moving all the time. So now I'm going to advance the sheet just a little bit more, just to make sure that I have that. We call that the ramp. We talked about that earlier. 1 second. Okay, now we see the distal flange deploying. There, it snugs up automatically up against the wall. And I'm going to snug it up a little bit more until it deforms a little bit, because a little asymmetric. You can see the cable running through it like that, right? It's a little asymmetric, more on the bottom half than on the top half. All right. So now we can lock again, and we can deploy the proximal flange in the working channel. Okay, so I'm just slowly pulling this back, all very relaxed. Now the proximal flange is deployed in the working channel. Now this is the part where we switch to the endoscopic view. Switch to endoscopic, please. Make that big. Now I'm giving gas, right? I'm turning my body a little bit towards the right, giving gas, pulling away from the wall as I pull this go back a little bit, and then very slowly, as I'm looking for the, I'm pushing it out. You can see it at the top. Just make sure that you do this slowly and you don't accidentally push it in. All right, now this part you can pull back a little bit and push again, and it pops out, or you can push the gray hub down. It both works. So now you see the blue dye. So you know you're in the right place, right? You didn't accidentally go in the colon. So this is looks very nice. You can see it draining. And the final step now is to dilate this tract up. Now you don't have to, because I'll tell you this, if you dilate this, you get some pain. Patient often has some pain afterwards, and you may get some bleeding. So you could leave it and just let it dilate on its own. But if you have a patient who's very anxious to start eating, now when you pull out the cable, what's very important is that you watch and do this under endoscopic guidance. Here you can see very nicely the micro wires that run along the bougie shaped nose cone, and they converge at the tip. That's what gives you that scalpel effect that we talked about earlier. All right, so now using the same scope, we can take a CRE balloon. You can typically use a 15 to 18, and we can dilate up this lumen. So that's optional, right? Whether you want to do that or not. So just to recapitulate, the most important is to be patient. And you have to wait for that golden moment when you have good visualization and you see the lumen in its trajectory longitudinally. And that's really going to give you the greatest rate of success. And if you don't see the bubbles, or you see the axios, can I have the CRE, please? If you don't see those bubbles or the sheath going into the lumen, just sit there for a moment, wait, don't keep pushing, because if you keep pushing, you will push the small bowel away. And then you may make it actually impossible to penetrate through, and that can lead to maldeployment of your distal flange between the small bowel and the stomach wall. Now, if that occurs, it's not the end of the world. If you see that the distal flange is deploying outside of the small bowel, you can resheath. And it's very easy to resheath. Okay, so I'm going to insert the CRE.
Professor
You
Bill
just-
Moller,
Yes.
US guided GJ is always through transverse mesocolon.
I'm sorry, I didn't
You
understand.
always puncture transverse mesocolon if you want to puncture any small bowel loop jejunum from the stomach. This stent go through the transverse mesocolon.
Oh, absolutely, it can. That's why you need to be very certain about your anatomy. That's why it's important to both, confirm with fluoroscopy and with ultrasound. So yes, it has happened many times to many of us where you accidentally go through the colon. That can easily happen.
Mesocolon, not colon.
Ah, you're saying the mesocolon, not the colon itself?
Professor Binmoller,
Yeah.
are you finished or can we shift to
I'm
other
just
room?
going to dilate. So you can do this all with your ultrasound scope. You just need to hook the axials with the, and I'm just having a little challenge doing that, trying to hook it here because of the axis. Okay, yeah. Yeah, usually I can do it with this, but sometimes it's a little tricky. So you see here, you don't want to go through the mesh. Here we go. Now I'm going to get it. Good, I've got it. Okay, advance the wire a little bit. Just look and see, perfect. Not too far, because you don't want to push anything out. Now, when you push in, don't push against too much resistance. Just make sure that you've got most of the balloon, enough of the balloon, I should say, inside.
How much you
And-
want to dilate?
We'll go up to the full 18, but we'll start it in increments. So first with 15, please, so you can start to dilate now. And when you dilate, you want to keep yourself as perpendicular as you can. So dilate to 15, please. Good. So it saddles very nicely, right? Good. And I'm nice and perpendicular. You can push in a little bit to keep that perpendicular. All right, go up to the next level. Okay, 16 and a half, right? No? And then 18. Good. And my nurses usually say, I got some, some resistance or so, and we'll just wait till it gives. All right, 18, go down. All right. And then after this, we should be able to look very nicely into the small bowel. And usually you'll see the afferent and efferent. Good. Okay. But it's not deflating. Deflate, please. Yeah. So this is not like a stricture where you need to keep it inflated for a minute or so. You just immediately go up and then go right back down. Do you want to minimize the risk of bleeding? So we're just deflating. And as soon as it's deflated, so here too, you need to do this with patience. Don't go just pulling this out because you can dislodge the lambs, the axios, and that's the one thing you want to avoid. So you'll see there's some bleeding here, but that's okay. The silicone covering should sufficiently tampen on that. And you can see now, look at that, right? You can see the afferent and efferent limbs there. The afferent is probably to the right and the efferent to the left. So it's a beautiful view of your gastroenterostomy. And we're done.
And now we will shift to the next case by Dr. Sandeep Laktakia.
So this is a 43-year-old male without any comorbidity, presented with.
Yeah, next room. Yeah.
I would
So
now
our
like
next
to
case is a
invite
Another one, yeah.
3-year-old male who presented with
Dr.
abdominal
Charanveer
pain
Singh
in
Grewal,
April
Dr. Manish
2022
Gupta,
without any
Dr.
Yeah,
symptoms
I've never
of
used
weight
that
and
though.
loss of
Dr.
appetite
Tirumurthy,
without
Dr.
other bowel
Alok
habits.
Mishra.
Our blood parameters, they were normal. On CT scan, a heterogeneous mass of approximately 13 into 10 into 15 mm seen in the head of pancreas region with enhancement in both arterial and venous and portal phase. There were no vascular involvement. It is suggestive of NET. So US guided FNA done, which showed low grade NET. So plan is for US RFA of the pancreatic net.
Over to Dr. Sandeep Laktakia.
Hi, good afternoon, everybody, and thank you very much for this case. And so as you heard the story, right, this patient has a pancreatic neuroendocrine tumor, the non-functional variety in the pancreatic body. The size is quite reasonable, less than 15 mm. I have passed my US scope down, as you can see on the screen. You have the US image there, right? Alok, do you have the US image there on the screen?
Yes, we have.
Okay.
Sandeep, what is the area of thermal effect when you do a radio RFA? Will it go up to 3 centimeter? Or
No. So when we do thermal RFA using a EUS, it only ablates the area few millimeters around, about 2.5 to 3 millimeters on either side. And we sometimes burn many areas which then coalesce together to form one single entity, which happens with passage of time. Sometimes everything does not happen in one go.
suppose the lesion is very close to the main pancreatic duct.
Yeah.
Would you like to put a stent?
So Dr. Matthew in the room is asking the question, if the duct is very close, pancreatic duct is very close to the tumor, what would you do? In that case, we will always give this patient a rectal suppository of indomethacin, which we have already given. And if the duct is very close, I prefer to place a pancreatic duct stent up front, usually a day or two before, so that there is no overlap of risk of pancreatitis from ERCP related pancreatic stent versus the procedure related, that is RFA related pancreatic stent. I have now passed the scope deep down into the second part and shortened it up. So what you see on the screen is the head of the pancreas. It looks quite heterogeneous. That's okay. I'm not considering. I think my aim is now to look at the tumor, which is in the body as per the report, proximal body. I did happen to get a glance of it. Here you see that the deeper part. It's deep from the head, but as I come back to the stomach, it comes closer. Can you appreciate that? Okay. Anthony is helping me out to measure the length. This is 13 millimeters in the long axis, and we'll put Doppler. Generally, they are very vascular. We see at the edge of it. No, this is incidental found lesion. But as we all know that surgery means distal pancreatectomy or enucleation depending on the location. This is almost going to the mid part of the pancreatic parenchyma. So this would require resection. Anthony, what do you think? Or I don't think this is for enucleation. In case it was going for surgery, resection. And also the duct, the pancreatic duct is lower down, somewhere here. That's a duct which is going. It's very close to it, very close. So I have to be careful about not to overshoot my target. And yes, please.
The size of your mass.
13 mm.
13 millimeter as, okay, I'll just measure it once again for you. So sorry.
Good morning, Dr. Sandeep, Dr. Monica here. Up to what size we can ablate these tumors?
So up to 18 mm or 20 mm, we can ablate the tumors. We can do bigger size also, but the outcome is not so good. Larger tumors more than 2 centimeters have a chance of lymph node metastasis. That's where all these patients should have a DOTA scan upfront to look for any spread anywhere else. If it's only single tumor or more than, or just two within the pancreas and there are no lymph node spread, then they're justified to be taken up for this kind of a procedure of ablation by US.
Single session or multiple sessions?
So we try to do in one session, but sometimes if the lesion is big or we're not able to do a complete job, few months later we'll do a CT scan and see, because there's sometimes a delayed effect. Can we have the needle now? So we'd like to show the device to you before I go further.
So, camera.
The cameraman can focus. Can I have that? Okay, can you focus this? Radhika is holding this. So this is a Usra from Taiwan, Korea.
Please enlarge the picture.
Yeah.
Can you
see this?
Yes. So this is just like a 19 gauge FNA needle. Exact mechanism is quite similar. It has a handle and a sheath controller and the needle controller. The only difference between the regular 19 gauge FNA, thank you, Anthony. I'm passing it like the cameraman can focus on my hand. The device has a sheath. The needle is inside it. The entire length of the needle is insulated except the terminal 1 centimeter through which the energy is given. So yes,
Can you show the entire assembly? Yeah.
yes. So can you just focus on the tip first? So that comes the needle out. It has two different colors. the tip is 1 centimeter uncovered or uninsulated, and the rest is all blue, which is insulated. Sorry, it's golden yellow. So it comes in different lengths of the active electrode, varying from 0.5, 0.7, 1 millimeter, 1 centimeter, 1.5 or 2 centimeters. And you can choose the length of the electrode according to the tumor size. Most often it's 1 centimeter, which is preferred. It's now fixed to the handle, just like we do the FNA needle. I'll take it back. It has a different locking mechanisms on for both the needle as well as the sheath. This also has also the end of this needle has one wire which takes the current, the white one, and there are two wire tubes. One is blue and one is transparent. The blue one carries the cold water from the connecting agent. It goes through inside all the way to the tip. When the tip gets heated up, the water also gets heated up, but its countercooling mechanism happens, and that heated water comes out to the other channel and then is expelled to a dustbin. So this is an internal cooling mechanism which helps in preventing charring of the tip of the electrode. If this was not there, when we heat this tumor, the electrode used to get blackened or charred, just like we see sometimes in cystotome or needle knife, and that charring prevents the heat to get it transmitted more in an accurate fashion to the deeper parts of the tumor.
It is continuously circulating.
So this is continuous circulating and attached to a saline on a stand. So it has 3 parts total to the whole assembly. This is the needle with the connector which is connected to the saline, and this connector goes to the generator. If the cameraman can focus on this, this is the USRA generator for the StarMed. This is the same generator which is also borrowed for ERCP guided RFA, which Dr. Reddy showed in the morning. And if you see, there's a wattage mechanical control here, which can be increased. Currently it's 35. We can make it more, 40, 45, 50. My preferred is 30 watts, which is little slow cooking, but that's okay. 5 seconds here and there doesn't make much difference. And the entire control is by a button. So the moment we press the button and energize, then we can.
How you decide the wattage?
So
Predetermined or
it's a predetermined wattage, and we can see the burning happening real time on the screen as we will do that. Once everything is ready, connected. So just wait for a few moments more. I'll keep the tumor in my view. So this tumor, the pancreatic duct is going below, so I'm safe. But if suppose the duct was interposing between the tumor and the wall, then I'll be more concerned. In that case, I will definitely post a pancreatic duct stent. Sorry, Saurabh, you had a question?
So if this is 15 millimeters, what electrode size do you prefer?
Yeah, so smaller is always better. We should not be bigger than the tumor size. Even if it's a 5 millimeter, I'm not worried. I can burn at 3 different points. But 1 centimeter is ideal. You go to the deepest part of the tumor, burn that area, and then come back and burn some more area. So in one trajectory, you can have more than one burn, depending on the length of the tumor. We can then torque our scope or fan our needle in a different direction and burn again. Having said that, Doppler at this point is not very useful, because even the burnt area, the bubbles will give some kind of Doppler signals. So the best way to assess that you have done a complete job is do a contrast enhanced US.
Sandeep,
So, yes, Alok.
if the duct is traveling through the tumor and you put a stent, then the stent can also get burned.
But this burn is not so big a burn. Have you ever tried cutting a stent, a plastic stent hanging out from the papilla with a needle knife? It doesn't really cut actually, in spite of the full spark going across.
I have burned my finger during.
So you had a really strong generator, or maybe a strong finger.
Is there any
Dr. Sandeep?
Yes, please.
Can we take the room for a few minutes?
Yes, please.
So we shift to room number 1, where Professor Mustafa is demonstrating. Over to, we are presenting the history first.
So this is a 48-year-old male who is a known case of CLD with portal hypertension without any history of upper GI bleed. On lab investigations, LFT bilirubin is 1.5 and INR is 1. And on endoscopy, you found GOV1F2. So our plan is for US coil and glue.
Okay.
Over to Dr. Mustafa.
Yes. Yeah. Good afternoon, everyone. Again, here doing this case under the control of Professor Rao. You can see I'm already in the position where I can see the fundal varus. You can see really a big bunch of gastric varices. So my target it will be to puncture. So first of all, I will go from the arrow here, going deep. Yes, from here, go down, down. Yes, hopefully till here, and then I will release the first coil, pulling back my needle forward, releasing the second coil here, and then the third here, and then we will finish. Yes, hopefully by a little bit of cyanoacrylate everywhere. So I'm using again a therapeutic linear scope from Olympus. I'm using a 19 gauge needle from Boston Scientific, and we are going to put coil from Cook Medical, followed by the glue. So I will take out my sheath first, like this. Okay. Pull back. So we will try to adjust a little bit my position. Okay. I aspirate. And then I puncture. So yes, and now he will aspirate. You just focus on the syringe. Yes, stop. We have blood. So we are inside the vein. Now it's very important technically to have a very good assistant, because it's now yes, we will inject. And then we will put the first coil. So the coil, you should focus on what he's doing. This is very important to preload. How he's preloading the coil inside the needle. So I should not move. I do nothing now. Yes. I am fixing everything. He just fixed the coil inside the needle and now pushing. You can see now in a couple of seconds. Yes. You just see what he did. He put first of all the fluoroscopy, please, to see the coil. Yes. Very good. Continue. You see it's coming.
Is the fluoro visible? No, it's not.
Yeah. Could you see? Could you ask the control room to show the fluoroscopic image, please?
Fluoro image.
You can see it.
Is the fluoro on there?
Fluoro.
Fluoro. Yeah, fluoro is on.
Okay, so we are pushing the first coil. Yes, continue pushing. Yes, this is very good. Okay, now I will pull my needle few millimeter back.
Sono picture also, please.
So you have less endoscopic, you have less EOS picture. Now I'm in a little bit of the proximal compartment. I will ask for the second coil.
Please enlarge the sono picture. Yeah.
Yes. So you see what he's doing. He's putting first of all the hard external sheath to push the coil inside the needle, just to avoid to make it straight. And then, yes. Now concentrate on the X-ray image. You have the second coil coming. Very good. I will pull a little bit back. Yes, push. Go. Yes. Okay. Now, yes, you finish. I pull a little bit back. Okay, very good. Now, can I put Doppler? So you see already you have less flow. Okay. So normally I combine this by injection now of glue. Yes. So this is the inbound. Yes, this is the ready mixture, the Indian glue, which is very good. So you inject a little bit saline, and then rapidly, fluoroscopy, please. Rapidly, he will inject the glue.
Blue is
Yes.
mixed with lipid oil or just plain?
Yeah,
blue?
It's a mixed with lipid oil, yes. And then flush by water, by saline, yes. You can see now the glue.
We are
Okay.
not getting good sono picture.
Okay, so now what I will do, I will try to adjust my position. Yes. Yeah? I will remove the needle, yes. I will remove the needle. Yes. I will check everything.
We have
Yes. Okay, you put the Doppler here, please. You see?
Sandeep.
Yes, hi, we are
Yeah.
back.
Yeah, back.
So you have the EOS image on the screen?
No, not only your image.
Okay, so can we just provide the EOS image on the screen?
Yeah.
So now you can see the tumor there. So this is a tumor. We all set now. That's the sheath which is pointing out from the scope tip, just like for FNA needle. Thank you, Matthew. Please help me out. So I will now pass a little more. Yeah. I generally want as less as possible. Okay, now locked. Yeah, I'll just make it a little bigger. One more round. No, it's okay. So there goes the needle inside. Can you see it?
It is inside. Yeah. Okay.
Yeah. So the far end, now we can start burning. Start the burn, please. And soon you will see the bubbles appearing here. You see the bubbles coming here already. It's about generally it's not in a cylinder fashion. It all depends on the tissue resistance and other things. Generally, it's about 2.5 millimeters on either side. And it also tracks back. Stop. Generally, it spreads more horizontally. Here it did not. Anyway, so I pulled back the needle a little bit and then I will burn it again. Please start. Staying within the margin of the tumor.
What is the length of non-insulated?
1 centimeter.
1 centimeter. You may come, when you're withdrawing, you may come.
Stop. So a lot of little bit of tissue. So we can actually wattage is to increase. No, badhana tha. Tell me what you're doing. Okay. So yeah, so it was little not deep burn, but anyway, we'll now change little direction now. Since it's a 3-dimensional structure, which we are seeing in 2 dimensions. So I have passed more to the distal side and please start now the burn. Yeah. So now increase the wattage to 30. It was 20 before. And that's why the deep burn was not happening. Switch off. Sorry.
We are not seeing the needle now.
I'll take it out and go in a different direction, little bit different. Because we need to. Yes, that is okay. Little bit.
Some echoic.
Along the track of the needle, it may come out. Okay. Now you start, please. Start. Yes, please start. 30 watts. Okay. So it's starting now.
So now we can see the bubbles. Yeah.
Yeah. Stop. So 3 sites we have burned so far. At about 10 to 15 seconds, when we see enough bubbles appearing and whiteness of that area, then we stop. There's a little bit of challenge with the pumping, and that may be one of the reasons that we don't have a very even distribution of the Yes. Can you start now? I pulled back a little bit.
Bubbles are coming.
Yeah, now. It's coalescing now. Stop. I think this is a very good one. So the three of them probably have joined together now, and I can pull back, and then torque all around and see how it's going. So central part is all gone, and one track it can see. If it's a very vascular lesion, sometimes Doppler at this point may help, but even the burnt area will give sometimes Doppler signals because of the bubbles are effervescent bubbles up here there. And at this time, SonoView is very useful, and we will inject a little bit of contrast. Contrast is ready. So if you see more enhancement inside in one area, we will target that as our final area of burn. This SonoView. So contrast enhancement is very useful during EUS RFA. But never attempt to overdo the things. Never try to cross the margin of the tumor. Let the shell remain. This also will get burnt with the passage of time because of the depth of injecting. Please go ahead. So Rajesh is injecting now. Sorry, just a minute. Just a minute. We have to. Where is that?
So you normally intend to leave some area as a shell protection.
Rajesh, just hold on for a second. Hold on for a second, please.
Yes, sir. Not giving. Okay.
Where is? Okay. So just a minute. Let me get the tumor back in the frame, and then so now we have the tumor back. So on the left side is the B mode, on the right side is the contrast. Please inject now.
Okay. Okay, I'm injecting.
Thank you.
I'm injecting.
So on the right side is very black tumor, but if you have blood vessels, they'll become vascular. You can use the pointer again. So that's a tumor which Matthew is pointing out. Yes, please flush. So it's a periphery which is enhancing and not the center. So that means it is quite okay. Can you appreciate that? On the right of the frame is the contrast image, so which is not enhancing. So that's a normal parenchyma, I think. So that's a good one. Yeah. So we'll keep watching it for a few seconds more in all the phases, and turn a little bit also. I think the main tumor is not enhancing, and that's the advantage of doing a real-time contrast enhancement. And I don't think we need any more burn now in this patient. So I will actually call them 3 months later, get a CT scan first with contrast enhancement. The tumor will shrink in size, even the vascularity will reduce, or sometimes they disappear altogether. If any remnant tumor is there, then I will redo it depending on the size, or sometimes just a scar tissue may remain.
Dr. Sandeep?
Yes, Rajesh?
Can we shift to other room?
I think I've done with the procedure.
Thank you, Dr. Sandeep. And we shift to room number 2.
Thank you.
where Professor Binmoller is going to present.
Thank you.
So 32-year-old male who is a case of acute necrotizing pancreatitis, now presented with loss of weight, loss of appetite, vomiting and early satiety. CT revealed a large one in the lesser sac. So the plan is to do US guided drainage.
Yeah, room number 3. Room number 3. Professor Binmoller, you are online.
Good. I just inserted the therapeutic echo endoscope, and I just passed the pylorus, and I'm going to do a quick survey to look at the anatomy of the pancreas in the head, best seen from the duodenum, of course, as well as the uncinate process, and then we'll look at the body and tail from the stomach. So endoscopically, you can see this is small bowel. And let's switch now, swap it so that the EUS is large and the endo is small, please. So just swap, please. EUS large. There we go. All right, so immediately you can see the IVC and the aorta here, and the spine is over on the left-hand side. And I'm just going to gradually rotate a little bit like this, and just sort of, I push down into the second duodenum. I'm going to actually straighten, so just pull back a little bit so that I could hopefully see some of the uncinate process. And I'm just pulling back slowly. So here's the pancreas. I just don't have a really great view. This is the mesenteric vessels here. I'm suspecting this is maybe a duct. Let's have some Doppler for a moment, please, over this to see if it's it's vessel. Okay. Well, this is obviously where Doppler is so helpful. And I don't want to spend too much time here trying to get the uncinate area, so I may end up slipping out. We're already starting to see the cyst here. I think the issue here is that this cyst is so big, it's really extending all the way from the head, probably to the tail. And these are the situations where sometimes I will consider doing what's called the gateway approach, which is placing 2 stents, 1 transduodenal and 1 transgastric. Now, I don't know that I need to do that in this case. Let me just sort of start to pull back a little bit further into the stomach. In the interest of time here, we want to look at what is the optimal area to access. My preference would be, if I have a choice between transduodenal and transgastric, that I go transgastric. Now you can see this is very large, and there is some necroses, but not really a lot of necroses. And I'm just pulling back towards the tail now, and you can see this extends all the way over to the tail. We almost don't see, this is the spleen. We almost don't see, this is the spleen here. We really don't see any viable pancreas here. Now afterwards you will see pancreas. So what I would propose is that we place a 20 millimeter Axios, and when you're selecting the area to go, it's important to look then endoscopically and make sure that you're not too close to the cardia, so that you're not deploying the proximal flange too close to the cardia. Similarly, if you're going transduodenal, that your proximal flange isn't deployed too close to the pylorus. I'm at 53 centimeters, so I'm likely well below the cardia, but you can just take a quick look with endoscopy, giving a little bit of gas, and you can see here the gastric fold. So this is a good position to be. The next thing you want to look at is throw on your Doppler, and you want to make sure you don't have any interposed vessels. We talked a little earlier about that. So you can see there's a vessel on the left side, and we're coming from the right side, correct. So I'm just pulling back. You can see that the distance is well below a centimeter. And there's a little bit of a vessel up there. We can mag up a little bit. And just look for a spot where we can avoid that one big vessel there on the right-hand side. I think if we go right there in the middle, it should be good. So remember, if we're using a 20 millimeter lambs, the flange is 30. So we need to have 15 millimeters on each side. And you don't want that flange to be where a vessel is. So I think this looks like a pretty good spot to go in terms of access. It's not much. So I actually always prefer to place the largest lambs that I can, so I have optimal drainage. The question here is whether you need a nasocystic irrigation, and it's really not necessary. So for in the case like this, I would dilate, and then I would go inside and then just sort of clean out as much as I can. That probably would be the best way to do this. Now, having said that, I had discussed with Rajesh earlier that when I do have a lot of necroses, then I will place a nasal cystic catheter alongside the lambs. And I will use the same axios sheath to access the cyst alongside the lambs, not through the lambs. So the reason for going alongside is so that after a few days, you can just pull out the nasal cystic catheter. You don't have to worry about dislodging your lambs. And you're also not occluding the lumen of the axios with your nasal cystic catheter. Also, the nasal cystic catheter tends to spontaneously dislodge because you have a 20 millimeter opening and the pigtail diameter is smaller than 20 millimeters. Remember, it was designed as a nasal biliary catheter, right? We use it as a nasal cystic catheter, but it's designed for the bile duct. So it has a very small pigtail, and that pigtail doesn't anchor that catheter inside of the wand. So if you want the nasal cystic catheter to stay anchored, then you need to go alongside, and you don't want to create a large tract. You want it just large enough with the diameter of your sheath, which is 11 French. And then you can place a guide wire once you're in, and then you can place over the guide wire your nasal cystic catheter. The question is today, would you like me to demonstrate that technique? I'm happy to do it, although I have to admit, I don't think we need to do that for this case. Yeah, so it's a little bit, it's said, you know, in these live demonstrations, you still have to follow what's right for the patient. Okay, so I can kind of explain all of these things maybe off, you know, in the course, but I think the way to take care of this today, largest diameter lambs. And why is that? It's because you're going to get some stasis afterwards if you don't have irrigation. I always do irrigation if I have a lot of necroses, always, because it's critical to have a closed circus and irrigate out the contents, keep flow. As soon as you have stagnation, then you'll get infection, and you'll get some food that's going to go inside of the cyst, and you want to have the largest lumen possible. In addition, we are going to place a pigtail stent through the lambs afterwards to avoid any risk of bleeding. All right, so I think we're ready to go now. Enough talking, and we're going to insert the 20 millimeter. So this is something you've seen many, many times now. Let's take the Doppler off here. Switch off the
Can we
Doppler,
have
please.
fluoro picture to see this?
We don't
position
need
of
fluoral. I never use fluoral. No fluoral. I don't have lead on. Yeah, I never use fluoral for
show the
these.
position of a scope to the
No, I don't care what the position is. I see everything here, and I have never used fluoral. You know, so here's the thing. So you should have fluoral as backup available. And I'm just so convinced that we're not going to have an issue that I didn't even put any lead on. So please don't give any fluoral during this procedure.
Only sono and endovision, no fluoro.
But yes, I do agree with having fluoral available if needed. Okay, so now I'm just going to, don't connect yet. I'm just going to advance. And here's what's very important is not to push against resistance. So you can see it's coming out the sheath at the very top. And now we can make it hot. So now you can connect. And then we just want to look one more time for the best spot to go. And I'm going to just check one more time where I am on my edge. Good. It's 48. I think that's okay. We're not too close. This might be a vessel right there. So let's switch on the Doppler again. Yes, it is. Right. So I'm going to push in a little bit. I just need to take a little bit of time to find the optimal place. Let's turn off the Doppler.
Use fluoro during system.
Yeah, for pseudocyst drainage, I can or walled up necroses, I've honestly never had to use fluoral. Okay, we make sure our settings are correct. So we have auto cut, right? Usually I use effect 5, and Wattage usually maybe 50 or so. All right, I think I'm in good spot. I'm going to have the assistant just kind of give a little bit of traction like this. So you just kind of push up against like this when you step on this, and you just gently advance forward, and now it's fully in. You can recapture your view like this. It's far in, you can lock. You can take off the safety now. We have a lot of room. Now I'm going to deploy the distal flange. Distal flange is fully deployed now. It's already snugged up on its own. You can snug it up a little bit more by pulling back the black flange. Everything is connected and locked together. So you have to unlock again for deployment of your proximal flange in the working channel. So I'm doing that now. So I'm just pulling back. By the way, take that off. So that should always come off immediately after you're inside. So there's never accidental that you might step on cautery by mistake. The proximal flange is now deployed. Now we're ready to switch to the endoscopic view. All right. So then I'm going to unlock the black hub. If I can have the endoscopic view large, please. There we go. Now I'm giving gas first, right? I'm going to try to pull myself a little bit away from the wall. And as I do this, I'm going to watch the proximal flange deploy. So there it is. As soon as I can see the proximal flange there, I'm advancing until it pops out. Pull back the black a little bit and pop it again, and there it's off. Now here, I'm just going to sit. You can see there's a little bit of deformity. I'm coming at a very sharp angle. So what's important is not to just yank this out. If you do that, there is a small risk that you might pull out the lambs. So you don't want that to happen. So just wait, kind of get yourself back into a good position. We're coming a little tangential now. I'm just turning myself around a little bit, giving a little bit more gas. And until I can get sort of a nice view, there we go. So I want to be able to see as I'm pulling out.
Thank you, Professor Binmoller.
The cable.
Thank you. And we are shifting the last case.
Okay.
From Professor Anthony Theo.
Okay, great. There's the nose cone. It's out.
So
And
our
then I'm
next
just
case
going to
and the
dilate
last
up.
is a 46-year-old male for history of open coli in 2018, had multiple CBD stones with partial CBD clearance. The last cholangiogram revealed 2 large stones. So our plan is for ERCP, cholangioscopy, plus minus lithotripsy and CBD clearance.
Over to Anthony Theo, please.
Hello, hello. Can you see me? Can you hear me?
Yes, sir.
All right, so I have a patient with multiple CBD stones. I've pulled out the stent and cleared some small stones. Can you see the X-ray? Can you see the X-ray? If you see the X-ray, let me know. Can you see the X-ray? Hello, hello. No response.
Yeah, you are audible.
Can you see the X-ray?
Yeah.
So on the higher level, there's a maybe 2.5 times 1 centimeters sort of rectangular shaped stone. So I think this may be difficult for BML. So the plan is to do a spyglass plus laser lithotripsy. Do you have my endoscopic view?
Yeah, you have scopic view.
So you can see we've already preloaded the spyglass and with the laser fiber. So this is important because once inserted into the bile duct, sometimes it's very difficult to advance the laser fiber. So here I'm going to try to cannulate freehand. So with this cannulation, we try to angulate the spyglass as much as possible. Okay, can I have fluoro? Fluoro? Okay, yeah, relax. All right, okay. Okay, so you can see the soy glass going up, I think. Okay, can we have water irrigation?
Over the wire we should go.
Okay, so this is a pie glass. Do you want to help me control?
You got the fluoro.
You control? Okay. So can we have the lumen?
Now you have
Okay.
got the lumen vision.
So you can see this is the lumen.
Can you enlarge the lumen view?
So can we have the fluoro as well?
Yeah.
All right. So I'm advancing towards the highlight area. So this is almost at the takeoff. So I'm going to pull back a little bit. And we can try to find the stone. Okay. So this is the origin of the left fluoro, please. Okay. Pull back some more. So far, we're not seeing any stone.
Is the stone in the cystic duct?
Possible.
Because in cholangiogram also we have not visualized a big stone. So there's a possibility the stone is in the cystic duct.
So, okay, I'm going to push in a little bit. We turn right a bit more. So let's see if the cystic duct is here. Okay, I'm going to pull back some more. Okay, and let's see if we can see the stone. Yeah, we sort of thought about this just now. No. Yeah, possible. Okay, so let's inject some contrast from here. So I think we are like at the origin of the cystic duct, right there. So we're gonna inject some contrast right at the origin. Yeah, the contrast is coming. See, you can see the
Enlarge this fluoro
filling
picture.
defect. Yeah. But maybe it's in the cystic duct and not the bile duct. Capture? Okay, capture. So what do you guys think? Do we need to clear this stone? So we check again. So this is the origin. Okay, we go to the bile duct. Okay, this is the bile duct. Looks like nothing. Suction? Yes. Perfect. Suction. But so far, there's nothing in the bile ducts. Okay, let's go a bit higher. Let's go to the right side. The right side. Yes. Okay, right side. Yeah. Right side. Higher. Okay, so right side, all clear. Fluoro. Fluoro. Okay, capture. Okay, nothing here. Pull back. Check the left side. This is left side. Advance. But also, I think nothing, right? Okay, so I think our job is done. What do you guys think? Diagnostic cholangioscopy.
Both ducts are clear.
Yes, everything is clear. No stenting required.
Excellent demonstration of both the ducts.
All right, thank you very much. Okay, let's finish. Let's suck out everything. Suction.
If you enlarge the lumen vision, lumen picture.
Okay, thank you. Thank you. Convincing. Okay, thank you very much.
I would like to thank the demonstrators and the chairpersons for the support. It is time for a lunch break, and the last phase of the conference will start at 2:45 p.m. sharp.
I know, but
cooperative scientific copy in their management. We are going to present this case. 79-year-old male presented with recurrent epigastric pain and vomiting for last 7 months.
Okay. Welcome back from lunch break. We will now be starting the last phase of the conference, that is the IPBC 2023, the Best Interventional Videos Forum. I would like to invite as jury members for the forum, Dr. Pankaj Desai, Dr. Vinay Dheer, Dr. Matthew Philip, Dr. Sandeep Laktakia, Dr. Sandeep Nijavan. The first presenter is Dr. Jayanta Samanta. Dr. Yogesh Sharwani.
It's a 5 minutes presentation and 2 questions. 5 minutes.
So I request all the presenters to please stick to the time. Thank you.
So good afternoon, everyone. First of all, I would like to thank Dr. Rajeshpuri for the opportunity, respected juries and friends. So today I will present a video on US guided biliary drainage, stent migration. Stay cool, don't lose the guide wire. So this is a 50 years old female, known patient of chronic calcific pancreatitis, presented with pain abdomen and obstructive jaundice with a significant weight loss. On examination, she was hemodynamically stable, but she was icteric and pallor was present. So the other blood investigations were all normal. She was not in sepsis. And CA99 was more than 5,000 with a total bilirubin of 13, showing obstructive pattern. So this is the CT image, which shows a large cystic and malignant neoplastic lesion in the pancreatic head and periampullary region. In the background, chronic calcific pancreatitis. So we took a US guided FNAC, which was suggestive of adenocarcinoma. So this is my video. So because there was involvement of the periampullary region, ERCP was not possible. So we planned to do a US guided procedure. So the initial choice was hepaticogastrostomy because there was duodenal infiltration around the periampullary region. So I selected a area in the segment 3 of the liver, punctured it, and according to the usual procedure guidelines, we passed the guide wire, injected contrast, and there was nice opacification of the bile ducts, which will come. So here you can see there is a nice opacification of the biliary tract, and we could pass the guide wire through the CBD into the duodenum. But what happened was we dilated the tract. Then when we started deploying the stent, I could not get across the stent across in the CBD. So when I finally deployed the stent, most of the stent was in the stomach, and there was a proximal migration into the stomach, and the uncovered segment of the geobore stent could be seen at the junction of the stomach and the liver. That means, so the bile was draining into the peritoneum. And because there is a long segment of the duct inside the stomach, even if we had the guide wire, we could not do anything. So there was nothing practically we could do in this situation. So I took out this stent and I closed this defect. Now, then I thought, next, what should we do? Because the system was dilated, there was we had injected contrast, and there was little bit of bile leak also. So somehow we had to decongest the system. So next I thought we'll do a choledochoduodenostomy, because from D1, the picture was clear. So in D1, again, we did as per the usual guidelines. We punctured the CBD and put contrast and dilated the tract with a 6 French cystotome. And initially we tried secured the guide wire. And initially we tried to put a 6 centimeter partially covered stent. But that day my luck was bad, the stent didn't open. The 6 centimeter stent didn't open. So next I had only a 4 centimeter stent. So I chose a 4 centimeter stent. Now with the 4 centimeter stent, the problem was it's very difficult to adjust. Some part inside the CBD, another part has to be in the duodenum. So when I finally deployed the stent, the duodenal portion of the stent was inside the duodenal wall. So the video, So as we deploy the stent, we lost the view. And when we finally deployed the stent, as we will see now, the metallic portion, the distal segment, was in the duodenal wall. But I was lucky, the guide wire is there, and through the guide wire, we put a plastic stent. And luckily, I could see the thread of the stent. So I caught hold of the thread of the stent and pulled it out from the duodenal wall. So you put a 7 French 7 centimeter double pictal stent, which nicely anchored the stent, the metallic stent, into the duodenum as well as inside the liver. I'll fast forward it a little bit. Then we took the biopsy forceps, we caught hold of that thread and pulled out the stent. And we successfully could do that, and so we could salvage. Sorry. So this was the final position of the stent. We could have at least 3 diamonds inside the duodenum. And this is the final position of the stent. So here it was very important to have the guide wire in place. So we could put initially the plastic stent, and then we could pull out the metallic stent as well. So post-procedure, the bilirubin decreased from 13 to 3, and you could discharge the patient without any untoward side effects. Thank you.
Why you chose hepaticogastrostomy first?
Because there was duodenal infiltration, and because we thought
was dilated till the lower end, so you could have tried choledochoduodenostomy, gastrostomy.
Because in due process of time, because it is a malignancy, the duodenum might get obstructed. So
you did the same procedure later.
Yeah, we did that because it was no other option was available.
No other option. That would have been the first option.
Yes, we could have done that. Retrospective thing.
And why you chose the 4 centimeter?
I didn't have any other stent that day. I had one 6 centimeter and 4 centimeters. I was unlucky the 6 centimeter didn't open up, so I used the 4 centimeter.
And why didn't it open up? Any reason?
There was some technical difficulty. The stent could not be opened up inside.
Sandeep,
Brave person. Congratulations. You really did not lose your cool during all these problems.
Yes.
So these were technical issues. Most of the things why the stent did not
Oh, yes, sir.
open, why the HGS did not deploy, subtle technical issues. But otherwise, I think in the end, you managed it well.
Yes. Thank you.
One small thing,
Sir.
if I can ask. Could you have cannulated the uncovered portion of the HGS and
Yes, sir.
gone inside and then drained hepatic only?
Oh, yeah, that was an option, but with that long segment of the stent inside the stomach, technically how feasible it was. So I thought.
And sometimes it's a 5 French double pigtail is a better than a 7 French in the end for anchoring, because the 7 may snugly fit in the stent and again we push it.
Yeah, you can push it inside. Yeah. Okay. Thank you, sir.
Very nice.
Top three decided by the jury will be awarded here by the jury themselves. So Dr. Jayant, please next. In the 5 minutes, we need to stop the presenter. 5 minutes.
You can play this. Good afternoon, everyone. We present here a case where we
Can you
hunt
increase
for
the
the
volume?
pseudoaneurysm in a vascular maze using endoscopic ultrasound-guided angiotherapy. Chronic pancreatitis is known to have multiple vascular complications involving both the arterial and the venous system, but the coexistence of both the venous collaterals and the arterial pseudoaneurysm within the same anatomical field is rare and can be a therapeutic nightmare. We present here a 43-year-old gentleman with chronic calcific pancreatitis with exocrine insufficiency who presented with melena and generalized weakness for 15 days. He had postural symptoms with a hemoglobin of 5.6 gram per deciliter with history of 4 units of PRBC transfusion before being referred to a center. After the initial resuscitation, an upper GI endoscopy showed no evidence of gastric or duodenal varices. Hence, the patient was taken up for a CT abdominal angiography. On CT angiography in the arterial phase, a gastroduodenal artery pseudoaneurysm was noted of size 1 by 1.2 centimeter, which was confirmed on a 3D reconstruction image. Interestingly, on the venous phase, there were multiple collaterals which could be seen forming a cavernoma, and this cavernoma was literally surrounding the aneurysm, forming a vascular maze. Thus, after a multidisciplinary team discussion, it was concluded that the patient was not a suitable candidate for intervention radiology because of the narrow neck of the aneurysm, as well as the surgeons were not keen to go forward because of the multiple venous collaterals, and hence the patient was planned for an US-guided angioembolization of the GDA pseudoaneurysm. So on linear US examination, we found that there were multiple collaterals that were seen in the area, and it was very difficult for us to target the pseudoaneurysm per se. There was a partial thrombus of the portal vein was also noted. And hence we decided to kind of map the vessels using power Doppler in order to try to locate the pseudoaneurysm which was hidden in this vascular maze. So one by one, all the suspected vessels were tracked down with using the power Doppler. Looking at the pattern of the flow, which was a continuous one in case of venous collaterals. Eventually, we were able to locate the pseudoaneurysm. Here we can see in the right upper hand corner. And as we applied the power Doppler, we could see the classical arterial flow in the power Doppler. Once we have finalized that this was the pseudoaneurysm, we followed these standard steps of US-guided angioembolization, that is puncture with a 19 gauge US needle, followed by deployment of a single nested coil. Once the coil was deployed, we applied a power Doppler once again. To look for the flow, we found that there was still adequate flow, and hence we decided to go ahead with injection of 2 ml of cyanoacrylate. Once that was done, there was complete obliteration of the pseudoaneurysm. This is a follow-up US at 48 hours, where we can clearly see the coil, the GDA, the patent gastroduodenal artery, and there was no presence of any pseudoaneurysm per se. This is a post-procedure CT angiography, which showed the coil artifact and was confirmed on this reconstruction image, where we can see the coil deployed inside the pseudoaneurysm. On follow-up, the patient is doing fine and there's no fresh bleed. In conclusion, careful evaluation of the vascular anatomy on EUS with the use of ancillary tools can yield intricate details and optimize the management decisions. And US-guided angiotherapy using coil and glue is a safe technique that can be used effectively to both diagnose and treat such complex conditions. Thank you. Good afternoon, everyone. We present here a case where we hunt for the pseudoaneurysm in a
good case. What are your thoughts, or why you chose coil plus glue rather than, because interventional radiology majority time would use glue and lipiodol, so that they can see the flow in real time on radiology, on fluoroscopy, and but where exactly it is getting blocked. So I think that or thrombin, both can be used, because this was not a very big pseudoaneurysm. So any thoughts on that, or why
Yeah,
you chose that?
Yeah, I think that is the reason why first I placed the coil, because there was not much space inside to place a repeat coil. So after the placement of the first coil, I again put on the Doppler. I found that there was still some flow, and as a result, I just injected 1 ml of glue to just add on to that coil, so help in obliteration of the pseudonism.
Good case, Jayanta. Do you have any experience with thrombin?
Sir, I had used twice thrombin. I have used majority of all the varix and pseudonisms, whatever that I do with coil plus glue. But I agree, sir. Thrombin would be
Easier.
Would be a good option.
Need
Yes,
a
sir.
bigger needle and works.
Saves your needles.
Pretty good. Yeah.
Yes.
For smaller pseudonism, thrombin, I think would be better actually, because the thrombin would stay there.
Right, sir.
And there may not be need of two things, that is coil as well as glue.
Okay, sir. So, but thrombin sometimes they tend to recanalize. They tend to dissolve away, and then again the aneurysm gets back. Sometimes it happens. I agree with you, sir. Coil plus thrombin would definitely be a better option, because by that time the clot must have formed inside this thing. Okay,
Dr. Chalapati Rao.
Next presentation.
Audio भी है. There is an audio.
Papillary mismatch neoplasm and role of US and intraoperative pancreatoscopy in their management. We are going to present this case. 79-year-old male presented with recurrent epigastric pain and vomiting for last 7 months. Ultrasound showed a solid cystic lesion in pancreatic head region, which was subsequently confirmed on contrast-enhanced CT scan of the abdomen. CT scan showed complex solid cystic mass lesion in the head of pancreas, which was later confirmed on US. The lesion was seen to be communicating with NPD with a duct diameter of 7 to 8 mm. Fluid MLA and CEA were high with no malignant cells. Patient underwent pancreaticoduodenectomy surgery and intraoperative pancreatoscopy was done to assess any synchronous or skip lesions and assess the resection margins before an anastomosis was taken. This is the final resection specimen, and intraoperative pancreatoscopy was done, and pancreatoscope was introduced into the main pancreatic duct. MPD appears to be a little bit dilated, and under careful vision, pancreatoscopy was directed along the course of main pancreatic duct till the end to reach the tail region. So there are multiple grape-like structures which are noted in the main pancreatic duct, which we can see in the tail region of the pancreas, indicating that there are skip lesions in the main pancreatic duct also. Before the instrument was introduced through the channel of the pancreatoscope, and multiple tissue bites were obtained and samples sent for histopathological examination. These tissue samples were standard protocol. So around 5 pieces were taken from this region, and then pancreatoscope was started gradually withdrawing along the course of pancreatic duct, and careful inspection of the ductal wall was carried out. And again, at one of the side branches, we started seeing these grape-like structures indicating another skip lesion of IPMN. And again, multiple biopsy samples were taken using SpyBite Max forceps. This sample was sent in another formalin bottle to the lab for histopathological studies. And there were no other lesions noted, and the resection margin was otherwise negative for any residual lesion. After this procedure, anastomosis was carried out by surgeon and patient was shifted to intensive care. Pancreatoscopy biopsy showed surface epithelium which is lined by foveolar epithelium which is mucous secreting. There was submucosal gastric gland suggestive of IPM and gastric, that is pyloric gland variant. Surgical specimen showed pancreatic node cells and hyperplastic mucus secreting cells with ATPR suggestive of IPMN. So in this case, we have diagnosed IPMN using EUS and FNAC. Intrapancreatoscopy helped us to detect more skip lesions. We wanted to extend the resection margins, but given the high risk of this patient and advanced stage, we have actually suspended this idea. Intrapancreatoscopy is helpful in detection of skip lesions and synchronous lesions and assess the resection margins, and you could alter the management in 13 to 62% as per the recent meta-analysis. Thank you.
Nice case, Chalapati. So these lesions were side branch IPMNs or they were main duct IPMNs?
Yeah. So as I've shown, the entire duct looks a bit dilated. So probably the main lesion was a main IPMN, but the ones which are at the mid body, it looked at the junction of MPD and the side branch. So probably some lesions were extending into the side branch. We couldn't get across because of the diameter of the scope. But the one which is at the tail region is at that probably there is some skip lesion in the MPD itself, because we could.
Why I'm asking this is that there is absolutely no mucin in the main pancreatic duct. It is beautifully clear. Normally, that duct is so filled with mucin that you don't see anything. That's a practical problem. So you were lucky that there were no mucin.
True. So probably we had the same thing. So I discussed with the surgeon. Surgeon was next to me. So probably what he also said, and he showed something like it looked like a mucin which was actually coming out immediately when he actually started resecting it. So probably the mucin which was there, it was all aspirated and sucked out. So that helped in our vision.
One more question. So you did this intraoperative pancreatoscopy, and then you said you took biopsies.
Yes.
So were they sent for frozen for immediate diagnosis, or because anyway the resection was going to take place?
Yes. So as I said, given the advanced age, ideally he needed a total pancreatectomy, but they look benign. They were not very big. And this was not reported on CT scan or previous EUS. So we wanted to keep this patient under follow-up. But carried on with the at least anastomosis because at least the resection margin was negative. We didn't do any frozen. We did not have frozen at our hospital.
What surgery was done?
Sorry, sir.
What surgery was done?
It is a pancreaticoduodenectomy. Whipples, yeah, Whipples. Yeah, thank you.
Dr. Jurgis.
Good afternoon. US-guided puncture of impacted stone extraction balloon, a novel rescue. Stop the voice. So I'll be presenting US-guided puncture of impacted balloon. I thank my co-authors. Nothing to disclose. So 45-year-old male presented with obstructive jaundice due to choledocholithiasis. ERCP and CBD clearance and stenting was planned and attempted. After successful stone removal, inflated balloon got impacted proximal to distal CBD inflammatory stricture. And this occurred due to inability of inflated balloon to deflate due to dysfunction in air inflation and deflation channel of stone extractor balloon. Multiple attempts failed to remove inflated balloon through CBD stricture. So what we did, we removed the side view scopy, leaving the balloon catheter in situ. Puncture of inflated balloon was attempted through direct cholangioscopy by passing variable endoscopic accessories like biopsy forceps and sclerotherapy needle, but this also failed. So inflated balloon was visualized as double layered hyperechoic wall convex structure, and it was punctured by 19G EUS needle and successfully removed. So this is the video in which a standard ERCP was performed, cannulation followed by sphincterotomy. Here we can see dilated CBD with a filling distal defect, a distal filling defect and an inflammatory distal stricture. CRE balloon was done for further sphincterotomy, for sphincteroplasty. Stone was extracted, CBD was cleared on occlusion cholangiogram. But when we tried to do a balloon sweep, we could not remove the balloon and multiple attempts failed. So we decided that we will cut the balloon catheter, and this balloon catheter was left in the duodenum. At that time, we didn't have cholangioscopy. So what we did is we used a pediatric gastroscope, thin scope, and we entered into the bile duct. We were fortunate to enter within the bile duct. And then we tried using multiple accessories like biopsy forceps and sclerotherapy needle, but we failed. We could not puncture the balloon as there was also a stricture and balloon was not visible. So we took our EUS scope, and through D1, we could visualize this convex structure, which was double layered. And then by using a 19 gauge EUS needle through D1, we punctured this balloon. So once the balloon was punctured, we can see hyperechoic waves which were circulating within the CBD after puncture. And then the balloon was removed, followed by stenting. So clinical implications, various accessories dysfunction, malfunction related complications are frequently encountered in endoscopy practice. Keeping an open mind and careful thinking which justifies use of available accessories and scopes help to overcome such rare accessories related complications, avoiding surgical exploration. To conclude, confirming proper functioning of endoscopic accessories before therapeutic procedures may avoid accessory-related complications. Avoiding panic, careful thinking, and involvement of available endoscopy colleagues are key features to overcome many procedure-related complications. And EUS-guided puncture of impacted stone extraction balloon is a good rescue technique and can be considered when other methods fail. Thank you.
The balloon was of which company? It was quite
Sir, so it was a Shaili endoscope.
Now, normally it gets punctured very easily, you know. So it's a good company balloon, that's for sure. But what was the technical hitch?
Sir,
what was the technical glitch that it didn't?
Sir, basically we talked to the company people also. They told that inflation and deflation channel might have been obstructed because of some particle, which they could not justify their answer. But we were neither able to inflate the balloon further nor deflate also, sir. So it was a accessory related issue.
This is a very common scenario. If you have done your surgical term, so when you are removing Foley's catheter, this happens a lot of times.
Yes.
So the easier thing would be you have to take a Savory wire, put the backside and introduce it through the channel. Usually the block gets over and you can get away with it. That is what is possible.
Yes.
So you can have a long Savory wire and do it with that. Instead of, this was a good salvage technique, but it could have been easier.
Yes.
That wire should not go deep into perforate the bile duct also. So you have to be careful.
You
Under fluoro.
Yeah, you can have a fluoro.
Okay,
Nice
thank you.
case. Thank you.
Dr. Sridhar, please.
So very good afternoon. I'll be presenting EUS guided pancreatic duct intervention in internal pancreatic fistula. I'll be presenting two cases. So the first case is a 33-year-old male, history of acute necrotizing pancreatitis 3 months back, presented with a right massive pleural effusion with was of course high amylase. He was admitted under the surgical unit elsewhere, given octreotide, intercostal drain. An MRCP was done which showed a pancreas divisum with a tract leading into the right pleural cavity from the PD. There was no improvement with conservative management. ERCP was attempted there, but it failed. This is the MRCP. Again, we attempted MRCP, a pre-cut sphincterotomy was extended, but then again it failed, and we planned for an EOS rendezvous, and it failed to consider for surgery. So this is the image. This is an undilated duct. It's around 1.7 millimeters somewhere in the neck of the pancreas. We used a 22 gauge needle to puncture the pancreas. So after puncture, we directly injected contrast into the duct, which delineated the pancreatic duct in its entirety. And subsequently, 018 guide wire was passed across the PD into the duodenum. You can see on the fluoroscopy now. Subsequently, a duodenoscope was introduced, and of course, with caution, and we grasped the wire with the help of a tattooed forceps, and we pulled it through the channel. And once it was inside the channel, we were able to introduce an ERCP cannula over it, changed the wire to a Visiglide wire, which was passed till the tail. A pancreatogram showed a leak from the tail of the pancreas. We did a sphincterotomy, and subsequently a stent was placed bridging the site of the leak. So after successful stent placement, the drain, of course, reduced over the next 7 days and could be removed. The patient was discharged and had no recurrence of symptoms at 1 month. And he was, of course, counseled about alcohol abstinence. At 8 weeks, we removed the stent, which showed a healed site of leak. Again, this is the second case is a 30-year-old male, again, a chronic alcoholic, presented with severe pain in abdomen with abdominal distension. This time found to have ascites, which was high amylase. An MRCP was done elsewhere, which showed an atrophic pancreas with a dilated MPD, again with a stricture in the head of the pancreas, with a partial PVT and gross ascites. Again, conservative management was initially tried but failed. ERCP attempted at an outside hospital failed due to difficult position of the papilla. It was extremely rightwards. Again, ERCP was attempted at our place. We failed. We tried a minor papilla cannulation. We did a pre-cut also of the minor papilla. Again, failed. So we planned for an EOS rendezvous in view of CP and pancreatic ascites. So you can see here the duct is dilated in the neck. There's a stricture right below that. There's a small collection in the region of the neck. Again, free fluid. So we took puncture this time because it was dilated with a 19 gauge FNA needle. Subsequently injected contrast, and you could see the leak from the body of the pancreas with a stricture in the region of the neck. The tract was dilated with a 6-French cystotome, and we thought we can negotiate the wire down to complete a rendezvous, but the wire kept getting stuck in the stricture and it could not be passed below. And hence we did a anterograde transgastric stent placement in this patient, and a PG was done. And you can see the stent in the pancreatic duct. Now, subsequently, of course, post-procedure patient was stable, abdominal pain settled, and the ascites resolved over 2 weeks. But around 3 weeks after the procedure, the patient came out with a stent that was accidentally vomited out. Patient was asymptomatic then, no pain or ascites. We did an ultrasound, which showed only the PD being around 4 millimeters. We discussed the possibility of recurrence of symptoms due to a dominant stricture, and we planned for an ERCP and stent placement. Now, this time around, again, we somehow were able to cannulate. Now, we used a stone extraction catheter for cannulation. There was a tight stricture which was across which no accessories were able to pass. We were able to dilate it with a cystotome, and a stent was placed. So we know that pancreatic fistulae are complex. They require, often managed conservatively, and usually they do resolve, especially in the setting of acute pancreatitis, 60% internal and 80% external. But most often the intervention that is required is ERCP with PD stent placement. And again, the clinical success varies for high output and low output fistulae. So EOS pancreatic intervention is an alternative, and there are various techniques for EOS intervention. And of course, we try to prefer doing a rendezvous in these situations. So if you look at data for EOS PD in internal pancreatic fistula, I could only find 3 case reports on a literature review. In both our cases, there were 2 PGs and 1 rendezvous. In our case, one was a rendezvous, another was a PG, and clinical success was achieved in both. So EOS intervention can be a rescue approach. Although technically challenging, it is possible even with an undilated main pancreatic duct, and EUSPG may be a salvage in situations where rendezvous is not possible. Thank you.
They're nice cases. Would you have considered draining the pseudocyst in the tail in the first case rather than trying to attempt USP?
There was only one, it was a small pseudocyst, sir. It was around 3 centimeters in size. So, which is why I chose the duct and not.
Duct is also very.
Agreed. Both were difficult. So, I had to make a choice.
Thank you, Dr.
Thank you, sir.
Radhika,
Thank you.
please. Radhika.
So good afternoon. My case is a US guided drainage of a perforated gallbladder in a patient with a hilar cholangiocarcinoma, post-biliary uncovered SEMS placement. Acute cholecystitis in a patient with a hilar cholangiocarcinoma has a multiple etiologies, and it includes a cystic duct involvement by tumor, post-biliary SEMS placement, and calculi. GB perforation due to acute cholecystitis is rare with high mortality. Standard management of GB perforation includes surgery or percutaneous cholecystotomy. But as we know, US guided drainage of a GB has been reported as a safe and effective alternative to PCC in a patient with acute cholecystitis who are not candidate for surgery. So we had a 74-year-old female with diabetes and hypertension. She was presented with obstructive jaundice. Her LFTs were deranged. On MRI, it showed GB with a calculi, and there was a hilar stricture. USG FNA from liver lesion was positive for malignancy. So she underwent ERCP and bilateral uncovered SEMS placement. It was placed side by side. However, after 5 days, she presented with a fever and right upper quadrant pain. On examination, mild guarding was felt. She was in hypotension. Her WBC count were significantly raised, but LFT were improving. On CECT abdomen, it showed calculi in a GB, bilateral SEMS were there in C2, and there was a collection around the GB which was extending into the right perinephric space. As that patient having a multiple comorbidity and she was in a stage 4 malignancy, we planned for a US guided drainage of a perforated gallbladder. So you can see the side-by-side stent on endoscopy view. And here is a partially distended GB with a calculi, and adjacent collection is also seen. We could not see the defect on a gallbladder, and this collection was a big collection. It was around 6 centimeter by 3.4 centimeter. The wall thickness of GB was 4.9 mm. Here you can see, and distension was 3 centimeters. So it was adequately distended. This is a scope position for a drainage we have taken, and with electrocautery tip under US guidance, GB was punctured. So you can see the position of electrocautery device. Distal flange was open under US guidance. There was no much space to manipulate the hot exhaust, but we could manage it. And the proximal flange was deployed under endoscopy guidance. You can see the free flow of pus coming through the gallbladder. And in this patient, we have placed 8 French 5 centimeter double pigtail stent in a GB through axios. And we also drained this pericholecystic collection, as it was a big collection, and it was punctured with a same electrocautery tip of a hot axios device. And here under fluoro guidance, 035 guide wire was coiled, and another 9 French 5 centimeter double pigtail stent was placed. So if you see the type of gallbladder perforation, there are 3 types. Type 1, type 3 should go for surgery, but in type 2, there is alternative that PCC can work. But in this patient, we took a liberty to drain perforated GB and collection with a US guided, under US guidance, and the LAMPS was used. So US guided drainage is feasible and effective in a patient with a perforated gallbladder. This technique offers a safe and minimally invasive alternative to standard management of GB perforation, such as surgery or PCC. Pericholecystic collection can be drained using the same electrocautery device of a LAMPS as a cystotome in same patient and in the same setting. Thank you very much.
Radhika, nicely managed.
Thank you, sir.
We in the morning just had a wonderful discussion on the same topic. Dr. Ajay Kumar presented
Okay.
and showed us the literature. And the literature as well as the experts, including Ken, said, please don't do lamb's placement in a perforated gallbladder.
Okay.
So what do you have to say to that?
Sir, as I showed, there are 3 types perforation. In type 2, definitely we can try, sir. And there was a localized collection. So the studies have shown that PCC and PCD works well in type 2. I'm not talking about type 1 or 3, but in type 2. So this can be.
Recommendations are used percutaneous. These patients are very sick. I mean, you did a great job. I'm not saying that. It's a lovely video. I loved seeing the pus coming out from there. But the audience should get a right message that if you have such a bad patient which has a pericholecystic collection, better to go by percutaneous route.
What is the follow-up for the patient?
She's fine, sir. We did not do a repeat CT, but she's fine.
How many days?
1 month has over, sir.
And yeah, I think I agree with Vinay that even the second collection, you did not drain it internally. You should have just kept a drain from outside. That would have settled all the purposes.
But after PCD or PCC, Miss, what was the follow-up like? Should
It maybe it can cause a fistula, and once you remove the drain, things would have settled down. I don't think that should be a problem. The problem was to salvage the patient. So only a percutaneous drain in the gallbladder as well as the collection would have been good enough.
Okay.
No, great case, but thank you.
Dr. Arpit Sastry.
Thank you all the organizers for allowing me to present on this forum. Hello, am I audible? So we'll discuss about a complex case of spontaneous CBD perforation with multiple biomas and how we managed it. So bile leaks are associated with intense inflammation, or they may be secondary to infection. They are usually associated with a high mortality until they are timely diagnosed and treated. Spontaneous perforation, they do occur, but usually at the level of gallbladder, and they are usually gallstone related. However, spontaneous CBD perforation can also be seen, although it is a rare entity. So we'll discuss about a 54-year-old male who was referred to us from outside with complaints of pain, abdomen, jaundice, and fever. The initial findings, the initial emergency evaluation revealed that the patient was in cholangitis, and the emergency ultrasound showed the evidence of choledocholidiasis. So patient had also underwent an MRI outside, but unfortunately we did not have the films and reporting at that time. So based on the ultrasound finding, we did the ERCP for this patient, which revealed evidence of multiple stones within the CBD, along with evidence of contrast extravasation, which we attributed to bile leak. Subsequently, meanwhile, when we received the MRI abdomen of this patient, it revealed evidence of multiple intra-abdominal collections. We did repeat the cross-sectional imaging in our institute, which showed the CBD stent in situ, along with multiple intra-abdominal collections. The 2 large collections, one in the perigastric area and the perisplenic area, were drained via CT-guided percutaneous drainage, and the patient was started on broad-spectrum antibiotics in view of fever. However, the patient continued to mount high fever spike despite of drainage of these collections. So the plan was to drain these remaining collections, which were there in the perihepatic and perisplenic areas. So we thought of going through percutaneous approach, but since the collections were deep-seated and they seem inaccessible, clearly, because we have to go through a lot of hepatic parenchyma and maybe through the pleural cavity, just to drain the perisplenic collection. So we dropped the idea of this percutaneous drainage. Second of all, we contact the surgeons for the possible surgical approach to drain these collections. However, since these collections were deep-seated and secondary to bile leak, we were expecting a lot of inflammation, and it would have been associated with more morbidity for the patient. So we finally went ahead with the EOS guided drainage of these collections, since they were more approachable via the gut lumen. We directed our linear echoendoscope toward the perisplenic location. We inserted the needle, and we could sense the smell of the bile with pus. we inserted the guide wire, we dilated the tract, and we finally inserted 2 guide wires. And while dilating the tract, we could see the pus with the bile coming out of the tract. And we ultimately deployed 3 stents in the perisplenic region. Similarly, we went ahead with the perihepatic collection. In the same way, we passed the guide wire, we dilated the tract, and we deployed 2 double pigtail stents into the perihepatic collection as well. So there were a total of 5 stents in these collections, along with the initial CBD stent, which was done at the day of admission. Post procedure, the patient showed, the imaging showed there was almost complete resolution of the collections, and we can see the perisplenic stent in situ, along with the perihepatic stent, which was also in place. However, after the procedure, there was some evidence of pneumomediastinum in this case, which was obviously expected since we used the gastroesophageal junction as the only available window to drain these collections. But the patient improved as the fever spike settled, and he was discharged in the next 3 to 4 days. On subsequent follow-up visit in the OPD, the repeat cross-sectional imaging showed the stents were in situ, and there was no residual collection left. On further follow-up visit, these stents were removed, and the patient is being planned for elective cholecystectomy. So, yes, technically not, but clinically it was a challenging case, as the patient had multiple biomas which were deep-seated and seemed inaccessible, and obviously we had limited drainage options in this case. So it is a classical example of combination of ERCP and endoscopic ultrasound guided treatment in a patient with choledocholidiasis with spontaneous biomas, where the ERCP helped us to decompress the biliary system, and endoscopic ultrasound enabled us to drain these collections. And EUS, of course, comes in handy in this case, as it was safe, effective, and minimally invasive. In this case, when we all were aware that these collections were not amenable to alternate drainage options. Thank you.
How many days after the surgery did you do the ERCP?
Sorry?
When did you do the ERCP? How many days after the bile leak?
Sir,
what was the time of surgery and what time of ERCP?
ERCP we did at the time of presentation only. The patient was referred to us for cholangitis, and the ultrasound had evidence of choledocholidiasis. So at day 1 we did the ERCP.
But this was post cholecystectomy.
No. He is being planned for cholecystectomy now.
So this was spontaneous.
Yes, sir. These are spontaneous leak.
Then why are your surgeons so hesitant in getting the laparoscopic lavage in the first sitting? This is the most simple thing that can be done. Multiple collections in the abdomen. I don't think US or any other multiple drainages like pocket drain is going to help the patient in biliary peritonitis. There will be pus plaques. You have seen the abdomen open sometimes after a bile leak.
So
I think the surgeons has to do this job. This is not your job, probably. That is what my feeling
in
is.
this case,
You did it, it's okay, but I don't think that should be the message that you can treat the patients like this.
So the surgery would have deemed a high risk for the patient.
No. I don't think so.
Since we were expecting a lot of inflammation with taken into bile leak, so EUS comparatively,
you should have thorough lavage and large bore drains. That is the message, right? Your surgeons should be, I think, more aggressive in treating cases like this. You cannot treat these cases like this.
It is Patnaik.
So, good afternoon, everyone. I thank organizers for giving me this opportunity. I'm going to present this case, hybrid ERCP and US guided fistula gastrostomy in disconnected pancreatic duct with pancreatic cutaneous fistula. With 2-year male with a past history of necrotizing acute pancreatitis 6 months back, underwent percutaneous drain placement for peripancreatic fluid collections. Also, why it's running by itself. So, can you? It's a PPT actually. So, I think they're given the wrong file. No.
You can speak with this.
Stop on the video.
I think that would be okay. Don't worry, take it easy.
Thank you, sir.
We have time, we have time.
छोड़ दे आप यहाँ से पॉज कर सकते हैं
How's the Josh?
पीपीटी लोड ही नहीं है कैसे तुमको यहाँ से आप
I hope post lunch people are not sleeping. These are very exciting videos. Very nice cases, well managed.
So पॉज कैसे करें पॉज स्पेस फिर चालू हो जाएगा इससे हाँ चालू हो जाएगा स्पेस से पॉज भी होगा स्टार्ट भी हो जाएगा ठीक है थैंक यू so sorry for the delay. So I'm going to present this case, hybrid US ERCP and US guided fistula gastrostomy in disconnected pancreatic duct with pancreatic cutaneous fistula. This is about 52-year male with a history of necrotizing acute pancreatitis 6 months back, underwent percutaneous drain placement for symptomatic peripancreatic fluid collections. And post-PCD placement, his symptoms improved, but there was persistent drain output of 200 to 300 ml per day since last 5 months, elevated drain amylase level. And there are no other associated symptoms. During hospital admission, there was accidental dislodgement of the percutaneous drain. Also, is a case of coronary artery disease and diabetes mellitus. So here MRCP showed there is a disconnection near the neck of the pancreas, and there is a small fluid collections with a fistulous tract. You can straight fistulous tract you can see extending into the skin, and there is also non-dilated tortuous upstream main pancreatic duct. So this is the coronal and sagittal section of the MRCP. We showed there is a pancreatic fluid collection, and the angle of entry of the upstream pancreatic duct is 90 degrees to the collection history of disconnection. This collection was away from the gastric wall, while the fistulous tract was closer to the stomach. So we planned a pancreatogram and to confirm the diagnosis of disconnections, and if possible, we can breach the leak. So you can see the pancreatogram that is confirm the diagnosis of pancreatic disconnection, and after contrast installation, there is contrast extravasation into the fluid collections, and also contrast enter into the fistulous tract. You can see the fistulous tract, which is quite prominent, and it is close to the gastric wall. So also you can see the long pancreatocutaneous fistulous tract, which is extending to the skin. So we passed the guide wire to the fistulous tract into the skin, and guide wire came out of the skin. So we caught the guide wire externally, and we place a 7 French nasal drain through the guide wire into the fistulous tract with the aim of saline installation and distension of the fistulous tract to make an artificial fluid collection. So after that we took the help of echoendoscope, and so echoendoscope showed and there is viable upstream pancreatic parenchyma with tortuous non-dilated main pancreatic duct. We can also see that distended fistulous tract close to the gastric wall. So here we are instilling water into the tract. You can see the catheter here, and there is ongoing installation. So we punctured the tract with a 19G FNA needle, and we negotiated the gap towards the neck of the pancreas antegradely. So this is the fluoroscopy images, and we punctured the tract with the US FNA needle. Contrast installation confirmed the position of the needle within the fistulous tract, and this is guide wire negotiation through the tract and antegradely. So after that, we dilated the puncture side using a 6 French cystotome, and soon the cystotome enter into the fistulous tract. You can see bubbles inside the fluid collections. So this is a fluoroscopy representation where we dilated the tract using a 6 French cystotome. Followed by that, over the guide wire, we placed a 7 French 5 centimeter DPT stent with the distal end inside the fistula and the proximal end into the stomach. You can see pancreatic juice draining into the stomach. So this is a diagrammatic representation of what we have done it. So this is a fistulous pancreatic ductal disconnection with a fistulous tract. I initially placed a guide wire and it came out through the skin. Then we put external drain. We instill saline and distend the tract. Then under US guidance, we did place a DPT and convert the external fistula into an internal one. So this is a follow-up CT scan. After 2 months, the fistula tract was healed, the stent was patent, and it was draining internally, and patient was doing fine. So US guided pancreatic gastrostomy or fistula gastrostomy is an option for pancreatic ductal disconnection where ERCP is not feasible. So if the drain has dislodged, you can place a drain externally through the IR guided. If the drain is pre-existing, you can clamp the drain. You can occlude the tract with a balloon. And if the collection is adequate and close to the stomach or internal wall, you can directly do US guided puncture and do a fistular gastrostomy. So IR guided rendezvous procedure is an option. Also here, surgery is could have been done, but this was a high risk patient. So hybrid ERCP and US avoided a major surgery in our patients. So whether to place a single stent or double stent, that's a matter of debate. In this patient, we place a single stent. So, and patient did well. Thank you.
Would you have considered upfront US guided
Sir, yeah, you could have considered it, but initially our aim was not to do the procedure. We thought we'll confirm disconnection, whether wire was going across the stricture. But eventually the wire entered into the fistula tract. So that's why we placed the drain distal and distended with a saline and then did the procedure. Obviously, you can do direct puncture and do a US guided procedure.
Next is Dr. Abhinav.
So, good afternoon, everybody. This case is a very interesting case. Basically, testicular lymphoma presenting as obstructive jaundice. Yeah, next slide, please. You have to run the slides. Slides from here? Okay. So this elderly gentleman, 85-year-old, presented with jaundice with intense pruritus. There was no fever or pain abdomen. Duration was 10 days. Bilirubin was 14 with high alkaline phosphatase, and ultrasound revealed a lower CBD obstruction. There was no gallstone. MRCP was done, dilated IHBRD, common hepatic duct CBD dilated 25, but with abrupt cutoff at lower end. Main pancreatic duct was also dilated, and there was asymmetric thickening of a duodenal wall. You can see here duodenal wall is thickened. Their differential diagnosis was lymphoma or adenocarcinoma of duodenum. He was worked up elsewhere. Upper GI endoscopy showed thickened duodenal wall, and there was large periumbilical diverticulum here in second part of duodenum on medial wall, and papilla was not visible. They wanted to palliate jaundice with ERCP, failed, and he was referred to a biliary drainage. Since papilla was not visible, it was buried in thickened fold along with the large diverticulum. This case also illustrates the power of thorough history and physical examination. So when he came to us, he was found to have enlarged testicles, and we did testicular ultrasound. You can see a mass here in his left testicle, and his spermatic cord was also thickened. So something the testicular problem. And then we did CT scan. This CT scan is very interesting, that you can see this tract of tumor ascending along the right gonadal vein, and you can see it is infiltrating second part of duodenum, resulting in dilatation of CBD and pancreatic duct. So differential diagnosis of testicular tumor may be seminoma or choriocarcinoma or lymphoma, which is basically leading to biliary obstruction. So now the question here, the challenge here is to palliate the jaundice. Papilla is not visible, buried in the folds and infiltrated duodenum. So we did EOS guided puncture of. This is a video, please. Yeah. So from first part of duodenum, we punctured this dilated bile duct, passed in guide wire, confirmed with contrast. And when we pass the guide wire down, you can see the guide wire is emerging here in deep down in the diverticulum. We changed our scopes. Yeah. So passed guide wire to duodenum through CBD, and we saw guide wire here in deep in the diverticulum, changed the scope, grabbed the guide wire, and then did the stenting. So after stenting, So after stenting, his bilirubin fell down and testicular biopsy was planned. But since the patient was not keen for 2 sedation, so this was also done within the first, even before even before the follow-up during the first sedation only, he was taken onto OT, frozen biopsy were taken, and it was suggestive of malignant cells. So our urologist planned it, orchidectomy, and on histopathology and ISC, pan lymphocytic markers were positive, so this was testicular lymphoma. And when I digged at the case, the literature, only 2 cases of this kind have been reported, but both of the cases were not with the jaundice. So this is the first case of testicular lymphoma causing duodenal obstruction presenting as a jaundice. So these are the mechanisms how these cases can present with the jaundice, either pancreatic metastasis or hilar lymph node or duodenal infiltration, which is the rarest variety. So thank you.
Nice case.
Thank you, sir.
On EUS, did you locate the site of obstruction?
It was
in the
lower.
CBD.
Yes,
Did
lower.
you take a biopsy from there to confirm that this cancer is the same as testicular cancer?
Sir,
Because
surface.
without that, I will never agree that these two are the same pathology.
Yes,
You
sir.
need 2 biopsies.
Yes, sir.
One
Sir,
from the testis and one from the bile lesion causing bile duct obstruction. So
agreed, sir. Agreed.
I have not seen you showing me a lesion near the bile duct in your EUS image. And just a suggestion.
Yes, yes, sir.
Were there any lymph nodes around? Because
No, there were no
lymphoma-
lymph nodes. There were no lymph nodes. Surface biopsies were taken using side-wing endoscope. They were obviously going to be negative, so they were negative. Yes, sir.
If we had a tissue biopsy from the lymph node or the bile duct obstruction, we could have saved his testes.
Yes, sir. There were no lymph nodes, sir. There were no lymph nodes around the bile duct. Thank you.
Dr. Nikhil Santhalia.
Thank you, Rajesh sir and respected jury member for this opportunity. So I'll be presenting this video of a US guided rendezvous procedure for extraction of a biliary ascaris. So I'll just play the video. A 5-year-old female presented with intermittent right upper abdominal pain, nausea, vomiting, and anorexia for last 15 days. On examination, she had upper abdominal tenderness. Her routine blood parameters revealed anemia, raised alkaline phosphatase, raised aspartate transaminase, and alanine transaminase with normal bilirubin level. Her MRCP showed mildly dilated common bile duct with a long linear filling defect. A 5-year-old female presented with intermittent on examination parameters revealed raised alkaline bilirubin level. ERCP was attempted for this patient. However, while passing the side wing endoscope, we encountered a smooth stricture in proximal second part of duodenum, precluding the passage of the side wing endoscope. Subsequently, a guide wire was passed across the stricture and CRE balloon dilatation till 15 mm was done. After the dilatation, the side wing endoscope could be negotiated across. While attempting CBD cannulation, we encountered lots of scarring and anatomical distortion in D2, thus making it very difficult to localize the papilla. Even after multiple attempts, papilla could not be identified and CBD cannulation failed. Subsequently, we decided to attempt EUS guided rendezvous technique for achieving the biliary access, and linear echoendoscope was used. The intrahepatic biliary radical in left lobe of liver was measuring 3 mm on EUS, and thus it was not suitable for EUS guided puncture. We then evaluated the common bile duct from duodenal bulb. It shows the CBD diameter of 9.5 mm with a longitudinal tubular structure with parallel hyperechoic walls with a central lumen extending throughout the common bile duct and common hepatic duct. The central lumen of the structure was heterogeneous with some areas showing anechoic spaces. This was highly suggestive of ascaris lumbricoides in the bile duct.
After finding a suitable window from D1, 19 gauge EV shot Olympus EUS FNA needle was used to puncture the CBD and gain biliary access. The position of the needle was confirmed by aspirating bile and subsequently doing a cholangiogram. The fluoroscopy image shows EUS needle in proximal CBD and a long linear tubular filling defect extending throughout common bile duct, common hepatic duct, and right and left hepatic duct, suggestive of CBD worm. 0.025 curve visiglide was negotiated across the CBD and then through the papilla into the duodenum. Fluoroscopy image shows wire entering into CBD through EUS needle, which was then manipulated across the papilla into the duodenum. The EUS scope and the needle was subsequently removed, keeping the wire in position. The side-wing endoscope was then introduced by the side of this wire into the duodenum. The wire exiting through the papilla was identified in the second part of duodenum. CBD cannulation was then done using a sphincterotomy along the side of this existing wire. A biliary sphincterotomy and a biliary sphincteroplasty till 10 mm was done. Multiple balloon sweeps was then done and CBD worm was extracted. In view of difficult CBD cannulation and puncture of bile duct from D1, we decided to do biliary stenting. So a 10 French into 10 centimeter specimen showed a 20 centimeter long Ascaris lumbricoides. Though biliary Ascaris is common in tropical countries like India, EUS guided approach is rarely needed to remove them. EUS rendezvous method is one of the most technically complex procedure for biliary drainage and should be reserved.
Oh, sorry. Yeah, thank you.
What was the cause of two obstructions?
So duodenal obstruction, we think it was sequestration due to I think either peptic stricture or local inflammation due to recurrence of ascariasis. But it was looking benign stricture.
Was he on NSH for a long time?
So there was no definite history of NSAIDs in this patient. But the mucosa looks smooth and so it was benign stricture.
Biopsies from that area.
So that was that time we didn't
Could be eosinophilic or something.
We didn't take the biopsy that time. Thank you.
Dr. Saurabh, please.
Very good afternoon, all of you. Thank you, Dr. Puri, for inviting me. And can I use this cursor? Yes.
Removal of internally migrated stent and a collapse.
Can we mute it? I'll present it myself.
Opposing metal 28.
Okay. Yeah, hi, good afternoon. Looks like I'm between all of you and the exit doors. So I'll talk about the first, I'll present one case today. So removal of an internally migrated stent in a collapsed pseudocyst cavity using a lumen opposing metal stent. Since I think the theme is to see how with endoscopy we can salvage our own complications. So this is a 28-year-old male who presented with severe acute pancreatitis, complicated with a 14 by 10 centimeter pancreatic pseudocyst with gross pancreatic ascites. So a CT abdomen revealed, as you see, a pancreatic pseudocyst as well as pancreatic ascites, which was confirmed on tapping. So initially, this patient was taken for a cystogastrostomy, and since it was clear fluid, we decided to place a plastic stent, which using standard maneuvers with FNA needle by coiling 0.035-inch guide wire, and a double pigtail plastic stent was placed. And since the patient had pancreatic ascites, we decided to do ERCP in the same setting. Now, however, as the ERCP was performed, the cystogastrostomy stent got dislodged. And as well as the fact that there was bleeding during the initial balloon dilation and there was blood in the cavity, I decided to instead place a nasocystic drain. And this was placed, and the cystogastrostomy stent got dislodged. I've seen that happen when you do ERCP in these patients immediately after. Post-procedure, patient was fine, no fever. 2 days later, he wanted to go home. So since he was asymptomatic, I said, okay, we'll remove your nasocystic drain and place a double pigtail plastic stent instead. So we took him back, and then here's the nasocystic drain, and we were cannulating next to it. And then the drain was, we dilated, and then the nasocystic drain was removed as the guide wire was in place. And now as we were putting a double pigtail plastic stent, just it flipped inside the cavity. So I decided, well, enough is enough. Let's just put a double pigtail extra stent and then call him back later for removal. On follow-up for ERCP, now we had two problems. This stent, which was, well, one problem, this stent which was internally migrated was there inside the cavity, but the other stent which I had placed for a future access had come out into the gastric lumen. So I did a ERCP, and pancreatogram is fine. The PDSITs is gone. The guy is doing fine. So now we said, okay, let's take you back. And we removed the stent from the gastric lumen. And I'm going to pause it for a moment here. So we removed the stent from the gastric lumen. And now we had no access to the cavity. The cavity is completely collapsed. And there's a plastic stent remaining outside the stomach wall. So options were, let's leave it alone, or send him to a surgeon, but that'll be too trivial to send to a surgeon. So we decided let's consider an endoscopic ultrasound guided approach. So we started with the EUS, and what you can see here is this linear echogenicity is the stent, which is outside the lumen. And as you can see that there is absolutely no cavity and the stent is lying outside. So I decided to go ahead and put a needle in that space, and I distended it with contrast. So that allowed me, it gave me a little more space. And then I said, okay, let's go ahead with a cystotome to recreate sort of a cavity, dilated that with a balloon, and ultimately placed a lumen opposing metal stent in somehow in that cavity, as you'll see. Yeah. So that's the stent being placed. We didn't have much room clearly, and right. So the stent was placed. Sorry, let me just move here 1 second. So, sorry for that. Yeah, I think there's something problem in the AV system. Okay, so I'll just move forward to this space. Right. So now the stent was deployed, and now I took a pediatric upper endoscope and managed to get it across this metal stent. And now we can see the plastic stent in that cavity. And we used a biopsy forceps to pull it out. And this was removed, and then confirmed that there was no leakage and the stent was removed. So in follow-up, patients had no complications. Is doing well 12 months later. Thank you.
Saurav, if the case had come to you again, how will you do differently this time?
I mean, this patient had a clear fluid in the cavity, and that's why I could not put a plastic stent there, and with, of course, limited finances. So I didn't do a metal stent up front.
You placed the plastic stent in the pseudocyst, and then you did an ERCP at that time to get that duct. And I think it does happen with a lot of
stent
us.
dislodged.
So the friction between the scope and the plastic
Yes.
stent will, even with a regular biflange metal stent, the non-lumen opposing ones can also slip out. So one should be extremely careful of doing a second procedure in the same sitting.
Right. Could have maybe have reversed the order with putting ERCP first and then do the cystogastrostomy later. But I think the main problem was the migration of the stent, I think. Well, the other thing I could have done differently is, of course, be more careful as I'm deploying the plastic stent and have a angle away and make sure the pigtail is nicely coiled, which is what we do normally. I think in this case, somehow it just.
Other thing was, could you have avoided a lamps at a later date, which you
Mhm.
did? And just balloon dilatation, you could have seen the plastic and probably saved some more cost there.
Oh, true. I could have done a larger balloon dilation with a maybe, I guess, a 15 mm balloon. There's no space.
That's
so
another
I think
option. You have the
that's
wire
gonna be-
inside, you can go to 10, come back with a pediatric scope beside.
Pediatric scope
If it
through
doesn't
that.
come out, you can dilate a little more and then maybe
True.
titrate your balloon according to the need. I
Yeah,
think
yes, I've
in
done
India,
that.
The cost is always a constraint, and certainly if you put a lamps, then the whole thing
Goes up.
Goes skewed.
True.
This
Yes.
was chronic pancreatitis or acute?
So this patient had acute pancreatitis with collections. Yeah. Not chronic.
Okay, thank you.
Thank you. Okay, thank you.
Thank you all the presenters. So now our esteemed jury, please be kindly be seated. Esteemed jury will decide now who will be the winners. The winners who left early because of early flight will be sending their awards doorstep. So we'll take 2 to 3 minutes for the jury to decide. So as instructed and by Dr. Puri, so I'm doing the last part, that is word of thanks. Vote of thanks. So I would like to congratulate the organizer, Dr. Rajesh Puri and his magnificent team, including Dr. Zubin and Dr. Bimal, for successfully conducting a wonderful, beautiful and marvelous conference. Then I would like to convey my sincerest gratitude to our esteemed international faculties for enlightening us with their radiant knowledge and flawless expertise in the domain of new technology and procedures. Also, I am truly indebted to the great national faculties for sharing their wisdom and experience with us. It would have not been great conference, have not been possible to have a beautiful conference without the wonderful delegates who are very active and eager to acquire proficiency over the various types of procedures and be of a great service to the mankind in near future. Grateful to the pharma and endoscopic technology industries who are constantly lending us a helping hand, and we are being a constant source of pillar of support, with special mention of Sun Pharma and Torrent Pharmaceutical for their unrestricted support. All of these great procedures would not have been possible without the help of Medanta Hospital administration, management, and the beautiful and very efficient endoscopy staff and team of Medanta, who are always assisting at every point of time, and which led to the successful completion of many beautiful and most advanced procedures. I am thankful to Mr. Ravi Grover and team audio visual for beautiful transmission. Last but not the least, I would like to thank the Leela Hotel for providing us with the necessary help, beautiful hospitality, and aiding us by making the conference a grand event worth remembering for everyone. Finally, my sincere gratitude to everybody. I might have forgotten few names, many names, who have directly and indirectly supported us, who blessed us to make happen and complete the conference beautifully. So we have little time for the jury to decide. So can I dare to invite Dr. Rajesh Puri on the stage for 2 minutes? Rajesh Puri, please.
I will take 1 minute. I think Dr. Manoj Sahu has conveyed everything. And thanks to everyone who is a part of this conference. But to my heart, I think without them, this is not possible. I think Zubin and the Bimal, I am not sure Bimal is here or not. So these are the two people who are, I think without them is not possible. Second, I would like to thank Ravi Grover team, because they never ask for the finances. If I say 2 lakhs rupees I have, they said we will not charge it. So Ravi Grover has tremendously helped me. Number third, Manoj Sahu. I think without that, it is very difficult to get the finances. Fourth, to all international faculty, but Professor Kenneth Bin Muller. I don't know he likes or not, but he travels in an economy class from the US to attend this meeting. So I think that is a tremendous thing what he has done it. And to all, everyone, I would like to thank, and I request jury to declare the result and give, please.
Vinay, this hard to declare the result.
We had some wonderful, wonderful videos. I'm very happy with the kind of aggressive interventions that we are doing here, especially the younger generation. So the first prize is actually split. There are two joint first prize winners, Jayanta Samanta and Itish Patna. And Itish and Jayanta. Jayanta is here.
Sir, Jayanta just left because of so and we'll be sending the prize to Jayanta. Please come to the please. Sir, kindly hand over the prize. Congratulations, Dr. Yatish. Sridhar, please.
I think all videos were, each one was better than the other one.
So basically what the jury is telling, everybody is the winner, but we need to decide 3 names. So all are winner. So the last word from Dr. Rajesh Puri, please.
So I think all the best and best of journey. And we will definitely meet soon in the EPL as well as the next year Endocon. But don't forget to attend Endocon 2023. Dr. Ajay Jain is especially requested. So please do attend Endocon 2023. Thank you.
I'm sorry, now it's possible to be a better show, but for the next I think